Meeting is live now. Please start the meeting.
Good evening, everyone. Welcome to the 9th edition of Kerala Society of Ophthalmic Surgeons CME series. So we started this program with the idea to have one CME on a particular topic, and we have been doing it in association with one district each. So one CME program with one district started with Kozhikode Ophthalmic Society, and all the district ophthalmic clubs have been doing excellent work, and so the result is to be seen in the number of viewerships that have increased over each CME episode. When I thought the one that was done by Cochin Ophthalmic Club, the 7th edition, had a great viewership of 3,500 plus, but the 8th edition has already crossed 4,000, and now this CME on Phaco Masterclass is being organized by the energetic group of Kollam Ophthalmic Association. So they've done an excellent job. The office bearers, the conveners, everyone have done their job perfectly, and I'm sure that this is going to cross 5,000 views. See, I mean, I just attended. Me, Arup sir, Gopal, and all were there for the TNA conference. Whoever we meet, they're just coming forward and telling, you're running an excellent program, and we're very happy to hear that. And we're going to keep up the good work. And my thanks should first go to the office bearers of Kollam Ophthalmic Association and the chairpersons of the 4 sessions, Jayaprasad sir, Harshul, Dr. Sathya Sinha, and Dr. Anaga Herut. So we can straight away get into the inauguration program. Dr. Mini, can you?
Thank you, sir.
Okay,
Good evening, everybody. Welcome to the Kerala Society of Ophthalmic Surgeons CME Module 9, organized by the Kollam Ophthalmic Association under the aegis of KSOS. This 9th module, the Phaco Masterclass, is a comprehensive package that encompasses everything that you need to know about Phaco, from the Phaco basics, the IOL design, Phaco in difficult situations, and managing Phaco complications. We have an eminent panel of speakers today from across the country to enlighten us on these topics. A warm welcome to all of you. Now we move on to the inaugural section. First of all, let me invite Dr. Arup Chakravarti, President, Kerala Society of Ophthalmic Surgeons, to inaugurate the CME.
Good afternoon, friends. Thank you, Kollam Ophthalmic Club, so well led by Dr. Mini Jayachandran and Dr. Divya and their team, for inviting me to inaugurate this program as president of KSOS. So I represent the entire 2,000 odd members that we have, and I'm really honored to do this inauguration program. Kollam Ophthalmic Club is a small club, but then any activity that they have been entrusted with, and they have come out in brilliant output. For example, we had our state annual meeting a couple of years back, one of the most memorable conferences that we have attended. And there all the CMEs they conduct, everything is put up online, and it is archived in the YouTube channels. And regarding Dr. Mini, of course, in addition to coordinating all these events so efficiently, she is a great cultural representative, very, very active in the cultural front of KSOS. Thank you, Dr. Mini, for all the services that you have been doing. Conducting or coordinating a meeting like this is not an easy job. Srini along with Kollam Ophthalmic Association, have really prepared a world-class masterclass, and it covering all the relevant aspects of cataract surgery in a span of 4 hours with some of the brilliant speakers. We are sure going to have a great time the next couple of hours, whoever is watching this session. So Srini, thank you and congratulations for pulling it off. This is the 9th program, and all these programs are archived in our website, and it can be viewed at any time, whenever at your convenience, at any time you can view all the programs that have been held in the past. I won't say much about the scientific program because I think all the speakers and the topics will be introduced. But I would just like to say that the KSOS has been very active over the last couple of months. And now we are really geared up for our annual Drishti conference happening in Kozhikode in the last weekend of November. Instruction courses have results have already been declared. And we are going to, Srini is going to put out the free paper submission status, etc., in a couple of days' time. Registration is also happening at the website. And I'm sure after a lapse of almost 2 years, it is going to be a great meeting. We just returned from TNA where the attendance was an all-time high. It was a record. I'm pretty much sure that in Kozhikode also going to have a great turnaround of delegates. And I agree with Srini. Our efforts have been recognized. They have been acknowledged and they have been recognized and they've been admired. About what Srini and Gopal have been doing over the last couple of months in terms of all these, PG programs, journal clubs, and CME series. So keep it up, guys. You're doing a great job. Good work is happening on the other fronts also. The editor journal is doing a great job. Biju, of course, is a very dependable treasurer for any organization. So with these words, I would like to declare this thing open, this webinar open, and I wish all of you, all the viewers here, to have a great time and learn a lot from these from the deliberations in this webinar. Thank you so much.
Thank you, sir. Thank you for the kind words. Now let me invite Dr. Mini Jayachandran, President of the Kollam Ophthalmic Association, for the presidential address.
Good evening, all. Warm welcome to the CME on Phacoemulsification, organized by Kollam Ophthalmic Association under the aegis of KSOS. Welcome to KSOS President Dr. Arup Chakravarti, who is a very dynamic president with innovative ideas, and he is the backbone of KSOS. Thank you, sir, for willing to inaugurate the CME in spite of your busy schedule. Next, I welcome KSOS Secretary Dr. Gopala Raju, who is a very young, energetic, and enthusiastic secretary of KSOS. He has been guiding us throughout. And thank you, Dr. Gopal. Welcome Scientific Committee Chairman Dr. Srini Adaklon, who is another vibrant person who has put in a lot of effort to arrange speakers and panelists of the CME, without whose help this would not have been possible. Thank you, sir, for being and helping us whenever in need. Next, I would like to welcome our Scientific Committee member, Dr. Thomas George, who has helped us a lot. Thank you, sir. We welcome all chairpersons, speakers, and panelists for agreeing to be part of the CME in spite of their busy schedule. Finally, I thank Kollam Ophthalmic Association Secretary, Dr. Shaini, Treasurer, Dr. Vishnu Mohan, and Dr. Jayaprasad and Dr. Rajiv Sugumaran, and all other executive committee members for their help and effort in conducting the CME. Thank you all.
Thank you, madam. Now, may I invite Dr. Gopal Pillai, Secretary, KSOS, for felicitation.
Thank you very much. It is indeed a pleasure to be amongst all of you and having this 9th masterclass on Phacoemulsification, a combined effort by the Kerala Society, a Scientific Committee, and the Kollam Ophthalmic Association. So it has been indeed a real pleasurable journey under the very able leadership of Dr. Arup, who would, like a father figure, tell us, do this, do that, don't do this, don't do that, don't jump into this, don't jump. So that has been the benefit that we have had. And of course, the great team that I have with Srini and all the scientific committee members. So no wonder we have been able to pull along the intensity of the academic program throughout the year and probably the next year too. So so I thank all my the committee, so that the the whole program can go through. This particular program is like 4 hours intense. Everything A to Z in phacoemulsification will be discussed in this 4 hours, right from the basics, from the machines to the ergonomics to the IOL designs to the difficult situations phaco to managing complications. So this will be a 4-hour, one-stop, know all for a practicing ophthalmologist, and it'll be a great treasure for any of the postgraduate or fellow who is watching it. We have, Srini has actually personally contacted and amassed all the best of the best speakers from all across India. And I'm sure that somebody who misses this program will definitely miss this really badly. I am not continuing further. Thank you very much. All the best for this program. Thank you all very much.
Thank you, sir. Now, may I invite Dr. Thomas George, Member, Scientific Committee of KSOS, for felicitation.
Good evening. At the outset, I'm glad that Dr. Arup, our president, is here, the secretary of KSOS is here, and of course, a flamboyant Srini, who is the scientific committee chair, who is the brain behind this whole series. All the scientific committees, CMEs that we have conducted on behalf of the district clubs have gone off very well, and this topic-wise being Phaco should do much, much better. And he has got a faculty that is too good, actually. It has to do well. And from the KOA side, we have had very good support and cooperation. And I would like to thank the President Mini, Secretary Shaini, and Treasurer Vishnu, as well as the 2 backbones of KOA, Jayaprasad sir and Rajiv as well. I wish the CME all the best. Actually, it will do well without even me wishing it. I wish them all the best. And I look forward to 4 hours of, like Gopal said, one-stop Phaco learning. Thank you.
Thank you, sir. On behalf of all the members of the Kollam Ophthalmic Association, I would like to thank Dr. Arup Chakravarti, a dynamic KSOS president, who in spite of his busy schedule, joined us today for inaugurating the CME. Thank you, sir. Let me also thank Dr. Mini Jayachandran, president of the Kollam Ophthalmic Association, for all the pains taken for organizing the CME efficiently. Thank you, madam. And special word of thanks to Dr. Srini, the brain behind the CME, who has arranged all the speakers and the sessions and was ever ready to help us and clear all our doubts with so much patience. Thank you, sir. I would also like to thank Dr. Gopal Pillai, Secretary KSOS, for all its contributions to the context of the CME. Thanks to Dr. Thomas George, sir, for all your help in organizing the CME. I would also like to thank all the chairpersons, speakers, and panelists who are here with us today to share their expertise with us. Thank you all for joining. Thanks to all the Kollam Ophthalmic Association members who tirelessly worked behind the scenes for organizing the CME. Last but not the least, thank you, dear audience, for joining us on this Sunday evening to sharpen your Phaco skills. Thank you all once again. Now, let us move on to the first session of the CME on Phaco basics. The moderator for this session is Dr. Rakhi. Dr. Rakhi is a consultant Phaco surgeon at the Ahilya Eye Foundation. She did her DOMS from Government Medical College, Kottayam, secondary DNB from LV Prasad Eye Institute, and Phaco training from the same institute. Her areas of interest are cataract and glaucoma, and she has presented many papers and posters at national and international conferences. She is also an active member of EOC India. Over to you, Dr. Rakhi.
Good evening to all ladies and gentlemen joining us today. Warm greetings and regards from the land of coconut and greenery. So I hope I'm audible and visible. Can I share my screen?
Yep.
Yes, yes.
So it's my proud privilege to introduce to you the speakers and panelists for today's session on Phaco basics. As said, only way you can stay on the top is to remember to touch the bottom and to get your basics right first. So, joining us today on Phaco Basics are our esteemed array of panelists who will be talking to us on the basics of knowing our machine, ergonomics, nucleus management, and cortex wash. So, first of all, on behalf of KSOS and KOA, we're actually very grateful to have you here and for your presence and time for this session. Our chairperson for this session is none other than Dr. Anaga Herod. She is currently the medical director at Anil Eye Hospital, Mumbai. She has done her post-graduations from Mumbai and has numerous national and international presentations in various platforms. She has also won various awards, including the Best Surgical Skill Award at the Women Ophthalmic Society Conference in 2018. She was also awarded the Best Doctor Award in 2012. She was also awarded with the IIRSI Gold Medal from the hands of the Vice President of India in 2018. Other than her academic achievements, she is a beauty with multiple talents winged out. She is a great classical dancer. She is also trained in classical music, and she also has specific interest in poetry writing and fitness. Our first speaker for this session is none other than Dr. V Gopala Raju. He'll be speaking to us on the topic of Know Your Machine. He has done his post-graduation from RP Center AIMS and fellowship in cornea and anterior segment from Aravind Eye Hospital, Madurai. He is also trained in refractory surgery under Professor Simons, Madrid, Spain. He is a founder member along with Dr. P. Vasudeva Vishaga Eye Hospital, Vishakhapatnam. He is currently the director and consultant in cornea and anterior segments at Vishaga Eye Hospital from 1993 to till date. He is the current chairman of Scientific Committee, Andhra Pradesh Ophthalmic Society from 2015 to till date. He has presented several papers, posters, and participated in various symposia in state and national conferences. He has won the Young Entrepreneur Award from Vizag Rotary Club in 1999. And also he has been awarded with the prestigious Dr. Malleshwar Rao Oration Award and Ugadi Puraskar Award. He's a pioneer surgeon. We are very happy to have you here. Welcome, sir. Next, we have this calming beauty, Dr. Sathya T. Ravilla, who will be speaking to us on ergonomics. She has done her post-graduation from Aravind Eye Hospital, and during her post-graduation, she has won the gold medal for securing the first rank in the institute. Later, she did her fellowship in pediatric ophthalmology and strabismus. Currently, she is heading the Department of Pediatric Ophthalmology and Strabismus as SV Aravind Eye Hospital, Tirupati. She has numerous publications, book chapters, research papers, and presentations to her credit. She's actively involved in training of mid-level ophthalmic personnels. Her specific areas of interest include patient education and innovation. At the other side of her, she is a great innovator as well as a painter. She has innovated the X-Boss, which is a collapsible aerosol box, which was greatly useful during the COVID era for the safe administration of general anesthesia. Another of her innovation is the squintometer, which is a prism holder, especially useful when there is a large angle prism and when they need to be stacked. She has won numerous awards for her innovations in national and international platforms, including ASCRS Film Festival Award in 2022 for her film on ergonomics in all. Other than this, she's a great artist. This picture, which is portrayed here, was actually drawn by her for a chapter on binocular vision. Next, we have another stalwart surgeon, Dr. Deepak, Meghur, who will be talking to us on the topic of nucleus management. He is currently the head of cataract and glaucoma department at Meghur Eye Care, Karnataka. He specializes in complex cataract surgeries. He also has won various awards and recognitions and has more than 200 presentations at national and international scientific meetings. He is currently the reviewer for Indian Journal of Ophthalmology. Dr. Deepak Meghur is especially famous among the young surgeons for his YouTube channel, in which he is sharing great tips, especially for the beginner surgeons. Thank you, sir, and welcome. Our next speaker is Dr. Suresh Mehta, who will be talking to us on cortex wash. He is an anterior segment surgeon from Mumbai. He specializes in FLACS, SMILE, deep sclerotomy, and other newer age surgeries. He is the editor journal of IIRSI and Indian editor of Eurotimes. He has over 28 book chapters to his credit and over 300 presentations internationally. And he has a wonderful other side also, where he is a great bodybuilder, a musician, and is trained in superbike racing too. Welcome you, sir. We also have an array of great panelists. First one is none other than our own Dr. Alex Baby. He has done his DO from KMC Manipal, DNB from Little Flower Angamali. He's also a trained cataract, glaucoma, and refractive surgeon. He's a former consultant and cataract surgery trainer who was in charge in LF Hospital Angamali. Now, currently, he's the managing director at Alfonso Eye Hospital, Spala and Todpura. Our next panelist is Dr. Thomas George. He did his PG training from CMC Vellore. After that, he was working as a tutor there in CMC Vellore itself. In October 2000, he joined Kerala Government Services. Later, he joined Chaitanya Eye Hospital, Trivandrum, and currently he's the head in consultant in glaucoma and cataract services. He has occupied various esteemed positions for KSOS and in 2012-2013, and he was a joint secretary during the time. He is also the current member of Scientific Committee of KSOS. Next, we have Dr. Matthew Kurian. He has done his MBBS from CMC Vellore, MS and DNB from St. John's Medical College, Bangalore. He has won the prestigious Ratan Tata Cataract Fellowship and completed it from Shankar Nethralaya, Chennai. He also has advanced management program done from IIM Mumbai. He was the ex-medical superintendent of head and cataract services from Narayana Nethralaya, Bangalore, and currently he is a medical superintendent and head at cataract services at Chaitanya Eye Hospital, Palarivattam, Kochi. And lastly, we have our own Dr. Srini Edekolan. He actually needs no introduction because he's a smiling friend to all fraternity pan-India. Yet, he has done his MD from RP Center AIMS, fellowship in anterior segment from Shankar Eye Hospital, Coimbatore. He is a chief surgeon and medical director and chief at cataract and glaucoma services, both at Comtrust Hospital, Talasheri, and Mamtrust Hospital, Kanyanad. In these hospitals, he does around 750 to 850 Phacoemulsifications every month. He is our current chairman of scientific committee, and he has already served various prestigious positions of KSOS and KGO earlier. I'll fail my duty if I don't mention his relentless hard work in organizing the CME and also backing us and guiding us during each and every step of this journey. Thank you, sir. So we welcome and thanks for being a part of this webinar. Now, over to you, Anaga ma'am, for chairing the session.
Thank you so much, Dr. Raki, for the lovely introduction. And thank you to Dr. Arup Chakravarti sir, Dr. Gopal Pillai, and Dr. Srini for arranging and introducing such a beautiful topic, which is the need of the hour today. So phacoemulsification is the bread and butter for all of us, whether they are in any part of the country. And today, whether they are beginners or already established phaco surgeons, all of us are part of learning. Learning never stops. So thank you so much for a beautiful topic. So let's start with the first topic, and I would like to call upon our first speaker, Dr. Gopala Raju sir. Is he has he logged in?
He might. He was in TNO yesterday. He said he might be traveling. I think we'll start with the next speaker. And
Okay. Dr. Sathya ma'am is already.
Sathya is here.
Yes, I'm connected. Thank you. Thank you once again. Thank you, KSOS, for this opportunity to be amongst so many stalwarts here. Is my screen visible now?
Yeah, it's coming.
Yes, ma'am.
Yeah.
Thank you for this. I mean, this recently seems to be catching everyone's eye, and I was surprised that it was also on part of basics in Phaco to have a thing on ergonomics, and definitely needs importance. To begin with, why are we even talking about ergonomics to enhance performance? This whole topic is about basics in Phaco and enhancing performance. And the reason is that when you look at it for any output performance, be it whatever, be it surgical or be it anything, it depends a lot on the person's well-being. And this depends on the work posture and the work activities also. This is influenced by equipment and environment. So that is why we are talking about ergonomics when we want to even enhance surgical performance. So there's a lot about talk about, what is the correct posture when you're sitting at the computer. And then I'm sure some of you are straightening up even when you see this slide. There's a lot of thing about when you're texting, they say even text neck. So they say when you are bent and slouched down, that a lot of the weight falls on your upper back and your neck. Whereas when you're sitting straight, the weight is distributed across your back. So there's so much importance given to the neck posture while texting. And there's even so much of talk about what is the right position to sit when you're in the toilet. What is the correct posture where it is good for the intestines also. But what about while operating? No, this is where surgeons spend most of their time. And there is really nothing about what is the right and what is the way that we should be sitting in an operating room. In fact, I'm sure most of you would agree at the end of a long operating day, you will be much more tired and stressed than you would when you have a outpatient day. And when you look at articles that have been talking about ergonomics in the operating room, most of them stress about how it's very important that you keep adjusting the patient's bed, the surgeon's stool, and tilt microscope accordingly, use foot pedals adequately. But they also tell about maintaining ergonomic focus. What this means is knowing that you're in the right posture. But how is that possible if you don't even know what is the right posture? So that kind of prompted us to do this study in our hospital. So we had a little questionnaire where we asked surgeons what was their pain scale. And then we asked them, like, do you know what is the ideal angle? And then we kind of tried to take photos of them and then ask them what are their assumptions of their own angle. Do you know how you are sitting? And then we would take photos of the surgeon in the operating room. We use this camera grid, and you can also see this reference marking across at the wall. So what this allowed us to do was to get an adequate calibration of how we were, and we would put a sticker at the C7 marking. So right before they scrub, we would put a small sticker, a yellow fluorescent sticker at C7, so we could do any anatomical landmark based on that. And then we had an orthopedician, a single orthopedician would analyze this. So we kind of took multiple intervals, we kept repeating this different photos, and then he would measure different angles. So when we try to do this, we try to first say what is the ideal angles, and we looked at different various parts. So we decided on 4. So we looked at the cervical angle, which is an angle measured between a line through C7 and tragus and a horizontal line through C7. So what is ideal here is 48 to 50 degrees, which means this is the ideal amount of flexion that is recommended. Anything below 40 degrees is usually associated with neck and upper back pain. The next angle that we looked at was the head tilt angle, which corresponds to the flexion of the head. And this is kind of like the chin elevation, chin depression that we would measure in strabismus. So we would we measured the angle between the tragus and the outer canthus and a horizontal line through tragus. So this horizontal line is like a station 0. So ideal is +7 to +15 is what is comfortable for a person. Moving on to the trunk angle, it is a line formed between C7 and trochanter and a straight vertical line. But the problem is in our sterile OR dress, it's very difficult to know what the greater trochanter is. So we took rough photos and the surgeon made a rough assessment on how the person was sitting. And anything within 10 degrees of the neutral angle is what is considered as ideal. Coming to the foot positions, it's quite a thing that how we are very unaware of how we are keeping our feet during the surgery. So it's recommended both feet being flat on the ground, or if you're using foot pedals, both being as flat as possible. And also that the neck flexion should be 90 degree or greater. We should not be flexed too much. So when we did this study, we kind of, instead of asking them what degree did you keep your neck in, it was very difficult. So we gave them these 5 options and then asked them how aware are they of their posture. So that's what we were doing when we did this study. And we found amongst the 18 surgeons that we studied who had an experience of 3 to 20 years of operating, 17 of them complained of some form of pain after a surgery day. 1 exercised regularly, 4 walked regularly, but nobody was doing it on a daily basis. And when coming to awareness, only 2 were aware of their neck posture. As in, they thought they were sitting in a certain posture, but they were just sitting in a different one. 5 only were aware of how they placed their legs. And about 65% were right about their trunk angle. So you could see that nobody was aware of how they were actually sitting. When we looked at it, 64% complained of moderate to severe neck pain. And none of them were sitting in what was the recommended cervical angle. And only 1 knew what the ideal cervical angle was. So at the end of the study, each person, we would give back like an evaluation report saying, this is how you are sitting, this is how you are. I think it's basically creating an awareness. I mean, there's no way when operating to know what is the exact thing, but just creating this awareness really helped. So we recommend that when sitting in the OR, apart from the patient's bed, always adjust the surgeon's stool. So if you have a thing on your foot pedal, you can do it yourself. Otherwise, you would request the unsterile assistant.
I didn't want to come there and sit there, she'll start misbehaving and all. And then your trip will get wasted.
So we also adjust the microscope tilt. So this allows us also to maintain the right neck posture. You can see in this, it looks like she's sitting straight, but actually her neck is slightly extended a bit. And this extension posture also can cause very discomfort quite quickly, more than an overflexion. The neck discomfort, even when you are in that posture, you will experience a discomfort. You can see how bringing the microscope down and adjusting the eyepiece, she is now able to keep her neck at a more comfortable angle. So this was a very interesting paper where what they did was they looked at how experienced surgeons were holding instruments when they did an SICS. So what they did is, if you are aware of how experienced surgeons hold it and then you learn it that way, it would kind of reduce the learning curve of SICS. So to give you some tips on how you would hold instruments in Phaco. So one of the thing is place both of your lower fingers to on the cheek of the patient to give you some support. So just a slight thing there, and then you can use the other 3 fingers to hold the instrument and go towards the center. While making a side port entry, we would stabilize the globe, giving counter pressure from the other side. And here again, you can see how 2 of the fingers are placed over the forehead. So if the surgeon has longer fingers, it's suggested to curve these 2 fingers, but these 2 fingers are the ones that are going to be stable, and the other 3 is what is going to allow you the movement. Moving on to the holding the second instrument, be it a Sinski or a chopper. As beginners, we tend to hold it quite lower down. So what happens is restricts movements. See, by just moving your hold above, you can see how much more range of movements you are able to do with your instrument, and much more easier. While holding the Phaco handpiece, it's recommended that you hold it like a pen, and again hold it a bit further up. Again, allows you better range of movements to move the eyeball. To move the handpiece both forward, backward, and to rotate it as and when we want to catch any nuclear bit. So this is another video taken from a different angle, and here you can see these 2 fingers are the ones that are stabilizing. These 3 fingers are the ones that move it. Similarly, here you can see these 2 fingers are curled here, and what you notice is the first 2 fingers are what allow for rotation of the second instrument. Whereas the third finger, when you want more stability, when you don't want it to move too much, placing the third finger a little lower down gives for that stability. So to end it, we keep talking about what is ideal. So the minute you go into the ward, it's very important that you adjust yourself and be a little bit conscious of how you are sitting. Having said all of this, on a recent conversation with the physiotherapist, what I learned is that more than ideal angle, movement is important. Movement is medicine. So static posture, no matter if it's good or bad, is not ideal, because movement is critical to our health. So as humans, our body has been designed so that we should be flexible in various ways. So being static is not good. So when we did this evaluation report, behind that we gave them various neck exercises and lower back exercises, because that was the most common. We've put up a poster in our doctor's changing room on reminding them to do activity. And this is a poster that we have put up in the OR. So it kind of like, even if you're not doing it regularly, when you look at the poster in the OR, it reminds you to just at least flex your necks and rotate your neck a bit. To end, take care of your body. It's the only place you have to live. Thank you.
That was a lovely talk, Dr. Sathya. Very, very enlightening. And I must agree, all of us at some point in our career must have faced all these problems. One question I wanted to ask you, you mentioned about ergonomics in the operation room, but what about the slit lamp that we also see more often? Many times I've seen ophthalmologists, when they are on the slit lamp, the same problem as with the operating microscope, either the chin is up or down, and especially the height of the stool is not the perfect one. And sometimes when you lower it too much, then you tend to hyperextend your neck. So I think an equal amount we also spend in the OPD, and about retinal surgeons when we are doing indirect ophthalmoscopy. So what is your recommendation for these OPD procedures?
I mean, I'm glad you brought that up. So as a phase 2 to this, I'm trying to do in the OR. So we have kind of got this still in the research, this little device that you can see here. So what this does is you attach it onto your back, and then you can fit it, so you calibrate it. So when you start it, you can sit up and say, this is what is my ideal posture. And then you can also set it that when you move away from that angle, you can set the range also. So if I move 20 degrees away from that angle, and you can set the time, you can say after 20 seconds or 30 seconds, then it gives you a small vibration. So it reminds you to come back to this posture. So this also analyzes how many times you go back and forth. So I've been in touch with this innovator. So that is something that I'm working on. Right now, the ideal thing is what you are most comfortable with, the same trunk angle and the same neck angle. So the same things would apply here. But in the OR, you have the flexibility of moving. And again, as cataract surgeons, one of the advantages is that our surgeries are not very long. So we are getting actually frequent breaks of stretching ourselves. So the VR surgeons and those that do longer surgeries are the ones that need to be more careful that they're in the right posture while they're operating.
Yeah, and definitely, I think we should all have a proper routine of not only cardio, but also for weight training, as well as to increase the muscle strength, increase the stamina, because for beginners, it is still okay when they have started practice. But over the years, I think we may all develop problems which we need to face. Anybody else wants to make it?
Yeah, Dr. Cyrus, the bodybuilder. Recently,
no, I just came on just now and I heard some words, cardio, weight training, and all.
Yeah.
Yeah.
Even I do it routinely, but I just wanted
to... I'll tell you, Srini, the thing is that if you do 30, 40 surgeries, I'll get problems. I do 2, 3 surgeries, so I don't get any problems.
No. See, that is where what I wanted to ask Dr. Sathya also. The time that you take for the surgery, you finish off the surgery in 5, 6, 7 minutes. See, the posture. See, is there a time limit where you're? I know that it should be an ideal posture. Even if it is not an ideal posture, if it doesn't last for long, does it really matter? Because as you said, you get up, then you stretch and all. No, I'm just asking for myself. I know that my posture is not good.
Yeah, but if you're only going to be in that position for 5 or 7 minutes and you have only 3, 4 surgeries, then nothing will ever go wrong. But I heard that you do 30, 40 surgeries at a stretch. So then, yeah, of course, if you're stuck in one position for 3, 4 hours, you do get a bad back and a stiff neck and all. The retina surgeons and all must be getting. Luckily, I don't do any retina, so I'm kind of immune to all these problems.
No, Dr. Cyrus, there was a question. There was a question. The friends we were discussing during our TNOA, you do your muscle isometric exercises, whatever forearm exercises on the OT day before the surgery. Does it induce any tremors? That's
no, not at all.
Yeah.
No, not at all. You can work out for 4 hours and then you can go to the OT. It makes absolutely no difference. Doesn't induce any tremors whatsoever. At least I never got any. See, luckily I did all this exercising and all during COVID, so there wasn't any work anyway. But even though work has come back, I do train in the morning sometimes, and I don't think it really induces any tremors or anything.
Yeah, even for me, that it's okay. But some people say they get it. Dr. Deepak, you also would be having a lot to say on ergonomics, right?
Yeah, anyway, but I must confess that my posture is not so great, and I do have cervical pain and back pain, but it was enlightening to listen to her talk. And I think it's just a very important message and top, if you learn all these things in the beginning of your career, it's really going to help us a lot compared to learning them, 15, 20 years later. So this is absolutely, it's a need of the hour, and it's important that we bring all this information into the front. Thank you for the wonderful talk.
Matthew wants to say something.
Yeah, I think when the going is good and there is no complications, everything is under control, we tend to have enough bandwidth extra to think about, is my neck correct, is my shoulder correct, etc. Intraoperative complication, operating on a VIP, a subluxated lens, which is a challenging case. That is when we forget all these good habits, and then you will be like all muscles tight. And after 5 minutes of that, you will realize that there is a problem. If you are senior enough, experienced enough, and have adequate bandwidth to think about these other things at that time, you are able to step back, take a breath, and then come back to a better posture, neck, shoulders relaxed. Maybe just rotate your shoulders, trapezius, etc. becomes a little relaxed, and then you can proceed with the surgery much better. But if you ignore it at that stage, your muscle spasm, especially back of the neck and trapezius, spasm will be there, and it will retain through the rest of the day, even when you're doing uncomplicated cases. So learning to take a deep breath, rest your muscles when you are having an intraoperative complication, I think is a valid point.
Dr. Thomas George is a
Srini,
Dr. Anaga.
Srini, another important point is, in my team, some of the surgeons were short, some of the surgeons were tall. So when we were sharing the same table and then the microscope, so definitely we need to do a lot of readjustment. One of my team members, she uses some table to keep the foot pedal. Sometimes she uses a different chair and then readjusts the optics or the microscope. So if you have doesn't have a tilted objectives, then they will have a lot of problem. Really, some of them end up doing surgery in a standing posture. These kind of things happen in my team. So that's why definitely I think our talk is excellent. And then many of these things definitely we need to apply on a day-to-day basis. That is my experience.
Dr. Anaga,
Yes,
Dr. Thomas George is the resident ergonomics expert of Kerala.
You're coming, sir, Dr. Thomas.
All of what Dr. Sathya told us is valid, and that we should be aware of. Most important is we should be aware of it. And holding a same posture right through is also a problem. So while I operate, I get this even intraoperatively. There is a time when the sister is taking the lens or something when you are not actively operating. That time I move away from microscope, stretch a little bit, 1 inch down, up, and sway a little bit, shrug my shoulder, whatever. But whichever is tending to go into a spasm, I make sure that joint is moved. In that 1 second, the first thing is being aware that this can be a problem. And going on to what Raju sir said, if you got a microscope with a fixed eyepiece, prefer to buy one which is 90 degree rather than 45 degree. 45 degree, make sure that you have got a head tilted forward all the time. And that's not good. Better would be a 90 degree eyepiece rather than a 45 degree.
But excellent inputs from everyone. But I feel whenever you're investing in a microscope, best to invest in a tiltable binocular, because over the number of years, definitely that's going to stand you in good stead. And most importantly, take care of your fitness. I think right from the beginning, I think each one of us should take out time from our busy schedule for that. And Dr. Srini, you were mentioning about the tremors. Like I've been doing weight training also every morning for the last so many years, but I've not found any problem with the tremors. And I think even the protein content in our diet is just one more additional input, especially vegetarians. Sometimes the protein content tends to fall short. So maybe that is also one thing which we need to add. So thank you so much, everyone. Shall we move on to the next talk? Dr. Gopala Raju is here.
Yeah, I'm ready.
For your keynote address.
Can you see my slides?
Yes, sir.
Yes, sir.
Are they moving?
Yes, sir. Yes, sir.
Are they moving?
Yes, sir.
Okay. Okay, good afternoon, all of you. Sorry for the delay. So today, mainly the topic is the Phaco parameters adjustments, and then foot switch controls, and then the selection of the machine. So this is how the presentation goes today. I'll just start from the beginning so that we'll have a continuity. See, cataract surgery now, phacoemulsification is the surgery of choice, and it's a machine dependent. So phaco machine is basically a tool in this process. So any tool will have a certain process of working. So we need to understand it completely first before using that tool, and then what is your expectation out of that tool? You should be very clear. And then what is the principle of its functioning, and then what are the parts and how it is to be operated. Like any equipment, generally they'll give the operating manual and then the basic manual. Generally, we don't look into that and directly end up in using that, and then starts going back and searching. That is what we should not do in the phaco machine. Then coming to the phacoemulsification surgery, use of basically it's a very highly skilled in the sense this human body sensor based surgery. We use our senses to maximize our cognitive function in performing the cataract surgery. The senses we use: visual sense, the touch, that is the fine motor, both the hand and then the foot, and then the auditory inputs by listening to the various sounds in the various levels of the foot switch. So three senses we will be using it, and then we'll be assisting our cognitive function. So we need to coordinate all these functions simultaneously. So that is the challenge. That is the reason why the phacoemulsification learning curve is little steep. On a continuous practice, this can be masterized, and then that end up in the practice our proprioceptive functions. After a certain level of number of phaco surgeons, so most of the things our hands and the things will do automatically. So that is the reason why experienced surgeons, they don't realize small things what the beginners face. So that is some level of proprioception happens. This happens only after the coordination and then the practice of the other senses. So to emulsify the nucleus simultaneously, what is our expectation out of this machine? So basically the machine, what we want is to emulsify the nucleus by the ultrasound, and simultaneously the debris should be evacuated. So that is the main basic aim of this tool, our expectation out of this tool. To maintain that when you are doing this process of emulsification and then the debris removal, so the chamber should be maintained. That means the eye contour should be maintained, and at any point of time the chamber should not either collapse or increase in the pressure. So the energy at the same time, the energy and then the mechanical movements that happens inside the eye should not harm the structures which are of not outside our interest. So it should be, all these things should be controlled by a surgeon through a foot switch. So basically infusion, aspiration, AC depth maintenance, and then emulsification. This is the basic expectation from the machine. So when you are using, you should see that all these things happen properly. These things needs to be adjusted, and when you are selecting the machine also, these things should be thoroughly evaluated. Then coming to the principal function of the machines. So basically it has two parts. One is the fluidics, the another is the emulsification. Fluidics basically the inflow and outflow in a balanced state. And then the emulsification, that is the ultrasound crystal that converts the electrical energy to mechanical energy, resulting in a to and fro needle motion or a side-by-side needle motion. So coordination between these three by the machine sensors, that is the brain of the machine, is the critical aspect. each of these function status should be known to the surgeon through an audible signals. So when you are using this tool, what is the machine is doing at what level it is activating. So we will be judging by that by these simple audible sounds that are coming out of the machine. Because our eyes and hands are legs are already engaged, so mainly we depend upon the auditory input. Through visual and foot control, the surgeon as his hands are already engaged. So our eyes, ears, and hands, legs. So all this coordination should happen. So this is the main challenge. So with this basic tool and then our expectation and then how the machine functions. So let us get first familiarized with the terminology of these parameters. Generally, flow rate means both inflow, that is fluid going into the eye, that is mainly 90% of the machines, they adjust by the gravity. By increasing the height of the bottle, you can increase the fluid into the eye. And then some of the latest machines have the active control pumps. The outflow is, that is the main parameter that we can easily adjust in the machine. This depends upon the pump and then the flow rate. Then the ultrasound energy delivery, this energy into time that gives the power. So finally we adjust the power. So then the occlusion. Occlusion is the blockage of the needle tube with the particle matter. Once there is an occlusion, then behind the occlusion the vacuum develops. And whereas in the other vacuum pumps, independent of the occlusion, the vacuum develops. And then the other word one should familiarize is the raise time. That is the time taken to reach our preset vacuum from the zero vacuum level. So these are the simple 5 familiar words one should get familiarized before starting the machine. So this is the bottle height, adjustment of the inflow, and this is the ultrasound how the needle moves back and forth and how it acts. So then the peristaltic pump, then the venturi pumps, how the vacuum develops. I think before starting the Phacoemulsification, one should thoroughly read this basic theoretical background and then get familiarized with the machine. Another third aspect is the raise time. Raise time is the time taken from the zero vacuum to the preset vacuum level. Suppose if you increase the flow rate, that is when in simple terms, suppose if you are traveling at 60 kilometers, then you will reach the target within 1 minute. If you are traveling at 20 kilometers per feet, then naturally it takes 3 times slower. So similarly, the more the flow rate, the faster we will reach the vacuum. So things will happen at a faster pace. So this one should familiarize before setting the parameters. So in practical terms, if you convert, so we are most of these things are the physics, and then which as a biology students, we always have some resistance towards the physics. So let us convert them into our simple nomenclature. The AC maintains. So what we want finally is the AC should be maintained. So that is by inflow and outflow. The inflow is by gravity, and the outflow with the pumps, the aspiration flow rate, that we can set from 0 to 40, or some of the equipment may up to 60 cc per minute. And AC shallowing either increase the bottle height or reduce the flow rate, or to check any leakages. And then next, what you want after the inflow and outflow, we want to hold the nucleus to emulsify. So this term of this holding is indirectly with the vacuum. So the higher the negative pressure, the higher the hold and suction. So that's why when you want to chop the the nucleus directly, so we need to hold it more firmly. So then we need to operate at a higher vacuum. Or when you are simply trenching and then the sculpting, so that time you don't require much of a holding. So then you can operate at a lower vacuum level and then the lower power level. So then the power again, the harder the cataracts, so the more power it requires. The softer the cataracts, the less power it is required. And then this vacuum and AFR, both these relation is a raised type. So if you convert all those physical terminology, so what we want is a good, well-maintained chamber by balanced inflow and outflow, and then the proper holding of the nucleus, and then sculpting. So with a low vacuum or high vacuum, or with a low power or the high power. So let us simplify everything and then just adjust the parameters. So these high-end equipments, they'll try to confuse you with many other parameters. That is, these are the finer aspects, but most of the surgery, most of the people can easily manage with these basic adjustments. So that means partly I will be answering your the third question, which machine. So then how to start? Then always I will advise beginners to start on a graded learning approach. First, you read the theory part thoroughly, observe or try to assist your teacher or the already experienced surgeon. Always people think that they want to do directly the surgeon, but we will learn most of the things by assisting only. By assisting, we will know how they are handling and all. Then go back and then read, and then masterize the tunnel and CCC and hydro procedures. Then understand the machine thoroughly, and then go to wet lab, do it on a wax eyes and animal eyes. Then you will get some kind of a confidence. But again, when you go to the operation theater, the entire thing will be different. So that's why familiarize the foot switch controls with an audio outputs, and then do only limited trenching. So when the seniors or the trainer is doing, just do only few trenchings initially, direct few, then don't go at a one stretch. If something happens, then our confidence levels will go down, and then we will be demoralized, and then it will take a lot of time to come back to again to that level. So then partly do a cortical aspiration with automated machines. Then start with a 4-quadrant cracking. So that will give you the depth and then the familiarity of the nucleus, and then the handling of the nucleus, and then the pieces. There are some schools of thoughts where they directly start with the chop techniques, but I always prefer my people to start with 4-quadrant trenching, then go to stop and chop, and then directly chop. Then coming to the parameter setting, so when you start, the first adjust everything yourself. Don't depend upon the sister or the senior and then go directly sit on the chair. Always do yourself the priming and then tuning the machine. Adjust the aspiration flow rate, vacuum, adjust the power yourself. Dry run on the test chamber, and then always start with a linear mode, that means the foot control. Then start with a pulse mode. Don't go with either burst mode or different kinds of, there are many modes. Simple pulse mode or continuous mode, you select and then do that. Once you get used to it, then you can change all the other things. Then the nucleus, and there are only 2 sub modes. You just keep one for a nucleus and one for a quadrant mode, and then continue the surgery. Then initially, please start with a case of somewhere around 2+ nucleus, and then do a 4-quadrant trenching and then cracking. Then when you're doing a trenching, select a low vacuum on moderate power and then aspiration flow rate. Always start with a linear mode. Then once the quadrants are removed, all the 3 modes slightly increase the vacuum to a moderate level. And then, because I'm not mentioning any vacuum levels here, because each machine functions at different levels. So maybe one machine 200 may be equal to another machine's 300 or 500. So that's why either low, moderate, or high. You decide, and then how check how your machine is delivering, and then come to a reasonable level of numbers. Then IA, slowly increase the AFR, then you will get familiarized to the faster movements of the fluid in the chamber, and then make finer adjustments depending upon the AC depth. Always after 2 or 3 foot switch pedal pressings, then see whether how stable your chamber, or after sudden dislodgement of the of your occlusion, just check how the chamber stability, then make a finer adjustments always, and then check for any flow obstruction. Then first raise the bottle height and then see still it is not working, then adjust the flow rates, and then the last is the vacuum. So these kind of adjustments you need to do initially, and then once you are confident the numbers reaches around 100, around 50, then go for a higher grades of cataract, then try all the other methods like chop and direct chop, and then go to a higher levels of the vacuum, and then increase the AFR, and then the other adjustments you can do. The quadrant removal also, once if you crack and things are there, then we try to relax at that level. One should never relax even till the end of the insertion of the IOL and then closure, because some initial stages, some of the mishaps happen at the removal of the quadrant last piece, or sometimes in the IA. Once the nucleus is all out, so we try to relax, and then we start subincisional cataract, the cortex, or sometimes in the sulcus, when you try to remove, we can create some problems. Make the finer adjustments depending upon the AC depth always. And then coming to the foot switch. Switch is the one first understand thoroughly the parts and functions. Some of the foot switches are wired, some of them are remote, and then it's an equivalent to an accelerator of a car. And then the basic models have 3 steps, that is irrigation plus aspiration, and then ultrasound. That is irrigation, aspiration plus ultrasound. So in foot switch 1, only irrigation, then 2 is irrigation plus aspiration. And then, so like that. So there are some dual modes are there, but basic foot switch one should get familiarized. And these foot switch also, mainly we will identify the position depending upon the audio output. And also some of the foot switch have that when the mode is changing, they have some tactile vibration also they can have at that option. But audio, the detection of the level of foot switch, and then visible when you are observing through your direct eyes. So if you coordinate these two, it will be very easy. And then the right side, left side for the reflex, and then for the mode change. This is the basic function. Then there are many other advanced foot switches where they can have the sub mode change and other things also can be changed in that systems. So these are and foot switch levels also, the distance or the gap, the amount of excursion in irrigation aspiration also can be adjusted in some of the foot switches. So these are the main advancements in the foot switch, and foot switch is the most important thing. And then the audio levels also most important thing. You can hear the sound. I hope it is audible.
No, sir. No.
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 Audio is not audible.
No. No. No.
Okay. Okay, I'll just after this.
Okay.
So coming to the Phaco machines, whether Indian or imported, now even the Indian machines also, the standard has improved very well, because most of the machines are now the microchip based. So then they are getting a reasonably good microchips. So all these sensors and then the coordination is happening consistently. But still, the main difference between the imported or the branded and then the Indian ones, dependency and they deliver 500. If you set a vacuum, definitely that most of the machines of the imported quality, they'll deliver to that level. 70% means 70%, 30 means 30%. But in Indian machines, what I noticed is you never know whether they are delivering to that level or not. So we need to get adjusted to the levels of the parameters, and then try to play with that. And I would suggest always when you are starting and then the initial stage, go for a lower budget semi-automation machine. Semi-automation machines are always easy to maintain, and also we will also get to know into each and every step. So otherwise we'll be lost in that. They have multiple parameters in that. Sometimes they are so confusing, and then we will end up finally depending on the application guy to save some programs on us. So that is the main problem. So machine that has a lower maintenance and then easily adjustable both for the staff as well as for ourselves, and preferably reusable items, because if you initially, when the load is not much, so if you open one cassette, then it may not be viable. Then simple adjustments like AFR and vacuum power, where you can easily adjust, like I have seen the machine like Artley has got an excellent, very easily user-friendly machine with all the simple adjustments and with a very good output functions. Preferably peristaltic mode is better for the beginners, and then the machine which can be easily portable and then easy to assemble, so that we can easily manage in the operation theater. So finally, to take home is understand the basics of the Phaco very well first, then understand the machine, then use the parameters to get best out of the machine, and then refine the surgical skills, then reduce the dependence on the machine, and then start enjoying the surgery. Thank you.
That was an excellent presentation, sir, and a beautiful overview for all our beginners and residents. Sir, I wanted to ask you two questions. Sure. One is, like usually most of these machines have 3 modules like soft, medium, and hard. So in your practice, do you change your duty cycle, or do you change the parameters for every case? Suppose you have a list of 10 cases. That was the first question.
Yeah.
Second question is, yes, sir. Yeah, I'll ask.
Go. Yeah. Generally, once if you reach some level of numbers of cases or the experience, I told you most of our actions will be taken care by the proprioceptive actions of our body. So that's why. And the second one is I'll be using mostly the linear modes. So when we are using a linear mode, so the softer cataracts, I'll be end up using around 60-70% of the whatever the power I set. For a harder cataracts, maybe I will be using the remaining higher end, then go to higher end and then use the thing. Generally, I have two modes like soft cataract, hard cataract, NS2+, NS3+. But honestly telling you, I'll end up using only one mode. Very rarely, sometimes very leathery cataract, if the things are not moving smoothly, then I'll ask them to change. But most of the time, I'll end up using only one program using most of the cases.
That was, I think, many surgeons finally end up answering the same thing, that over the period of years, finally you keep only 1 or 2 or 3, and then you don't need to adjust small parameters for everything, except of course if there is a specific situation. So the second question I wanted to ask you was, you mentioned about the reusable tubings. So tips and tubings are something which we re-autoclave every day, right? So for the benefit of our viewers, what I wanted to ask you is, how do you decide at what point of time to change the tip and at what point of time to change the tubing?
Always the first thing is we'll inspect the tips. Suppose any visible damage to the tip, it needs to be changed. And then otherwise most of the needles, they've come for a longer time. And then the second thing is when we're not able to emulsify the nucleus or make bury the nucleus like what you generally expect, then that is the time I think we'll end up in changing the needles. Coming to the sleeves, once they'll become very soft, they're easily malleable, and also the tubes also, when they become, now most of the time I'm using these cartridges, so we'll daily we'll be disposing it. But there are reusable tubes like in Otley and other machines, so you always check the consistency, and then if they're becoming soft, or if the vacuum is not maintaining, then if the aspiration is not up to the mark, then change the tubes.
Dr. Deepak sir, your views on this? You're muted, sir.
Yeah, I agree with him totally. I think most of us nowadays are using the disposable tubings, but for reusable tubings, I would recommend to stick by the company recommendations. Like Oertli has a recommendation of 30 autoclave cycles, or your the AMO, so sovereign compact users also, they have a recommendation like you have to use 30, 40, whatever it is. My advice would be stick to it. Simple reason is two things. One is, of course, the efficiency of the performance, but second would be, my concern is also regarding the sterilization aspect of it. Over a period of time, if you're autoclaving, especially if you're autoclaving, it's very difficult to go inside and clean these tubings and other things. So over a period of time, there is muck which is accumulating inside the wall of the tubings. So in a worst case scenario, if we have some bacteria which get stuck inside these, it might be difficult for the steam to penetrate inside and all. So it's not just about the performance issue, but also the sterilization issue, especially when you're using reusable tubings. So my suggestion would be just stick to the company recommendations.
One important point when we are doing sterilization for the Phaco tubings, the tubings are long, hollow cylinders, and we need to put these through only vacuum cycles, where the vacuum is actually pulling out the non-condensable gases inside the tubing, emptying the tube and allowing the steam to penetrate inside. If we do not have a vacuum cycle, then no amount of steam penetration, no amount of time exposure is going to allow steam to penetrate into the tube. So it is critical that when you're using reusable tubings through autoclave cycle, it must be a vacuum cycle.
Exactly. Very, very valid point, sir. Dr. Srini, would you want to add anything?
Not really. See, I just had a question like to Dr. Deepak. Dr. Gopala Raju mentioned something about the Indian Phaco missions. Your experience, because last week only I was talking to Minu. He said he had a demo with Chaksu, and he says he was amazed by the performance of Chaksu. He said unbelievable performance. Your experience with Indian Phaco missions?
Yeah, I have heard good things about Chakshu. Personally, I haven't used them, but apparently it's very good. The only reason, as Raju sir rightly pointed out, the consistency and dependability. They work very well, and suddenly one day they just don't work. And the frequency on unpredictable nature of these machines is the only cause for concern. Otherwise, most of the Indian machines have really come up to the level, especially Chakshu. But even then,
one more thing here. I mean, we are running short of time, but still, I have to ask this regarding the higher end Phaco machines imported, like for AMO or Alcon, higher end version and the lower end version. Because I have in one of my hospitals, I have a Alcon Laureate, and in the other hospital, I got a Signature Pro. I'm very happy with when it was compact and when it is a Laureate. I can do 10 cases, 11 cases with the Laureate, but it's not possible with a Signature Pro. So your thoughts on that?
No, I think the surgeon is the most important factor. Everything else comes later. So if the driver is good, he can drive a Maruti 800 car also and Mercedes-Benz car also. It doesn't make much of a difference. So if the driver is bad, you give him whatever car, it doesn't work well. Having said that, you have for most average cataracts, most machines will work well. See, if the surgeon is an average surgeon, a decent surgeon, most average cataracts, everything else will be the same. You feel it's a waste of money when you for most cataracts. But in just one or two, grade 5, grade 6 cataracts, where this is where non-dilating pupil, those are the situations where these high-end machines make a difference. Otherwise, for most average cataracts, I think most machines will do well. Probably the surgeon is probably the most important factor.
Yeah, see, there were a lot of questions. See, I went to TNOL, all those units come and ask, when they're asking, they're all worried about going for a basic mission. You would tell them definitely go for a basic mission? Money is a concern.
No, I think first hone your skills. See, the place where they are learning their skills, I think the honing your skills is important. Usually what happens wherever they do the training, the fellowship part, whatever machine they're using, usually they get used to it. Getting used to the machine is more important than other way around. Like, you just go and get the machine. If you have learned with Laureate, if you learned your surgeries with Laureate, then go and buy something which is similar to that, or learn the machines sovereign compact. But the problem comes if you learned with only high-end machines. If you learned with just torsional ultrasound and you Centurion machine, you just learned with that, then it's very difficult for you to go back and work on a smaller machine. Otherwise, whatever you learn, that becomes very easy for you to just transit.
Thank you, Dr. Deepak. Dr. Anaka, I think we are running short of time. We'll move on to the next presentation.
Yes. So I'd like to invite our next speaker, Dr. Deepak. He'll be speaking to us on nucleus management.
Hello friends, welcome to the Back to Basics series. In this presentation, I would be giving a brief overview of the principles of nucleus management in phacoemulsification, and I will be sharing a few practical tips on few of the techniques. So let's understand what is the goal of phacoemulsification. As we know it, the goal is to remove the nucleus from the capsule without damaging it, and also without damaging the iris and the corneal endothelium. Now, how do we achieve this goal? In most cases, we can't remove the nucleus en masse, that is in single piece. So the fundamental principle to achieve this goal is to break the nucleus into smaller fragments and then emulsify and aspirate each of these fragments through a small port of the phaco tip. So nucleus division is the fundamental principle, and to achieve this, we have the following techniques. The classical 4-quadrant technique, the stop and chop technique, and the direct chop technique, which has got two variants, the vertical chop and the horizontal chop technique. So let me begin with the 4-quadrant technique. And the first tip which I would like to share in this technique is to stabilize the nucleus with the second instrument during sculpting. The tip should gently cut across the nucleus without ever pushing at it. Then widen the groove after the first couple of sculpts to allow easy access to the wider sleeve, which can then effortlessly pass through the groove without getting obstructed. Number 3, one has to use adequate power so the nucleus matter is effortlessly shaven off without being physically pushed at during sculpting. This ensures zero stress on the capsular bag and the zonular apparatus. The lens matter, in fact, should effortlessly melt in front of the tip without any physical stress and then get aspirated easily. The trench should be sufficiently deepened depending upon the density of the nucleus. Harder the nucleus, deeper the trench we should have, so that the division process into the 4 quadrants will be easy and less stressful on the zonules. And at this stage, having a good stereopsis and excellent focus on the surgical plane is critical. While dividing these fragments by lateral separation, care needs to be taken to keep the 2 instruments deep in the trench and then laterally separated, especially in the harder cataracts. This ensures easier cracking of the posterior plate without stressing out the zonules. Well, the classical 4-quadrant technique continues to be the safest and the most predictable techniques of nucleus removal till date, and with the advent of the torsional ultrasound, it has regained its significance much more. Now, moving on quickly to the stop and chop technique. This is an excellent combination of the sculpting technique and also the chopping technique. The same principles of sculpting are utilized here. To stabilize the nucleus with the second instrument, the groove is widened to allow easier passage of the tip to the deeper sculpting. Here we do a single long trench and then divide the nucleus into 2 big heminucleus. Each of these heminucleus is then chopped into smaller fragments, typically 2 or 3 pieces, and then emulsified. Now, compared to the classical 4-quadrant technique, this is relatively quicker, much more efficient, and consumes lesser energy. The significant advantage when we compare this technique to a direct chop technique is that there is a sufficient space which is created because of the initial trench. This makes the nucleus manipulation much more easier and safer within the capsular bag, especially when we are dealing with a much denser nucleus. It's a versatile technique which comes in handy in most types of cataracts. Now, moving on to the direct chop technique. Here, we don't do any trenching or sculpting. The phaco tip is buried into the substance of the nucleus using a short burst of energy, and then the chopper scores the nucleus, dividing it in the process. Now, it has 2 variants, the horizontal chop and the vertical chop. In the horizontal chop technique, the long blunt chopper goes under the rhexis into the equator of the endonucleus, hooks it, and then the chopper is moved towards the phaco tip in a horizontal plane to achieve the nuclear division. On the contrary, in the vertical chopper, a sharp-tipped chopper is placed just in front of the nucleus, and then the chopper is moved vertically down while the phaco tip is moved vertically up. The plane of movement of these instruments is vertical, and hence the name. Now let's go back and see some live footage. In the horizontal chop technique, the blunt chopper goes under the rhexis, hooks the endonucleus, and then approaches towards the phaco tip. And the crack is visible, and as it approaches near the tip, the chopper is then moved laterally so that the complete division of the nucleus is achieved. Placing the chopper under the rhexis and reaching towards the equator of the endonucleus is quite intimidating to many surgeons. But still, this is the most efficient way of cracking the nucleus, since the forces acting here are much more physiological. the vertical chop. Here, the sharp-tipped chopper is placed just in front of the buried phaco tip, and then the chopper is pushed vertically down while the phaco tip is moved vertically up ever so slightly, and then the two instruments move laterally away from each other, ensuring a complete separation of the nucleus. The nucleus is then rotated and subsequent chops and lateral separations are done in a similar manner until the entire nucleus is divided into 6 smaller pieces. In vertical chop technique, it's preferable to complete the chopping of the entire nucleus first until we have the necessary number of fragments, and then it's preferable to emulsify one by one. The compactly arranged nucleus pieces within the bag provide the necessary friction and the stability while performing the vertical chop. This aspect, however, is not so relevant in horizontal chopping, and we can emulsify the first fragment as soon as it is created. In softer cataracts, we need not bury the tip very deep into the nucleus substance, and even a blunt Sinskey hook instead of a chopper will also do the job. Just with a little pressure, the division can be achieved. The beauty of this technique is that all the maneuvers are done in the central part of the bag, which is a safer zone and under direct visualization. The chopper is always within the rhexis margin. It is less intimidating to most surgeons compared to the horizontal chop. For very hard nucleus, I prefer to create a small trench here to get a very good grip on the central core of the nucleus as deep as possible. In this technique, it's all about getting a very firm hold on the deeper plane of the nucleus. During the chop, we are unlikely to separate the posterior plate in the first go. We need to perform multiple lateral separation movements at progressively deeper planes by constantly repositioning our instruments at the deeper planes. Of course, such cataracts demand our patience and also some degree of skill. Lastly, the quadrant removal aspect of the nucleus management. Now, we need to emulsify these pieces. This is a relatively easier step compared to the chopping maneuvers. But few important points are critical which are going to ensure clearer corneas on day 1 post-op. Number 1, the plane of emulsification. We want the phaco tip and the fragment to be as away as possible from the cornea, but safe enough not to damage the posterior capsule. Ideally, this plane would be at the plane of the rhexis, which is sufficiently far away from the endothelium. Lens chatter and turbulence, they can significantly cause endothelial trauma. The judicious use of phaco energy, along with appropriate flow rate and vacuum, will minimize lens chatter. The lens fragments should be just dancing around the phaco tip while being emulsified, and the overlying second instrument prevents any fragment from flying around and hitting the corneal endothelium. The perfect combination of energy, flow rate and vacuum is critical to achieve this. The amount of energy delivered is controlled linearly by the foot pedal. This final clip shows the last few fragments of a dense nucleus being emulsified. Kindly note, the process of emulsification is very controlled, and the fragments are still moving around in the capsular bag. There is minimal lens chatter and the plane of emulsification is posterior. And in spite of the consumed energy during the procedure being extremely high, the cornea on the day 1 is clear and we have an happy patient. So this was my brief overview of nucleus management in Phacoemulsification. Thank you for your attention and hope this helps. This film is intended for
Dr. Anaga, we'll move to the next presentation, and then if we have time, we'll have discussions.
Okay. Dr. Cyrus, can you please start your presentation? Dr. Cyrus? Dr. Cyrus, are you there? I think I'll just call him.
Yeah.
In the meantime, Dr. Deepak just. Yeah.
See, Dr. Alex, baby, anything you want to add on this, or you want to ask Dr. Deepak something? Dr. Alex, you're muted.
Yeah, question is for a beginner. What is that? It is according. Do you think for a big?
One second.
Yes, sir.
Now, shall I present?
It's okay. It's okay. Dr. Cyrus will present.
Yes. All right. Sorry. The Share screen. Hi everyone, can you hear me?
Yeah.
Yes.
Yeah.
Yes,
So I just had a challenging moment because my dog ate the other headphone, and so I was just dealing with that. Just give me a second. So this is one headphone which is in my ear, and this is the other one which has been chewed by the dog. So that's why I was just rescuing that. Okay. So hi everyone, thanks very much for having me. Thank you Srini for inviting me here, and thank you Anaga for inviting me as well. So my talk for today is cortical aspiration. You all can hear me now with the other one headphone?
Yes,
Yeah.
yes.
Yes. So cortical aspiration is my favorite technique, and my preferred technique is only one. It is bimanual INA, and that's because I never learned any other technique. So when I did ECC, we had a Simcoe cannula, but that was like 25 years ago. And when I finished post-graduation, I didn't bring the Simcoe cannula back from medical school, so they left it there only. And we were already doing Phaco and stuff, and we were already using bimanual INA. So I never had the chance to transition from a unimanual single handpiece IA to bimanual. So this is the only cortical aspiration I've been doing since 23 years. So let's have a look at a little video clip now. So cortical cleanup after FLACS, for example, is a little different than after a regular Phaco because there's no frill. So even if you adjust the laser system, you will still have to go into the periphery and pull out the cortex. And if you're going to go in the periphery and pull out the cortex, it's difficult to use a unimanual, especially for subincisional cortex. So that's we always use a bimanual. Now and then you engage the periphery of the bag like this, and then you end up detaching the bag. This does happen once in few hundred cases when you're inattentive, and it's basically surgeon error more than anything else. So then you have to pop a tension ring and then inject the lens. So this is one of the possible pitfalls of having to do cortical aspiration after FLACS. Otherwise, it's rather straightforward. Let's have a look at this case where we do cortical aspiration a little differently. So this kid was playing tennis ball cricket for his school league and got hit on the eye, sent him off to do a UBM. This was about 3 years ago. And you can see anterior segment imaging there. You can see that it's erroneously written as posterior lenticonus. I want you to see two things which are very funny actually. One is, can you see this? Yeah. So it says left side large angle recession noted from 2 to 9 o'clock position. There is a large posterior lenticonus noted. It's not a lenticonus, it's the posterior capsule which is ruptured. And it's also written there is marked starching of the zonules instead of stretching. So I don't think they did a spell check before writing this report. Anyway, let's go back to the surgery now. So this was the little fellow. I docked him onto the catalyst system so I could have a good look inside and see what was going on. So this is what we could see, that the posterior capsule is kind of given way. And the lens is also a little bit tilted. But we didn't plan to do a catalyst because there is no sense of just using it for a capsulotomy, which you can do ourselves anyway. So after some trypan blue and a careful rexis, which goes pretty well, now we do a very careful hydrodelineation like this. And a slow hydrodissection, one shot, just to get one edge of the lens a little up. So I can stick in the Phaco tip. Of course, you're not doing any Phaco. Again, this is irrigation aspiration. Just suck out. And now you can do what is called dry IA, which is another type of cortical aspiration, where you fill up the bag with viscoat or any other viscoelastic, and then basically have to pull the cortex out of the bag. Block the posterior capsule opening with viscoat with the other hand, and then get the cortex out. Now inject the lens inside, put it into the capsular bag, and the remaining cortex, you can just burp it out like this. You're always going to have some vitreous in the front, so you can't let this case go without some triamcinolone. And then you just remove the vitreous meshwork with the vitrector. And the end result was very, very good. This kid still comes to see me today with perfect vision and everything. Let's have a look at the next video now. So once again, most of the time I end up doing FLACS because that's what people want now in South Bombay. So again, we don't really use Phaco. Most of the time you just end up using irrigation aspiration. So this is the only time I would do a IA with a unimanual with the Phaco handpiece. And once again, carefully use a bimanual system and put in the lens. Let's have a look at one more video now. Now you can also implant a lens with fluid injection like this using the bimanual irrigator. Most of the time I don't put in viscoelastic in the end because it's just one more step to then remove viscoelastic. You can always inject a lens in like this under fluid and just position it. So these are the many uses of a bimanual system, which I think is far better than a unimanual or a single handpiece. I see people still using a single handpiece and I always wonder why they're doing that. When we eat food, we use a fork and a knife. We don't like push the food around the plate with one fork or a spoon. So it always makes sense to do a bimanual. So that's the end of the slideshow, and now we can have questions.
Yeah. Thank you so much, Dr. Cyrus. Both Dr. Deepak and Dr. Cyrus, excellent presentations as always. So I agree with you, Dr. Cyrus, coming to your presentation first. Definitely bimanual irrigation and aspiration is something which is being widely used. A few tips I would also like to add is for all the beginners, many times, the outflow, sometimes if there is a leak at the side port, then sometimes there could be a sudden shallowing. So you need to be very careful. Another thing is always we should remember that the opening of the aspiration port is superior. So that is why it is very important to see where you are pulling, and that visibility has to be very, very good. Many times I tend to use the SCI mode of my Lumira or the Leica, and that gives a very good glow. So the moment you have a very good glow, you can actually see where you are pulling, and that is the most important part. Most of the PC rents occur in the irrigation aspiration mode because there is no support or no barrier of the epinucleus also. So this is, I think, one of the most important parts, especially if there is a floppy bag, then, and if the chamber is shallowing, then you have to be extremely careful. Regarding Dr. Deepak Meghur's presentation, sir, as usual, so many points very well put in. Sir, what I would just like to ask you is, like, for example, if you have a specific strategy that you have planned in the beginning, but during the course of the phacoemulsification, so many times we may need to change the strategy also. So what are those areas where you may have to change the strategy, number one? And like the horizontal chop, it is sometimes difficult, especially if you have a smaller axis. So your comments.
Yeah, changing the strategy, the first question is, of course, many times you get a situation where you're dealing with an ultra soft cataract or an ultra hard cataract. So in ultra, you have gone away with starting to do a vertical chop technique, and then you realize that it's just not cracking. So these situations where you change the strategy and start trenching and probably do a stop and chop technique, because you're struggling to, too much struggling to divide the nucleus by direct chop technique. Similarly, with your very ultra soft cataracts, you thought you could chop, you can't get a hold of it at all, you can't do it at all. Then maybe you just have to change your strategy, just chew up the nucleus, and maybe there you can again do a thin long trench, divide into two heminucleus, and then aspirate it out. So these are the two situations where you will be forced to change strategies. It is not uncommon to get into the situations. Regarding the second question, small rexes and horizontal chop. Yeah, I think it's an issue, especially because many times if you're not very conscious of the fact or mindful, your chopper can in fact be over the rexus rather than under. So staining of the anterior capsule does help us a lot, get a good stain of the capsule, even if it's not required in such situations. If you stain the capsule well, you really are sure that the chopper is gone right under the rexus margin and you can see that it's tenting up, and then go ahead and do it.
Absolutely. Yeah, thank you so much for your inputs. Dr. Gopal Raju, any comments?
Matthew is asking something. Matthew
yes,
is,
sir. Dr. Matthew, sir.
In all the textbooks that you read, there is the statement, impale the phaco tip in the center of the nucleus. Okay, so we are looking at the nucleus from the top and you are getting a surface image. When we are saying that we need to impale the phaco tip in the center, we are also talking about impaling it within the thickness in the center portion. And identifying the thickness where you are with relation to the anterior capsule and the posterior capsule were a couple of publications by me in 2013 in the JCRS. So you can use, as you trench, you look at the fibers that are being cut, the orientation of the fibers, and you can use that to see whether you are very superficial. If you're superficial in the nucleus, the trenches, you will see cross striations. As you go deeper, you will see a little bit of linear striations and a combination of cross striations. And that is the ideal portion for doing a primary chop. For divide and conquer, you need to be much more deeper. And at that point, you will see only linear striations in the floor of the trench. And that is a point where cracking must be attempted. There is not sufficient thickness for impaling the nucleus. So these are useful points for people who are beginning or unsure of whether it is time to chop, whether it is time to initiate a crack.
Yeah, many times the red glow starts being seen very well once you're trenched deep enough. Suppose you are not able to see the red glow, that means you need to trench and you have to be extremely careful. Do not be full pedal down. Otherwise, you can easily go through and cause a PC rent at that point of time. Many times, even in soft cataracts, like sir was saying, it is difficult to divide into two, even if you are doing a direct chop, stop and chop. So a little bit deeper trench will help to divide into two. Yeah, sir, Dr. Gopal Raju, sir, you were saying something.
The texture and then the hardness and then the elasticity of the nucleus. Clinically, we can judge only by around 70 to 80% of the final, but only we will get to know about the actual nature of the nucleus after the first digging into the nucleus and then start dividing. So that's why only 70-80% of the time, and then the rest of the 20-30% of the time, we will be forced to change our strategies. That is my view.
Dr. Anaga, 2 more minutes. Arshul is.
I have a quick, quick observation on what Gopal Raju had to say. So it is no longer about, I think, the machine, whether it is Indian or foreign. I think a lot also depends on the tips that you use. For example, on a foreign machine, premium lens, premium company, if you use one type of tip versus the another type, Kelman tip versus the balance tip, the same machine performance alters completely. Similarly, on a basic entry-level Indian machine, I had the opportunity to do the Appaswamy machine the other day. When we were using the Appaswamy tips versus the same machine using AMO tip, the performance of the machine changed quite a lot. So I think it is no longer the capacity of the machine. It is also more than that, I think, is the quality of the tip that you're using, the nature of the tip that you're using.
Yes.
So Dr.
Thank
Sathya,
you.
anything more to add, Dr. Sathya?
No, sir, I've been learning a lot also. Thank you, sir.
I'd like to thank everyone. Like to thank KSOS, Dr. Srini, Dr. Arup sir, Dr. Gopal Pillai sir, all the speakers, Dr. Gopal Raju sir, Dr. Deepak, Dr. Cyrus, Dr. Satya ma'am for.
Thank you, Anaga, and thank you, Srini, for having me.
Yeah, Dr. Cyrus. Dr. Lalit was telling we should have a fitness competition for the next IOC 2023. He was very serious about it. Okay.
Yeah. I'm ready anytime.
Dr. Anaga is also there.
Yeah, I can do that.
Okay, thank you.
Okay.
Thank you,
Dr. Anaga.
Thank you, Srini, KSOS.
Sir,
Thank you all.
Thank you, Gopala Raju, sir, Cyrus, everyone. It was a wonderful session. Now we are going to move on to the session by Dr. Harshal. So
that was a wonderful session, which covered
Divya.
A to Z basics of phacoemulsification. Now let us move on to the second session, where we will be discussing about the intraocular lens design. The moderator for this session is Dr. Soumya. Dr. Soumya is a consultant phacosurgeon and glaucoma specialist at Ahalya Eye Hospital, Attingal. She did her MBBS from Government Medical College, Calicut, and MS from Regional Institute of Ophthalmology, Trivandrum. She has underwent long-term fellowship in glaucoma and phaco from Ahalya Eye Hospital Foundation, Palakkad. Over to you, Dr. Soumya.
Thank you, Dr. Divya, for your kind introduction. Now, I thank KOA and KSOS for giving me a chance to, as a convener in this session. Now, can I share my screen?
Yeah, please, Sonu. Are you sharing?
Okay, can you see?
No. It doesn't matter if you can read out. That's fine. We don't have much time. It's okay. You just read out whatever is there.
It's coming.
Okay.
Coming to the next session, that is intraocular lens designs and the selection. Coming to the chairperson, that is Harshal Dag sir, and I welcome him to this session. The keynote address will be given by Dr. Sudarshan Khokhar, sir, on iris glow lens implantation. Dr. Gaurav Luthra, sir, on multifocal and trifocal lenses. EDOF lenses by Dr. Kumar, doctor, and a note on toric IOLs by Dr. Harshal Dag sir. And the panelists will be Dr. Ambika Shetty, Dr. MS Vijayalakshmi, Dr. Sonu George, and Dr. Srini. Dr. Harshal Dag, he is the Director and Chief Surgeon at Ravilla Eye and Phaco Surgery Center, Jaipur. He is the Director of Jaipur Laser Vision Center. He is the present Chairman of Scientific Committee ROS and member of ARCS Central Zone, Assistant Editor IJO Cataract Session. He is an MBBS Gold Medalist from Dr. SN Medical College, Jodhpur. He is also an MS Gold Medalist, coined the term hydro implantation. He has got several gold medals in his name, including Shurveer Singh, Surya Narayan Gold Medal, etc. Now, I welcome you, sir. Dr. Gaurav Luthra, sir. He is a cataract refractive surgeon, director of Drishti Eye Institute, Dehradun. He has special interest in refractive surgery, challenging and pediatric cataract surgery, and keratoconus. He is the chairman, academics, and past president, IIRSI. He has over 200 live surgery demonstrations and 5 orations and 4 named national awards. He is also a gold medal in many of the sessions. He is a founder and chief instructor of technical skill transfer courses at AIOS since 2015. I welcome you, sir. Dr. Sudarshan Khokhar. He had his MBBS and MD from AIMS and FRCS Edinburgh. He has expertise in pediatric and complicated cataract surgery along with refractive surgery. He has been conducting instructive courses on complicated and pediatric cataracts in different national and international conferences like AAO, ESCRS, APAO. He has more than 25 years of his teaching experience at APEC Institution of India. He has over 80 index publications, has authored 6 chapters in different books. I welcome you, sir. His innovative works include Khokhar's capsular painting cannula for capsular painting in case of white cataracts, etc. I welcome Dr. Kumar, doctor. He is the CEO of Dr. Eye Institute, present IIRSN president in 2013 to 2014. He is an anterior segment surgeon who specializes in excimer laser with laser surgery and laser cataract surgery. He has got many best video awards and best paper presentations in several sessions. He has contributed to many chapters at anterior segment in ophthalmology in number of books. I welcome you, sir. Now, these are our panelists. Dr. M.S. Vijayalakshmi, she had an MBBS and DNB from Government Medical College, Calicut, and DO from Kottayam Medical College. Now working as a senior consultant, Phaco and Refractive Services, Contrast Eye Hospital, Calicut. She is the course director in Phaco training over there. I welcome you, ma'am. Dr. Ambika Shetty, she is the director of Gitanjali Eye Hospital at Trivandrum. She has an MBBS, DNB, FICU, and FRS glass. She has his MS from Minto Ophthalmic Hospital and a long-term fellowship in cataract and refractive surgery from Netradama Eye Hospital, Bangalore. She established department in ophthalmology at Gitanjali Hospital. She has 10 years of experience in Phaco, including topical, complex cataract surgeries, toric, and multifocal IOLs. She is passionate about mentoring surgeons to improve their skills. I welcome you, ma'am. Dr. Sonu Jod. He had his MS from St. John's Medical College, Bangalore, fellowship in Phaco from Lotus Eye Hospital, Coimbatore. He is presently the head of department and senior consultant at Medical Trust Cochin, a multi-specialty hospital with postgraduate training and optometry BSc and MSc since 2 years. He is also a professor of optometry under the KOAs. He has more than 18 years experience in Phaco, cataract surgery, and anterior segment disorders. He has special interest in ocular surface disorders and has done research work in it, including amniotic membrane graft and limbal stem cell grafts. He has 3 international publications, more than 35 presentations, various state and national conferences. I welcome you, sir. Now, the last and not the least, Dr. Srini. It has also been explained detailedly told by Dr. Rakhi. He had his MS from RP Center AIMS, fellowship on anterior segment from Shankara Eye Hospital, chief surgeon and medical director. He has been a chief surgeon, medical director at Contrast Charitable Trust Eye Hospital, Talsheri, and Mam Trust Eye Hospital, Kanjunga. He does about 70 to 80 Phaco every month in these hospitals. I welcome you, sir. Now over to you, the chairperson, Dr. Harshal Thak, sir, to take on the session. Thank you.
Thank you so much, Dr. Soumya, for the wonderful introduction of all our guest faculty here for today's evening program. And at the outset, I'd like to thank Kerala Society of Ophthalmic Surgeons and Kollam Ophthalmics Association, Dr. Srini, Dr. Gopal Pillai, Dr. Arup, for giving this wonderful opportunity to conduct this session on intraocular lens designs. We all know that in today's era, we have plethora of IOL choices available, which we can offer to our patients, and so that they can have best vision, which can be spectacle free. We have multifocal, trifocals, EDOFs, torics, and all those lenses available. So today our speakers will be highlighting what all are and the indications, contraindications, and the technique to use these lenses. So
Harshal,
Dr. Srini,
give me the opportunity to welcome my own dear teacher, who was probably one of the best hands in any sort of surgery in India or perhaps in the world, and he was my guide also for my thesis. Sir, it's a privilege to have you here. Sir, so what we can have a little bit of tweaking, because I think Dr. Gaurav and Dr. Kumar doctor were there for Rajasthan this midterm conference, and they're traveling to I mean, that's what Harshal said, right? They're going to the airport. So
they can go ahead. They can come earlier.
Yeah, then they can be on phone during their travel and be there for discussions. So who is starting first?
I think Dr. Kumar is going first, and then Dr. Gaurav. So Srini rightly said, Dr. Khokhar, when I gave my PG exam, Dr. Khokhar was my examiner, and way back in 2001. And yeah,
the friendliest of
years I've seen that. I always call him Encyclopedia of Ophthalmology. Whatever you have in your mind is there for you. Yeah.
You're delaying those guys.
To have you, sir.
Yeah, please go ahead. Those guys are going to miss the flight otherwise. Yeah. Thank you.
Okay, so let's start with Dr. Kumar. We all know he's a prolific surgeon from Mumbai, and he'll be speaking on EDOF lenses, nuances. Dr. Kumar, all yours.
Thank you, KSOS, and all the organizers for having given this opportunity. It is a great pleasure to be here. I'm going to talk about EDOF IOLs and what's my little experience with that, and what are the market trends that are going on. So in today's world, we have the iHance. The iHance Toric is coming end of this month. We have the Lucidis, we have the Vivity, and the Indian companies, what I know of, we have the Comfort and the Magnificent. So these are the EDOF IOLs that are available in the market today. So I'll just show a little video about the iHance, which is under high magnification. The beauty of this lens is that the learning curve is zero, because if you're used to using any of the IQs or the Technis ones, to use this lens is very, very easy. So really there's no learning curve. So here I'm showing under very high magnification, the highest possible. You can see the square edge and you can see the optic haptic design, and the square edge goes on to the optic. And that's from optic to the haptic. And that's the reason why the PCO in such a scenario is very, very low. And you can even see the little curvature in the center of the optic, which is there. And this is what actually gives us the ability to be able to read. And this is the optic haptic junction. The square edge is going from the optic to the haptic. And this is how it is. Now, as far as the loading of the lens is concerned, really there is no learning curve, because if you're used to using the Technis one, it's as simple as that. Just load it in the cartridge the same way and implant it in the bag in the same way you put the Technis one. So this is the loading. The cartridge is made beautifully, which actually houses the haptic on the top, and then just push on the optic, and then the lens is implanted into the eye. And I like to prefer, unless it's not a toric, that all the lenses have to be implanted horizontally to prevent negative dysphotopsia. So this is the iHance, which is going into the bag. We'll discuss the results as far as concerned. Now coming to the new EDOF, which is the Lucidis. I've used quite a few of them, not as many as many of the panelists, but I must have used about 300 and 350 of those. So I'm just going to show one step of the lens, how different it is from the other IOLs that we are using. And finally, the viscoelastic removal. So this is the lens that I'm using. So this is the loading. We fill up the methyl cellulose in the cartridge. It's a hydrophilic lens, so it comes in water, as we know. And once the lens is loaded onto the cartridge, we just close the this thing and push the plunger, and the lens moves forward. So it's like any other lens loading. Really, there is nothing much. But when it comes to implantation, there is a bit of a learning curve, and I'll tell you why. So this is the plunger going ahead, and the lens goes ahead. Now coming to implantation, we make sure that the implantation is, of course, in the bag. You will see that you're going into the eye. A little bit of air sometimes comes if you lose the plunger, but this is the leading haptic going into the bag. Now coming to the trailing haptic, there's a little trick. So you can see the leading haptic is going straight into the bag. There are many ways of putting the IOL in. We prefer to either dial them in or we just nudge them in. So you can see here I'm using a T, and I'm going to just nudge the IOL into the bag. So you can see that it just folds upon itself and it goes into the bag. As I mentioned earlier, I like to put all the lenses horizontally, and the lens is well centered. Now this is a femtorexis. We are going ahead and then doing phacoemulsification and putting the lens into the bag. Now coming to dialing of the optic haptic, here the optic and the haptic have a large curvature surface area. So when it comes to dialing, you will see that there is an effort made here. You can see that little bit on effort made there. And of course, the lens is again placed horizontally. So this is another way of putting the lens into the bag. And of course, it's very important to remove the viscoelastic from front of the IOL and from behind the IOL. This is bimanual IA. And many times I like to go with the irrigation behind the IOL and push the saline inside so that the viscoelastic comes out. Don't forget, friends, that the viscoelastic compartmentalizes in front of the IOL and behind the IOL. So sometimes I even use the main incision, just nudge the optic a little down and remove the viscoelastic from behind so that all the viscoelastic is completely out of the bag and there's nothing. So this is going behind the IOL with the irrigation port itself and just removing any viscoelastic if there is any there. Now, as far as the IOL itself is concerned, so there is a little difference in design compared to our IQs or any other lens, the Technis, iHance or Comfort or Magnificent. There's a little difference. So you can see the difference that the surface area for the optic haptic is large. And that's the reason why there is a learning curve to dial this lens in. So the first way out was that we just place the lens in as what I mentioned. So you can see this is a surface area which goes from the optic to the haptic, which covers a large area. And that's the reason why this can happen. But there is really nothing much to worry. This is the image guided procedure. Now I'm just dialing the with the help of a T, just dialing the haptic into the bag and then making sure that the alignment happens. Now, there is another one method of doing this is where I use a bimanual technique. So this is an iris repositor in my left hand, which is a non-dominant hand, and I'm injecting the lens with my right hand. And at the same time, I'm making sure that the lens goes into the bag and making sure that it gently opens in the bag. And now look at my left hand just nudging the haptic into the bag. So here you can see I'm not dialing, I'm not rotating, but I'm just nudging it into the bag. So this is another method of just placing this kind of an IOL into the bag. So there's a little bit of a learning curve as far as the Lucidus is concerned. Otherwise, there is no learning curve at all. So this in my hand worked very, very well. I prefer to make a little larger rexus compared to anything else. I like to fill the bag with viscoelastic. I use a bimanual technique to remove the viscoelastic from front and behind the optic, and this works very well. Now, I've also implanted the Eden lens, which is made by the Lucidus. It's a diffractive design. This is the VVT lens. So I've not implanted many VVTs, but I was a little unhappy compared to the price to money ratio. And so I've stopped again implanting the VVT. I've used a few, but not many. So I must have used about 8 or 9 and not more than that. Now, I've used quite a few of Comfort. This is a company called AdTech. This is again just like an EDOF IOL. They also have a Comfort toric. But the biggest disadvantage of any of these lenses is that they are pupil dependent. Another brilliant lens made by an Indian company called IOCare is called Magnificent. It's hydrophobic EDOF lens compared to others which are hydrophilic. So I have used the pros and cons of each. The ease of learning curve with the iHance is brilliant. Toric will come end of the month. Lucidus, a small percentage need an ad. So why do a certain percentage need an ad? I really don't have an answer. If any of the panelists would like to add to that, I'm not sure. But a very small percentage also do complain of halos. VVT, I've done a few patients, but some needed an ad. And one patient of mine complained of halos. So I stopped using the VVT. Comfort, I've used many, but all the lenses technically are pupil dependent. So if you have a pupil of 2 and below or 2.4 and below, Comfort is not going to work well and patient will get a refractive error post-op. And as I said, so in conclusion, patients who do not want glare, halos, and starburst, who are averse to these words, these are the best options available for them today. Thank you for your attention.
Thank you so much, Dr. Kumar. So if you compare to multifocal and trifocal lenses, what is the incidence of photic phenomena in these EDOF lenses in your patients?
There is no negative dysphotopsia at all. So only thing is one of my patients of VVT has complained of halos. Some of my patients, so if I have done say 100, 1 or 2 patients in Comfort have got -2 post-op because the pupil was very small. If you dilate the pupil a little bit, the -2 disappears. So this is what I have found. So I then do a sphincterotomy, yak sphincterotomy, and the patients are comfortable. So it's very important that when we use any of the EDOF IOLs, in my experience, measuring the pupil is the most important thing. And that if it gets missed, whatever we promise may not happen. Another thing, of course, we know that in iHance, patients need an ad of 1.5. There is no controversy there. But the biggest advantage, no halos, no glare, no other dysphotopsia or anything happening there. But I only give that lens for people who want to manage their phone, which is 80% of our time, with full light, bright light, without changing the font. They will be able to use their phone quite comfortably. So I think this EDOF works very well.
Yes, Dr. Kumar, one question here. When you plan for a iHands, bilateral, do you adjust intraocular lens power? Do you go for on target or a target minus 0.5 or something? Because I use quite a few of iHands. I mean, more than 100 I use a month. So I normally go for a little bit minus, and patients are quite happy 6.6. I mean, you're not promising them N6. What is your practice?
I absolutely agree with you that 0.5 in the non-dominant eye will bring them to N8. Otherwise, they are N10.
Yeah.
So this is my experience. I don't have as much volume as you, but this is what I've found, and it works clinically quite fine.
Yeah, one more company was come out. I mean, they just show me the lenses in the TNO conference now. Like the Excel Optics has come out with a hydrophilic EDOF lens with a 7mm optic to take care of the negative dysphotopsia. Yeah, that's I have to use and see it. I mean, I think Dr. J.K. Reddy was involved in the design, and also.
So I have used 7mm optics made by IOCare. And we tried to do a study and placing them horizontally for the negative dysphotopsia. The biggest problem here, Srini, is that we do not know who's going to complain of negative dysphotopsia. Right? So if you, and another thing I found was I did a visual field for them. And if you have to do full field, it takes a long time. So patients get tired. So unless it's a blind procedure where one eye patient complains of negative dysphotopsia and the other eye we put a 7 millimeter optic and does not complain of negative dysphotopsia, then this study will have some value. So actually I gave up the study because the perimetry used to take a lot of time and patients used to get quite fed up. But I've done this with, and IOCAR had made these lenses very many years ago.
Okay.
But you are right, I think.
Yeah, Khokhar sir, any comments on this?
Butcher sir, good evening.
No, you're muted, sir. You're muted, sir.
Can't hear you.
I recently operated about 2 months back, 2 ophthalmologists from Delhi. And my first lens was iHands. And this guy went to US and brought a VVT from there, and he wanted a VVT in the other eye. And I told him, because when I see the bump, as Kumar showed you under the magnification, when you see the bumps in the center, that means there's a transition zone. So the more chances that the patients will have the halos, especially the ophthalmologist who knows there's a ring. So ring in the lens is ring in the mind. If you don't tell the patient, I think 90% will go away. Similar to the ICLs. ICLs have a hole. If you tell the patient there's a hole in the lens in the eye, he will 100% see it. Otherwise, they don't. So what I'm coming to is that, so the VVT lenses and the iHands lenses, when we put them on the eye trace, we realize that the higher order aberrations which are induced from the lens were maximum with the VVT as compared to the iHands. So that's the only thing I wanted to add. Otherwise, I think Kumar is doing a great job and he's a wonderful surgeon handling Mumbai eyes.
Thank you, sir.
Dr. Sonu George, any question? Yeah, please.
I just wanted to share my experience with the newer IOL, that is a Swissfob from Appasamy. So I've compared 3 lenses. One is the iHands and the Magnificent and this Swissfob. And like, you know, with a micro monovision in the non-dominant eye by around 0.5 to 0.75, I am able to get around 70% N6 for intermediate and also N6 for near with this lens. And I could never get N8 with the Technis iHands, and maybe around 23% with the Magnificent. But this lens is a very good promise. And if you look at the profile of the lens under the microscope, the polishing and the aspheric design, etc., is excellent. And regarding the VVT, I also do this slight 0.5 to 0.75 in the non-dominant eye. Reasonably happy with the results. Nobody's complained of glares and halos, but there is one patient who says his vision is not clear. He doesn't explain what exactly it is, but he says the vision is not clear. Other than that, this is my experience.
Can I ask one question to the panelists, Harshu?
Yeah, please.
So to Srini and Professor Kocher and Soni, my question would be, we conclude that all EDOF lenses are pupil dependent. Which, according to your experience, is the least pupil dependent?
What I will say is the one with the non-diffractive. So I think the iHands should be the least dependent, because other ones have a refractive value. When you have a refractive lenses, like whenever you have a bumps, different refractive sites, then they become a more refractive than diffractive. So those one will definitely need a pupil dependency. Whereas remember those lenses of Array 3Ms about 30 years back, you put a drop of pilocop in the morning and put a dilating drop in the evening, otherwise they won't see anything. But so those are the ones. Otherwise, majority of these ones are actually doing pretty good. iHands, I think, is one of the best ones. I feel that way.
Yeah, even I agree with you, because all the aspherically corrected EDOF lenses are less pupillary dependent.
My experience also seen with EDOF, Technis iHands.
Yeah, Harshul will move on.
Thank you.
Thank you so much, Dr. Kumar.
Thank you so
much. Next, I'd like to invite Dr. Gaurav Luthra. We all know an amazing surgeon from Dehradun, Drashti Eye Institute, and he's ARC chairperson of IRSI, and he'll be speaking on multifocal and trifocal IOL technology. Dr. Gaurav.
Thank you, Harshul, for inviting me, and of course KSOS. It's really a pleasure to be there with all of you and getting to learn. I'm just in a little bit of an off location, and I'll just share my screen. So in case I get disconnected in between, I'll try to reconnect within seconds. I have a fallback option as well. So let me just connect. So as planned for this day's talk, I will be speaking on some new trifocal and multifocal IOLs and how to plan them and the new technology. So let's see how this moves. So the need for refractive surgery has been, obviously we all understand that. Refractive cataract surgery is the need of the day, and patients somehow expect spectacles-free vision at all distances now. They kind of, come looking for it. They expect it from us that we'll be able to give them reading and distance. And if you tell them that, I'm going to give you only distance vision, they'll actually be surprised to see why is this doctor not able to give me good reading vision? That means there's something wrong with this surgeon. So the demand for presbyopia correcting IOLs from patients is growing. And multifocal IOLs have been around for a long time, almost 3 decades here now, and they've grown and they've evolved and they've improved so much that today we can implant them with so much more confidence and newer designs. So they've evolved. They debuted in the 80s, and over the years, they improved. I remember during my PG training, we were delving with some PMMA multifocals. And they obviously used to have a big incision, and that's why they were not even the torics had come in PMMA design in the 90s. And after that, gradually, we started having better and better lenses. So the first one was in 1986 by John Pierce, and then this was a 2-zone refractive multifocal. And the first FDA-approved multifocal was the AMO silicon array lens. So they've evolved over the years, and then we had the accommodating lenses and the bifocals with different ADPARs, and then the EDOF, and today the trifocals and the continuous range of vision lenses. I was just looking back at my multifocal presentations over the years, and I found this from 2003 when we used to use a holder folder. There were no injectors for this lens. This was a silicon acrysil twin set lens. I think Kumar used to use a lot of these as well. And they were amazing lenses. They used to give a great vision. And then also in the 2000s, 4 and 5, we were using these 1CU human optics, and I used quite a few of these in that year till I found one of my patients coming back with something like this. Suddenly he said, I can see 4 of everything. And the haptics had all folded in, and that was the end of my journey with the 1CU lens. So over the years, they've evolved. Then the Restore came along, and we started using more of the Restores. The Restores evolved over the years, with the add of +4, then the +3, then even with the +2.5, because they wanted to give better intermediate vision. So, patients used to complain with the earlier Restores about having to hold things very close to read anything. So then we started doing the +3, and then even they had sometimes, I think, come out with a 3.5, but that never came to market, and then the 2.5. So the maximum experience I had was the Restore +3, but those were bifocal lenses, and they continued to evolve till we got the Alcon Panoptics. And also I used a lot of the Zeiss lenses, which came in excellent. The Zeiss took over 80 Lisa, Acryl Lisa, and they came with several models like these. So how have multifocals become popular over the years? Because we've improved so much with our surgery. Our incision sizes went down. We went to Phaco, so our induced astigmatism went down. We learned how to tackle astigmatism. We started doing optical biometry because multifocals are so sensitive to accurate biometry. If you don't have a plano or a ±0.25 or 0.5 result and astigmatism as well today, our multifocal patients cannot be happy. So all these things, smaller incisions, precisions in IOL calculations, minimizing astigmatism, minimizing SIA, has all improved along with the technology of the lenses, and everything is going hand in hand for us to reach this stage where we are today. And broadly, the multifocal IOLs are of the refractive and the diffractive, and the combined lenses today are like the synergy, which combines the two principles. And these were the refractive multizonal designs as in the past. I will not go into the details. We don't use many of these lenses now. Then the diffractive designs, which suddenly became popular because they had much better reading ability and great distance vision. But then they obviously also had some limitations with the halo effects, and several lenses came up like this, as I discussed just now. And then the apodization came up, which basically is gradual reduction or blending of the diffractive step heights. And this managed to decrease the, symptoms from the halo effects and the other distinct effects, which we used to get with the multifocal lenses. And then, of course, came because of the problems with the lenses, we came with the extended range lenses like the Symphony, and then the iHands, and then several other lenses like that. And then, of course, today, I think for patients who really need great near, intermediate, and distance vision, trifocal lenses are here to, in the market today as the best option. And there are several of them available. This is the Zeiss lens design, which I have used a lot over the years. And as a trifocal zone over 4.34 millimeters and a peripheral bifocal zone. So basically, broadly, the bifocal lenses, I like to call them bifocals now because they are not truly multifocals. And then I like to call the patient because, you know, if you tell patients that I will use a multifocal versus a trifocal, they'll get confused. They'll think multifocal IOLs are way better than the trifocals. So now I call them as bifocal lenses and trifocals. And I hardly use any bifocal lenses now. Mostly we've shifted to trifocals. And I think bifocals will gradually go out because they have the extra intermediate zone, which the bifocal lenses did not have, and it makes sense. And moreover, they have actually improved in the effects of the problems we used to face with glare and halos. So the modern trifocal designs are actually better at countering these effects than we had with the bifocals. So success with multifocal IOLs depends a lot about careful patient selection and a good knowledge about the IOL design to choose which lens to give to which patient. This is so critical with so many kinds of lenses available, and then building up the right expectations with excellent surgical technique, because that goes hand in hand with delivering good results to the patient, and also knowing how to handle the manage the possible complications. So where to start if you are doing multifocal IOLs? Raise your standards, become great with your cataract surgery and a perfection in biometry. Start getting 90% of your patients within plus minus 0.5 of emetropia for spherical and cylindrical numbers. Pay attention to astigmatism. Do toric calculation for every patient, even those with 0.25 or 0.5 of cylinder. And, a large choice of presbyopia correcting IOLs are available. Also, one other thing for success with multifocal IOLs is that you must know your patient. So introduce the possibility of this to every patient, that there is a possibility of getting near and good distance vision at the same time, because many patients you may not think will take a multifocal IOL will actually opt for a multifocal IOL. And assess the patient's needs as you talk to them, whether how much of near and intermediate needs does the patient have. Ask them, do you like to keep seeing your phone every now and then? And the patient will almost always tell you that, yes, I need to see my phone always, every now and then. And those are potential candidates for a multifocal lens. A good amount of chair time and a patient hearing from the patient and understanding their mindset. If they are perfectionists, then you have to become a little careful. Also, some myths and misconceptions need to be cleared. Some patients do come with, myths about glare and halos from friends who have told them, or some other surgeons who have told them that don't go for a multifocal lens. It will give you, glare and halos. So you have to kind of break the myths, but don't make false promises either. And explain to them how initially after surgery they may notice some glare, but that happens with almost all lenses, including monofocals and multifocals, and tends to settle down as both eyes are done and over a period of time. So night driving, you must ask about night driving. How much? I typically ask them that, do you drive inter-city or something at night? So typically those who drive within the cities are unlikely to face too many problems, but those who are into highway driving at night and long drives, you have to become a little cautious with them. Other considerations, of course, would be the pupil size, the arm's length. So, Indian patients don't have very long arm length, so they may like to hold their reading material a little closer. So you have to remember that when you operate such patients, or shorter patients with shorter arms. And of course, the personality type and the profession and the age of the patient. Also, today we should look out for any history of previous refractive surgery. So a good preoperative evaluation for multifocal patients is a must, which includes meticulous preoperative evaluation of the ocular surface, all parts of the eye, a good optical biometry, using a new generation IOL calculation formula, which is fit for such surgeries. Making sure that you are measuring ELP and lens thickness, maybe an aberrometry if you have access to that, and ruling out existing comorbidities. So I'll quickly run through 3-4 things that you must do before using a multifocal lens. Good keratometry, maybe a topography if possible, because that tells you about, I have actually picked up quite a few inferior steepening patients with PMD, subtle keratoconus, and they seem to come up as toric patients. And the moment you look at their topography, you'll immediately see that this patient is not going to do well. So I would strongly suggest that if implanting a multifocal lens, a quick look at the topography is very, very useful to prevent disasters, even for torics. And maybe an OCT for screening for the macula for any macular pathology, and if possible a tear film assessment and aberrometry. So biometry, we can all now, many people have moved on to optical, which is really, really important. I already spoke about topography benefits, and this was very, very important that you must have a look at that. And then, of course, the aberrometry, if you can have a look at that, because that also tends to give you the angle alpha and kappa, which I'll just talk about. So these are the few things that I would suggest. Again, I think most important thing when putting multifocals is that you must take into account even the smallest astigmatism that is there, and do a good toric calculation. And if there is astigmatism, please don't shove it under the carpet. Make sure that you're tackling it, because many times you see that a patient with -1, 1.5 diopters has been given a multifocal lens, and they come to you and they're dissatisfied, obviously. and then you don't know what to say, because the surgeon who would have implanted it should have actually looked at high astigmatism and not maybe use a multifocal or maybe use a toric multifocal, which also give us great results. So I think switching to torics is more important for multifocal lenses, and that is very, very important. And choosing the right IOL is, as I said, you can have such a huge range of different kinds of presbyopia correcting lenses which you can use, and you can go with what suits your patient best. And choosing the right procedure as well, because you may want to do femto-assisted cataract surgery if you have small astigmatism and not going to use a toric multifocal as well, even some incision planning. And Harshul, am I running out of time? I just need about 2-3 minutes more. Is that okay?
Yeah.
Okay.
Yeah,
So
take 2 minutes.
counseling and setting the right expectations is again a key to success with multifocals and trifocal IOLs. So the counselor has a very important role. If your counselor is mediocre and builds up wrong expectations or does not really give the patient what what you would like to convey, this can go horribly wrong, and it often does. And so ensure that you are building up the right expectations when offering solutions like these, and never hype total freedom from glasses. Even with the best or most expensive lens, I tell the patients that this is only going to decrease your dependence for 90% of your activities. And we aim to get you to 0, but we never achieve 0. We may come very close to it. So you may want to use glasses for some very fine print reading, or even occasionally for very fine things. Like I tell them, like I stay in Dehradun, I tell them if you have to see the Mussoorie Hills, you may still want to wear some glasses and, to see very well. So that kinds of prepares them that, they will not have perfection. They may need glasses occasionally for certain activities, and tell them that the best results are only achieved when both eyes are done. They typically would want to come back for the second eye surgery, and mention about occasional issues with glare and halos, but don't talk too much about it, because as Dr. Khokhar said, it's much in the mind. If you tell about it a lot, they will start looking for it and then they'll come back. So definitely mention it, but please don't scare them away, because that will add to the problems as well. And so I think pick the best candidates. We've already discussed quite a few things, and pay attention to the red flags. So make sure that you're not missing some of these important things. Look out for diabetic retinopathy, ARMD, Fuchs dystrophy, patients with behavioral issues and high expectations, high visual demands, and look at what their profession is. For example, pilots and golfers, they may have different expectations, and you may end up with a situation. And also definitely look for pre-OS refractive surgery. I told you about angle kappa and alpha, which I think is very important. When we are doing refractive surgery, we are more careful about the angle kappa, because especially with hyperos, we look out for that. But with the cataract surgery and multifocal IOLs, I think it's more important to look for the angle alpha, which is basically should be ideally less than 0.5 millimeters, and it's the angle between the optical axis and the center of the capsular bag. And you may use the angle kappa measurements as well, but definitely look out. So this is a sample eye trace which gives you both these measurements for both eyes. And of course, some of the topographers do this too, but you can even manually measure it. And definitely, if you have a decentered IOL, this can be an issue for poor quality of vision. But the verdict is not out. There are some patients who have very bad angle alphas, and yet they may have excellent vision and very satisfied with their surgery. So this is not like an absolute perfect technique, and this still has some way to go. So this is the way I would center my lenses with either the Virion or the Callisto, because it's good because it gives you how to center the lenses onto the visual axis, and you have to be lucky if the lens stays where you put it there. So currently available technologies, the PanOptics, the Acrylisa trifocal, and some of the fine vision trifocal lenses, which we used a few years back and have become available again. And the concept of the EDOF, Dr. Kumar spoke about, but the AT-Lisa Tri family, which has, the toric and the regular version as well, with an add power of for intermediate of 1.66 and the for reading for 3.33. And the other lenses that it obviously claims a lot of things. Coming on to the PanOptics, which has the Enlighten technology and has, it has much less dependence on the pupil size and gives you excellent near and intermediate vision both. And these new lenses, the PanOptics and Synergy, claim to have very high light utilization in the 90s. So this is one thing. And this is a non-apodized diffractive multifocal IOL. And it has a central diffractive zone for the intermediate vision, which is the 1.164 millimeters. So it allows you to work with even, it's not pupil dependent. So as I said, this transmits 88% of the light at 3 millimeter pupil size. And for intermediate, it gives you 40 to 80 centimeters range of vision. And this is the optical principle. So you can see here for the distance, the intermediate and the near. And you can then also have, it has the quadrifocal optical effect, which gives you which adds on to your distance zone. So this helps improve the distance vision as well. And the Synergy, and I'll finish now in about half a minute. the Synergy lens. It combines the technologies of the Technis Multifocal, which was a bifocal, and the Technis Symphony, which was basically the extended depth of lenses, and tends to give you, or claims to give you, the continuous range of vision. And we have found that patients with the Synergy tend to have much better ability from near to intermediate than our other patients who are using the other lenses. Also, it has the chroma line technology, which corrects the chromatic aberrations, and this also, the Synergy also has the advantage that other than continuous range of vision, even has less dependence on very good light. So typically I would tell all my multifocal patients that you must have great light, very good light for near vision for when you want to read. But with the Synergy, this claims to address that as well. So if you look at the deep focus curves, and I will not be able to go into the details of these lenses, you can see that how these lenses are. This is the Technis Synergy on the left, and the Technis monofocal. So while they may match over here for the distance and they're pretty comparable, but then the Synergy comes into its own and gives you a much better, defocus for reading. And this is comparing some of the available technologies for the trifocal lenses. And you can see here that the Symphony, which is basically an extended depth, is missing out some of the near abilities, which the other lenses are able to address pretty much similarly. So I think to summarize, because it would take one talk each to talk about each lens in detail, a good refractive outcome is the mainstay of a happy premium multifocal IOL patient, which would address both your spherical and cylindrical errors. Accurate biometry is again the mainstay. So optical biometry is the way to go if you want happy multifocal patients, and all the other devices which I told you about for diagnostics. And attention to details and understanding patient needs is so important. And I think outcomes analysis is again very, very important to keep improving, because otherwise you will end up with a situation. So with that, I'll stop. Sorry for exceeding my time.
Thank you very much, Dr. Gaurav, for enlightening us with all the technologies of multifocal and trifocal lenses which is available. So my question to you is, what's your take on using trifocals or these lenses in patients who have undergone previous refractive surgery? In which subset of the patients?
So Harshul, I was lucky because the power went off just now and I missed your conversation in the last few seconds, and here I'm back. So I think I was lucky that I could finish my talk just before the power cut.
Yeah. So could you hear my question?
No, I could not. I just joined back.
So I was just asking you that in which subset of patients would you like to use trifocal or multifocal lenses in patients who have undergone previous refractive surgery?
So I have only very few patients where I've actually treated trifocals in previous refractive surgery, and this would typically be those patients where I've done a good assessment of the centration of the optical zone and try to see that the well-centered, good optical zone is there, maybe on topography, as well as do an eye trace and try to look for how many corneal aberrations. And also typically I would definitely not touch anybody with decentered ablations or some topography errors or irregular astigmatism, because it'll totally and I would definitely avoid all these in RK patients. I do a lot of RK patients as well, and there I would not want to touch it. So you have to basically look at the central optical zone, and if you have a good central optical zone with minimal aberrations, I would do it.
Dr. Vijay Lakshmi, what do you think is the role of ocular surface in evaluating these patients?
So we get, routine patients also, when we do not, patients are coming for cataract surgery, the dry eye part should be taken care of absolutely. Because we have seen the cylinder values getting reduced or coming to nil point after treating them with lubricants. So that is one very important part I have to convey. The second thing is we must do a topography, very important. Not only just anterior topography, because we are seeing lots of cataract patients also. So that part also should be taken into consideration. So dry eye part is something which should be taken care of. First and foremost, before instilling any medicine, check the biometry, rule out dry eyes, and then only plan for any toric or multifocal.
Harshul, just one more question. And Harshul,
yes.
Let's go to the keynote address.
Yes. Okay. So thank you. Very much.
See, any more specific questions to Dr. Gaurav? Because his power
Dr.
will go
Gaurav,
up any time again.
If patient is complaining of
question from me, very basic question regarding the second eye surgery in a multifocal, the timing. Just last question. And
so off late, I tend to tell my patients to come back within a week or so. I am very keen to operate them because they tend to settle so much better. And I prepare them when I'm implanting a multifocal lens in one eye. I tell them that it'll be great. Even if you don't have much cataract or minimal cataract, you'll adapt much better. And they're quite amenable now. Off late, I see that most patients are so ready to get operated within a week or two of their first eye. So I would definitely want to do it soon.
No, I mean, for people like me who don't operate on such affluent people like you. See, there are some patients who say, okay, we'll wait for 2-3 months and all. So what would be
I would not push them. I would not push them because if the patient is keen to do a surgery, wants to wait for a couple of months, I'll let them do that. I'm not going to push them because, but I leave the question open and I tell their relatives that, if you, if they want great results and this is the best way, but feel free to come back when you're comfortable. So
what sort of glasses do you give?
So I typically would, give them, initially I would definitely give them plano in the other eye, in one eye, and then maybe progressive in the other one if they have a significant error. And very often, if they have some cataract, I don't change it for them only for the other eye. I tell them that either use a plano or continue to use whatever your existing glasses, because that way they'll come back sooner to you for the second eye surgery.
Thank you, Dr. Gaurav. Harshal.
Thank you so much, and thank you for having me.
Thank you so much, Dr. Gaurav.
Thank
and
you,
now
sir.
let's move on to the keynote address of this session, and that is by none other than Dr. Khokhar sir, and he'll be going to speak on the use of iris glow lenses.
Yeah, thank you, Harshal, Srini, and Gopal Pillai. Okay, so let me share the screen. I don't know, it's not trying to. What's wrong here? Are you allowing me to share the screen from the other end, please? Once again, I'll cut it, cancel it, and go again. Okay.
Dr. Harshal, can I ask you a doubt meanwhile?
Yeah,
sure.
See, we have young patients with fuchs iridocyclitis. So would you recommend, they come for multifocal IOLs. Would you recommend, sir?
No, usually I try to avoid, because we know that they can have the recurrent attacks of the fuchs anytime. So I usually discourage them from going for multifocal or trifocal lenses. Yeah. Was that PIP? I
don't know why it's not
Dr.
sharing.
Khokhar, can you share?
Yeah, one second.
Okay.
Yeah, I'm trying to do that, but this one is actually stopping my mic when I'm going there. No, I'm there. Can you see my slide?
Yes.
Okay, so you can see my slides, right?
Yes, sir.
Perfect. Okay, so after so much of talk of technology, which you can buy, you have eye trace, you can have pentacams, you can have optical biometers. Well, what happened? And the premium lens, of course. So what is the premium lens for a patient who's a spherophakic or who's a Marfan's, who's got a very thin sclera? So answer is none of these things going to work there. So we need to have a lens which goes there and stays safe. So what can you do? You can put an iris claw lens, you can put a scleral fixated IOLs, or you can put a AC lenses when there's no support of the sclera. So especially if your sclera is very thin, the SF IOLs also go out of the window. So you're left with the iris claw and AC lenses. And we'll be discussing how the things are going to work out in favor with the iris claw lenses. So with that, I'm going to open this keynote address. I'll be covering this talk under 3 headings, basically. First being the aphakia management, which is what I talked about, insufficient capsule support. You had a mishap, you couldn't put the lens, or somebody outside in a pediatric cataract has done a lensectomy, he's eaten up the entire bag, including the posterior capsule. So there's no support. Second could be refractive correction, because that's where these iris claws started earlier. And third is the last thing, which is the most important, is all these patients, like Gaurav said, he's doing lots of RK patients who are coming back for cataract. We started getting patients with the iris claw, which were done about 20-30 years back. They all come with a cataract. So if not you, then maybe your son has to operate on these patients if he's running on the same practice, because this is what's going to happen. This is what is going to be a problem now. So everybody who's putting these lenses should be able to take out these lenses without causing collateral damages inside the eye. Okay, so let's see what all you can have. You can have AC lenses. Well, all the cornea surgeons will throw a fit because they say it's an endothelial damaging. Glaucoma, there's a chance of extrusion of the haptics. We've seen so many patients. We done a study here about 5 years back in which we realized if your sizing is good, there are only 2 sizes available in India, that is 12.5 and 13. So if you have good sizes, say your eyes is between a 10.5 to 12.5, you can go ahead and do either of the lenses. But if it's more or less, then it's not indicated for the AC IOLs, which are not bad lenses, but if you use them properly, we have seen patients with 30 years, 35 years follow-up with the AC IOLs doing absolutely fine without extra damage to the endothelium. There could be SF IOLs, the second group. There could be suture erosions, haptic erosion. There's so many complications which can happen. It's a steep learning curve. And especially if the sclera is thin, it's a contraindicated again. Then comes the pre-pupillary iris claw lenses. Now, we started doing retro iris claw recently, about 3.5 years back. Before that, we were not doing the pre-pupillary because all our corneal guys used to say, if you have a corneal lens on the iris, that's the cause of the endothelial cell loss. So we'll be discussing that also. And mind it, this is the easiest surgery to perform. You just put the lens in and just clip it on, and it comes out in a few seconds. Your surgery is over. So let's go and see what happens. Now, iris claw, as you say, was introduced by Jean Wurst, and he's a Dutch person who made these lenses in 1978 to correct the aphakia. So it's a lobster claw. You can see the picture there. So the claw is there, and the tissue goes in between and gets caught, and you can see the position of the claw changing from the side up to make it easier to operate. Now what we're doing is, I'll come to the design later on, and these all have 10-degree angulation. So that means when you're putting the lens on the iris, front of the iris, the convexity is facing to the back of the cornea, and you're putting it retro, it goes upside down. So it can never have a pupil block. So that means if you put it a retro fixation, you don't have to do a PI in these patients. Okay, so these are the lenses which we used over the last 3 years. Artisan lens is the one which is the basic lens which was available to us, which is Optec company from the Netherlands. The beautiful lenses, but the problem was not all the powers are available to us. And at the last moment, if we wanted to change the power, we didn't have any inventory of these when they were expensive lenses. And so we switch over to Indian lens, which is Lensai. No financial interest here, but these lenses I realize are pretty good, and the design is more or less similar to what the Artisan was offering us. And if you're doing a anterior to the iris, the A constant is 115, whereas for the posterior, it goes about a 2.5 diopters more. So this is what the lens looks like. So basically, at the end, you have a claw, and so it means that either you have to have an opening which is at 0-180, 3 and 9 o'clock to put the claw down, or you make a little angled opening superiorly and come down. I'll show you that during the surgery, which I'm going to be showing you. So, okay, so this is what the iris claw lens looks inside the eye. You can have anterior fixated or posterior. This is a retro fixated, and you can see the eye. This is maybe after a year of the surgery, and you can see the eye looks so quiet. Okay, so if you see the literature between the pre-pupillary, so basically the work started about 15 years back when Semina et al. Has started doing work on the pediatric traumatic cataract unilateral ones. And they had this 5 eyes in which they followed for 10 years. And this was one of the biggest landmark articles in JPOS. They found out that the endothelial cell was pretty high in this one, 40%. And they attributed majority of them that to the trauma which had happened before the cataract was formed. So, and one of those patients had an RD in the follow-up for 10 years. And the second study, which Semina et al., which published in JSCRS, which these both all are retrospective studies in which they seen the data and they come out with that. And we did a prospective study, which is still going on. I'll be telling you about that later on. And this, they had 20 eyes in which they had cataract surgery done. So there was no trauma. There was no extra factor which was causing the endothelial cells to go down. And they put the anterior iris claw in these bilateral cases, and they followed them for 13 years. So this is the longest follow-up which has been seen in the eye with the anterior chamber lenses. And they realized that this mean endothelial density was pretty good even at the end of 13 years. And it was comparable with the age-matched people in that entire cohort. So meaning that hardly there was any dropping of the endothelial cells. The third study with Gulat et al. Also found that the endothelial cell loss was about 10.9%, and CME was seen as 2% of these 2 cases, sorry, not 2%. Okay, so this is what anterior claw actually looks like. Now this was other eye was operated with the IOL. This adult patient, and this eye there was no lens, and somebody had done a lensectomy, maybe had a rent, and they took the nucleus also out. So this is what they came to us. So now the challenge was what to do. So we put an iris claw. This was anterior fixed. This is the only video I found of the anterior fixed iris claw because we're not doing most of them. And you can see there's a patch of the atrophy on the iris on the left side. So incision has to be 5.2. In case you want to avoid this bleed, you can always make a scleral flap and a conjunctival flap and do a cautery there. So in this case, we were not sure we were able to enclave it. So we went there, and once you hold it, you see your lens has to grip in, and you see my incision which is coming from the side, and we just take the tissue in a grip and we go put it there. Now you notice there's some bleed which is going inside. Don't worry, we'll be doing a PI in this patient and we'll taking the bleed out and the other side. So this was the only video of the anterior fixated I could find. That's why I wanted to show you that this is what we used to do earlier, and we're not doing it anymore for the last maybe 3.5 years now. And again, the other side has been enclaved and put in, and that's about it. So that's what I was trying to tell you. This is the quickest and fastest surgery. So then you need to put sutures. Once you've done a suture there, then you can go ahead and do a PI, and from the PI also you can go and take out this blood. Since the iris lens is anterior, you can easily go make a PI. And for the cutter, you see what I've done a PI, and I've gone through the opening and I've taken out all the blood from the back. And this patient on the first post-op day was 6/12 vision unaided, and he was very happy because he was FA kicked throughout his last 3.5 years. Okay, now this is what is a retrofixated. Now, this is our technique of doing an interlenticular aspiration. This is a child which is 6 years old with a subluxated lens. So I made make an opening into the lens all the way because I want to sacrifice this lens anyway. So rather than cutting straight away and letting all the cortex fall into the vitreous, what we do is we do an interlenticular procedure in which we actually go inside the bag. We aspirate it inside the bag, so the fluid and everything is going inside the eye and we're coming out, aspirating it out. So once you've done that one, you put a Helon, maybe a high viscosity methylcellulose on the surface, and the section has to open 5.2. That's the only problem. This lens is rigid. All these lenses are rigid. Now you see what I'm going to do. I made a 5.2 opening, and then I'm making a side port. Now this is a side port which is important because your claw is at 180 degree across. It's not superiorly. So you have to have an instrument which goes straight in. I'll show you what I mean again, because once the lens goes in, I dial it into the place where I want to park it eventually. So on the surface of the iris, it goes there, it sits there. Now I'm going to hold. My right hand is holding, my left hand has got a bent needle, which is a fixed needle with a fixed angulation. And I go behind, I lift up the lens, and I see the impression from the back and tuck it in. And that's about it on the left side. Similarly, coming with the other hand, my grip is in the left hand. This forceps is very good because hold is very firmly. So if you can't hold it firmly, you see it's coming up, you can see the impression and lens goes in. And that's about it. The lens looks decentered because the pupil is not that constricted down as compared to up, otherwise it's properly centered. And that's what it looks like, and the surgery gets over in a jiffy actually. Okay, now if you want to see the literature of the retropupillary iris claw, it won't be complete because we are not the only one who are doing, there are lots of people who are doing. Brand et al. Has done, Hindelberg brand has done something, Negretti has done his work, and Frolini has done his work. So if you compare these ones, the common thing which they found out was that in all these ones as compared to the anterior, the endothelial cell loss goes down. Yes. In certain patients, they have transient uveitis, which happened in our patients also. And there's a disc inclination of the IOLs also. So anybody who says he doesn't have a complication or disc inclination is not telling you the right thing, because you can't be very sure of the disc inclination on either the side. So I'll show you certain videos showing those also. So if you notice this data in this side, and all these patients, or majority of them, were actually very happy patients, and very few had very few complications. Okay. All right. So if you see the endothelial cell count with our study versus the other one, we realized that in study we had a 2.8% count as compared to the Gunnerman study, which was 6.4, and there was another study which said 0.99. So it varies from 1% to about 11%. So if you're somewhere between 4 to 5%, you're pretty good at. Good. So our study was an epispective because due to the COVID, we can't give the entire 3 years because the residents were not there, patients are there. So we picked up the patients from 2019 till August 2020. So all the data was retrospective, and the next one, the next group which we recruited was a prospective. So this was one of the only studies which had a prospective arm also to RS fixated lenses in pediatric cases with insufficient support. So this was a study design. I think we'll skip it. So only 4 out of the 15 eyes had disc innervation, 2 spontaneous on the table itself, and 2 were traumatic ones. So I'll tell you how we managed those one, and then I think we'll be over. So if you notice this on UBM in this patient, now this patient came to us about 6 months. These 6 months, this was about 8 months after the surgery. So you can see this lens in the front, and that's what you can see on the UBM also. And the other one is also disenclaved. You can see it, the lens is off the center, but the other side is very firmly attached. So how to go about these ones is what I want to tell you. And once we fixed them, and they were all 6/12 or better, even on the first post-op day. So this is one eye in which the thing was entangled and dangling downwards. Okay, so UBM shows that it's attached on one side. It was attached on the nasal side. So I'm going to make a trocar entry on the nasal side after I'm making 2-port entry. I make 2-port entry only because I'll take a smaller forceps and hold it. I go with the trocar, go parallel to the sclera first and then go posteriorly. So with that, the trocar, what you see, what I've achieved it, I have got the lens elevated. Okay, so you'll be seeing it now. The lens is elevated. You can see the lens is elevated. It's coming anterior. And then I go with the forceps from this side and hold the lens and bring it in front first. Okay. So I hold this lens. Ideally speaking, you should enlarge the section and hold with a bigger forceps to get a firm grip. But here, since the trocar also was at the support in the back, we thought in case it slips out, we can always lift it up. And once I went in, and I could see the inclination there, and I could leave it, and the trocar comes out, and this is what it looks like. So you don't have to create a panic in these patients. You can manage it, these patients, pretty well. So this was one of the patients of the thesis. So I'll tell you the things, how it happened and how we handled it. And if we can do it, we've been doing it plus 3.5 years. I think any of you, you're a very good surgeon, so you people can all manage it. So it's the technique I'm teaching, and not the technology. Technology, there's hardly any technology in this one. Okay, so this was the technique we published also about a year back, and it's quite appreciated all around. So anybody who's doing inclination should be ready to use this technique for a re-inclination if it comes. Now this is a patient in which, now you see what happens here. All right, so we started, so one hand gone in, the left side lens is going in, gone in. You can see the impression against the iris, and it's not tucked in well. Tuck in well, one. Now it's tucked in. Okay. Now you notice what happened to the other side. Other side, sometimes if you are tucked once and you're not sure and you want to tuck it again, sometimes you actually untuck it. So this is what happened in this patient. This is on the table live. So I tucked it, and suddenly I realized, no, I haven't done it. I did it again. So I actually opened the claw again. So that's how easy it should be to take it off if you want to take it out later on. So you see the lens is dangling here. Now again, here, since my upper incision is totally open, it's 5.2. So I went with a small forceps. I have to hold it and bring it anterior to the iris again and start again. So I bring it anterior, and that's it. Once it gets disenclave on the table, people normally goes a little small, but there's nothing to panic. It's a stuck tissue which can actually be pulled a little bit and can be stretched without causing any issue. Now again, you see I held it. Now you see how firm my impression going to be. See the impression of the entire lens there. You can notice that. You can see the entire impression of the lens. Then you tuck in, and I'm good at it. Then I can switch it up and finish it off. Okay. So now if you compare pre to retro comparative studies, now there are three studies in which they have done 5 years in the first 2 studies and 6 months in the last study. And this all talk about little ovulization, which we also had in our patient on the first few days in 1 week with the ovulization. But over a period, once the pupil dilates and constrict, I think it gets released and become round. And 90% of the pupil by 6 months are all round and reacting to light. And you could dilate the pupil and see the retinal periphery also, which we had one of the retina colleagues to see the retina to see if there's a problem in because of the edge of the lens. They couldn't find any. But they had more problems in patients with a multifocal with the rings rather than having with this one. Okay, so now. These are the 3 different studies which have been published recently. So let's go back to the one in which now you've done the iris claw and the patient comes to you for refractive things. So how can you remove these lenses? So we published a technique in which we did the entire surgery with the lens in situ, because these artisan lenses were used and they had a big claw and they had a very thick claw rather. I mean, the phakic claws are not that thick because you're putting on the posterior. These claws are very thick. So what we realized that we could do all the hydro, air, dye, everything under the lens. Even the rexis could be done. Even the hydro could be done. And when we put the probe inside the eye, the probe went in, but it was pushing the lens a little anterior, but it did not disenclave. Am I audible to everybody? Somebody's voice is coming from the other side. Srini, it's all good?
Yeah, good, sir. Good, sir.
Okay.
Perfect.
So I can do the rexis. I can do a 2.2 now because that's what the machine allows us. I do the hydro. The only step I found here was that because I'm using a Phaco and a chopper, I could have put a chopper first and stabilize the lens and then put the probe in. Now see, when I'm putting the probe in, this you learn when you have done few patients. Now you see it's going away, but it did not disenclave. So that's what I was trying to say. So if I'd just put maybe a thinner sleeve, or without a sleeve also, I could have made a groove and then gone in with the sleeve. So, but I could manage it later on, because once my chopper came in, the things were quite well stabilized. You can see the lens is stable, and you use viscoat on the top under the endothelium and Helon on the undersurface. So you have a soft cell technique. So, and this is a soft cataract, because all these myopes will not have that much cataract, that harder cataract. And once I've done an IA, I could actually aspirate all the cortex, Srini, from this back going behind the lens. And then we put in Helon GV, not a plain Helon, and we put in an implant also inside the eye. And this was the era about 15 years back when I was using these yellow lenses, but we have switched over to most of the clear lenses now. So that's how the lens goes in. See, I could have opened this claw earlier and then put a suture and done it. But then one moment you open the claw, the pupil will tend to die onto you, and they might go small, and you might have a problem during the phaco. So once I'd done this, I went and disenclaved the claw. See, it's so easy to disenclave, yeah, and from the other side also. And after this is a small video which a lady has come from Canada all the way. She had iris claw lens done in India about 30 years back. Nobody was willing to remove the lens there to do the surgery. So I just did it last week. I'll go show you the last one. Now, even if the pupil goes small, Srini, it's not going to make any difference to me, because my surgery is already done. I'm going to enlarge the section from 2.2 to 5.2 and take this lens and put a suture or two, whatever it desires. But my cataract surgery has gone as I wanted it to happen. Okay. And then put a suture and make sure the chamber is good, and then you can go and aspirate and then finish off the surgery. Now, okay, now people have use femto. They use a FLACS to make a rexus and do it. But once you put your probe inside, I think that's the time when you realize the space is less under the lens. Okay, so this is a surgery which was recently done. This lady has come all the way from Canada to get it done. So what we did was, now see, my side ports are opening at the angle because I want to disenclave. And since they're 180 degree across, the disenclavation happen only once I come either from that side or I come from superior with a needle which has a bend. So now I'm putting a viscoat first and then the Helon. Now see, I'm coming and holding the lens. Always hold the lens, otherwise this lens will move and hit the endothelium. Your main aim is not to let the endothelium get damaged. Now see, I have disenclaved one side. And we put this patient on a Fleur eye drops. I use the Moxicip KT 3 days before, so that the pupil doesn't die on me. And this pupil was very well dilated in this case. And you see the other one also go and that's about it. And once this lens is out, you can suture it up and do the cataract surgery as you would run any other patients. So I'll just skip this one, and this lens can be taken out. And of course, you can do a surgery or a clear lens. Anybody can do that. Okay, now to conclude, I want to say that the retrofixated IOL is a very safe and effective approach to manage aphakia in absence of capsular support. Now we're using the lenses with the claws which are not very firm, so we can have more companies coming out with the claws which are more firm, like you saw the artisan lens, and the retro will become as safe as the anterior one with the added advantage of not losing the endothelium. It's a very short learning curve, especially for all these surgeons. They can actually manage it very well. The last thing which I'm saying is you have to be familiar in handling of these lenses, because all these patients who have been done earlier, and they're not few, there are lots of patients who are coming with RKs and who are coming with operated phakic lenses. Maybe you haven't done it, somebody else from the other states have done it, and they all will come to you. And if you can manage that, for that you have to be prepared by using this, getting used to these iris claw lenses. And thank you very much. With that, I'll conclude my keynotes. And if there are any queries I can answer, it's all
Harshal, you'll agree that he has the best hands in India, right? So you're going under the iris flow lens and managing it. Harshal, see, we'll have to wind up the session early because Dr. Mahipal is supposed to join at 7 o'clock. He's got a physical meeting at this thing. We will have the discussions. Sir.
Yeah, it's okay. I mean, even that Phaco part could have been avoided if I'd gone with my chopper Asinski earlier to support the lens. That's what I told you. You can try it. If it doesn't happen, you can always remove it. So these are techniques I'm teaching you, not the technologies. Technologies you can buy. You all are rich people. You can buy technologies, right?
Mahipal sir, your comment on that video, you saw it?
No, I didn't see it. I just joined.
Okay, no issues. So, I mean, Harshal, we can do one thing. Sir has a presentation.
Yeah, I think let's take Mahipal sir. Yes.
Let's finish off Mahipal sir's presentation, and then we'll continue with the session. JP sir, is it okay?
Yeah, sure.
Okay, but who is going to introduce Mahipal sir?
Dr. Divya.
Yeah.
Dr. Divya.
Dr. Divya.
Yeah. He's there.
Can you please introduce, sir?
Move on to the third session, where we will be discussing Phacoemulsification in difficult situations. The chairperson for the session is Dr.
No, Divya. We just going to do Mahipal sir's presentation. We'll just go back to the previous one.
Yes, sir.
Just do the. Yeah.
Yes, sir. For the keynote address today, we have with us none other than Professor Mahipal Sachdeva. Sir requires no introduction. He's a chairman and medical director of Center of Sight. He's a renowned cornea, refractive and cataract surgeon and a pioneer in India of phacoemulsification, phakic IOLs, and femtosecond laser technology. He has adorned various posts as president of AIOS, president of DOS, chairman scientific committee of the AIOS at the young age of 38 years, and he was also the member of the governing council of Delhi chapter of Red Cross Society of India. He has conducted courses and has presented over 150 papers in various international symposia and has over 100 published articles to his credit. He has authored over 10 books on cataract and refractive surgery, including the first book on phacoemulsification by an Indian ophthalmologist. He is recognized globally with fellowships and scholarships from Japan and USA and has received numerous international and national awards, including the Lifetime Achievement Award of Ophthalmology. And he was awarded Padma Shri by the Government of India in 2007. We are proud to have you here today, sir. Now over to you for the keynote address.
Thank you very much, and sorry for interrupting in between. I have another lecture at DOS at 7. So thank you very much. I think I have already sent the presentation. If you could play that on WeTransfer or you.
Ankit, are you there?
Yeah, I think.
Good evening, friends. I'll be talking about femtolaser assisted cataract surgery for difficult situations. Whenever you look at a new technology, I would say that the new technology should work in regular cases, as also it should simplify the challenging cases. And that is what is very, very important. Then whenever a new technology comes, can we challenge our limits with this new technology? And this is, I am going to show few videos and particular situations wherein the femtolaser assisted cataract surgery has been used to simplify challenging cases. Now let us look at the first situation, which is a posterior polar cataract. We all encounter posterior polar cataract, wherein you can see this onion world ring. You can have a deficient posterior capsule in about 30 to 40% of these posterior polar cataracts. And this was a nightmare for any of the cataract surgeons when we were doing phacoemulsification, where one could have a nucleus drop. Now, the problem with the polar cataract is that there could be pre-existing weakness in the posterior capsule. And when you do a cortical cleaving hydrodissection, this can cause a hydraulic rupture of the posterior capsule because of the pre-existing deficiency. Now, in case of a femtolaser, you don't really need to do a hydrodissection, because what you get is an automatic pneumodelineation that happens. And this eliminates the use of fluid for forceful hydrodissection or delineation. Furthermore, you get a great capsulorhexis, and the nuclear disassembly becomes much easier because you can have pre-chopped nucleus. Even concentric rings that have been defined, they can help you get pre-chopped nucleus, and it is very easy to remove this. Now, the most important thing in a femto is the use of the anterior segment OCT, which is something which is inbuilt into every femtolaser machine. And this high definition anterior segment images would delineate both the anterior and the posterior lens surface. And you can easily detect the possibility of pre-existing posterior capsular rents, and therefore you could customize the offsets that you have and leave behind an epinuclear cushion in these particular cases. So see here, this is the bubble that you have. You are actually removing the offset, as you can see, from 500 microns. You have kept it to a much higher degree. Therefore, you will have the epinuclear cushion that will remain with you always. Now, our group has reported this, that the femtosecond laser integrated anterior segment OCT can help you give a great specificity and a sensitivity to detect pre-existing posterior capsular rents, and this can be used to increase the safety margins for all posterior polar cataracts that you have. Now, this imaging helps you see and to prepare for any problem. So let us see this particular case where you can see that there is a pre-existing defect that you can see on the slit lamp. And what we are doing in this particular case is a femto-assisted procedure. So you can see that this is the pupil that has come into view. This is the limbus that has come into view. And this is the anterior surface of the cataract, as you can see. And watch here, this is the posterior surface of the capsule, where you can see that there is a pre-existing defect, which is very, very clear. It's a large pre-existing defect you can see here. So what we are going to do here is that this default setting that we have, we are moving it up so that the nucleotomy that is done is going to leave behind this epinuclear cushion. So can you see that epinuclear cushion that has been left behind? This is a great capsulotomy that we have had. We have made it into 6 quadrants, as you can see, and this is the end of the picture after the procedure has been done. Now let us look at the OCT, which you can see intraoperatively. And this is the microscope integrated OCT, where you could see that there is a defect. And because of the nuclear disassembly, we were able to remove the entire nucleus with an epinuclear cushion sitting here without disturbing the posterior aspect of the capsule where the defect is. And you can see that it is only towards the end of the procedure that we are getting this defect into play. And you can see that this is a vitreous blob, which is still not changed, which is there. And you can go ahead and put the intraocular lens, and this is the post-op picture that you have. This is the photo essay of the same patient that has been reported in Indian Journal of Ophthalmology. The slit lamp picture showing you a posterior polar cataract along with a pre-existing defect, which you can see is very, very clear, a vertical pre-existing defect, which is going up and down. And this is the microscope integrated ASOCT. Even the IOL Master 700 is showing you the defect in the posterior capsule. But the main advantage of FLACS is that when you do the in vivo imaging, you can easily take up the nuclear disassembly and leave behind a huge amount of, you can see this huge amount of epinucleus that can be left, which will allow you to do a safe phacoemulsification in these particular cases. And this is at the end of the procedure. You can see this is the vertical defect that is there, and this is the globule of the vitreous that is coming. So therefore, to sum up posterior polar cataract, all that I'll wish to say is that the posterior polar cataract, when you are doing femtolaser assisted cataract surgery, you can leave behind, after direct visualization, an epinuclear shield, which acts as an armor for you. You don't need to do any nuclear rotation because of the pneumodissection that is there, and you can have the surgery right till the end without the capsular defect coming. And this is just like you can crash if you don't have the airbags, and the femto is like an airbag, and you can come out safe with the femto laser in a posterior polar cataract that you have. Now let us look at another challenging situation, that is in small pupils. So what has been shown is that you can actually put in a Malyugin ring and go back and do the femto laser assisted cataract surgery. I'll just show you in the video. So you can see here, this is the incision that is being created. So because we are going in first for making position for the capsulotomy to be done, you can also reduce the capsulotomy size up to 3 millimeters. But if the capsule is pretty, if the pupil is pretty small, it is better to go in with a Malyugin ring. And now you can see this is the Malyugin ring, and this is a subluxated cataract, as you can see. One is doing a good capsulotomy. There the capsulotomy comes into view, and the nuclear disassembly that comes into view. And this is a good 5.5 millimeter capsular access that one has been able to get. Now let us look at phacoemorphic glaucoma. When you're looking at phacoemorphic glaucoma, the pressures are high. This is a medical doctor who came to me a couple of years ago and had a lens-induced glaucoma that was there, and this is the LensX system that we are going to use. The important thing here is that you are seeing this is the iris coming nearby. You can see this is the LRI that we are planning. Very minimal space between the iris here and the capsule, and you can see that this is iris and the posterior part of the cornea, and you can see that there was a huge amount of lenticular fluid that came out. But since we are doing the capsulotomy on a closed chamber, that is very, very important. The capsulotomy is done on a closed chamber. You are able to get a good capsulotomy, and the cataract obviously is soft and you are able to take it away. Now let us go on to the next level difficulty, which is rock hard cataract. So this is a cataract which I would say is a grade 5 cataract. We did a slightly larger capsulotomy, and you can see, just watch these bubbles coming out. So when you see these bubbles coming out, look at the black cataract. The cataract is broken into small pieces by the femto laser, and the amount of phaco energy that you need is significantly reduced. As you can see, it falls by about more than 50%. And one is able to emulsify all this with the femto laser, having pre-chopped the nucleus, which is very, very good. Now let us come to the next situation, that is post-traumatic subluxation. Even if there is vitreous here, if you were to do a manual cataract surgery and you were to do a capsulorhexis, there is no tension here because of the zonules, and it becomes very, very difficult for a person to do a capsulorhexis. But with the technique of femto laser, even if the vitreous is there, which I am going to show, you are able to work and do the procedure of capsulotomy very well. We have also described limited pars plana vitrectomy for optimizing surgical outcomes in subluxated cataract using the femto laser assisted cataract surgery. So I'll just show you what exactly we mean by that. You can see in this particular case, this is the subluxation of the same patient that I showed you. You can see that the iris going back. Here you can see, if you look minutely, you can see the vitreous blob. This is the vitreous blob that is there, which is seen in this particular case, which is very evident. And now let us see how we are going to proceed with the case. We'll have to, because of the subluxation, you have to customize your capsulorhexis. You are seeing we are going on a custom center of the capsulorhexis. And mind you, in this particular case, I have not shown you the femto procedure, but you can see through the vitreous it has cut. You have got a very good capsulorhexis, and we have got 6 quadrants that we have made. Now what we do is that through the pars plana approach, we will gently go in. We have injected tricot, and we will go in, and you can see that we are removing the vitreous, which is going on to the towards the cornea. So what that helps us do is that the vitreous will not get hydrated. We are putting an endocapsular ring so that the defect becomes less. And because of the femto pre-chopping that we have, we are able to remove the nucleus much easier than we would have if we were to use a phacoemulsification. Obviously, alone, obviously the parameters that we have set are low. And you can see that this is the irrigation aspiration that is happening, and the stability of the entire capsular bag is there. Now what we will do is, without injecting viscoelastic, without taking out the fluid, we have been able to inject a good lens, and you can see that we can again go in and remove the rest of the vitreous which is there. And this is the post-operative patient that you have, post-operative scene of this particular patient getting good outcomes with femto laser assisted cataract surgery. So friends, this is what I will wish to say. I've just shown you a couple of cases where we are using technology of femto cataract, and it has evolved to find widespread use in complex cases. I would say today that the penetration of femto, at least in metros and in tier 1 cities, has gone up significantly. And apart from the routine cases where we can see that we get repeatability in the hands of even less trained surgeons, and the phacoemulsification procedure becomes much easier if we have a pre-chopped, pre-capsulotomy, pre-incision, and the LRI correction with a femto done. So I personally feel that it's time to take the leap of faith and switch over to the power of femto, wherein you can take care of the complex cases of cataract surgery and make them simpler to do with the power of femto laser assisted cataract surgery. Thank you.
Good evening, Dr. Mahipal. Good evening.
Good evening.
Thank you for being with us today. I know you are very
My
busy.
pleasure. No problem.
Shall I let you go?
No. I have 5-10 minutes. You can ask me any questions.
Sir, before you come in, like anyway, sir didn't see Dr. Khokhar's video. My question to Khokhar sir, would you advise me as my teacher? Would you advise me to go and buy a femto laser unit?
Wow, that's a great question. You just had a talk from no other than MPS. So yes, you see there's certain cases, if you have white cataract and a posterior polar where you think things can go bad, it may come to your rescue. But at the same time, till the femto becomes so refined that you don't have to you just have to go to the probe and suck it out without doing any chopping and all those. Your technology cannot never take up over techniques. So technology you can have, it can help you, yes, but you can't ensure that all your 100% white cataracts will be okay. You still can have tags left around, you can have problems running off. So nothing is perfect yet. But yes, if you have money enough to go and buy it, yes. But if you're a good surgeon, I don't think you need all these gadgets, as of me.
Exactly, and that is what I wanted to say, Dr. Srini. This is one question I wanted to ask Dr. Mahipal. Femtosecond laser-assisted versus manual phaco cataract surgery, FEMCAT, the multicentric participant masked randomized superiority and cost effectiveness trial. The interpretation of this study was, despite its advanced technology, femto was superior to manual phaco in routine cataract. No additional benefit either for the patient or the healthcare system. What is your opinion, Dr. Mahipal?
So I think the same thing was said about refractive surgery, that when you're using a mechanical microkeratome versus the results of a femto assisted the safety factor that it brought in was much higher. So what has been compared is actually trained phaco surgeons versus femto surgeons, which I think is a technology that is still, I think it is evolved significantly, but the comparison is with people who haven't kind of really use that technology very often. The first important thing is that if they might be talking about the insurance system, etc. But when a patient is willing to go in for precision, for accuracy and repeatability, I don't think that we should not we owe it to the patient that the patient can make a choice. Today, as things stand, at least in my personal practice, 70 to 75% of my cataract surgeries are done with the femto laser. And there is a demand by the patient to go ahead and do it. And I have therefore definitely shown you, deliberately shown you difficult cases where, as Dr. Khokhar also agreed, that there is the place for the femto cataract, which definitely makes it much superior. So we can leave the choice to the patient if the patient is willing to pay. And if you have a practice, what Srini asked was that if you have a practice which is large enough and there are large enough patients who are willing to pay for the additional safety. See, why do you travel in first class and why do you travel in business and why do you travel in economy? That's exactly, I would say that it's the same plane which is going to take me, if I have to take a flight to anywhere, LA, New York, anywhere I have, it is the same plane, the time taken will be the same. But you still may be paying 4 times or 5 times the amount in a first class as compared to economy class. So therefore the choice is...
I want to ask you the second question, Dr. Mahipal.
Yeah.
Dr. Shannon Wong, MD, who is a senior consultant from Austin Eye Center, the US, came live in YouTube. He's one of the pioneers of femto cataract surgery. And he has done more than 3,000 femto cataract surgeries, I think, on the Alcon machine. And he said, femto laser, after 3,000 cases, he said, femto laser is simply not necessary for safe cataract surgery. Patient is worried only about the visual outcome, not the technology. And he says his femto cataract surgery numbers he has brought down personally from 97% to 5%. So, Dr. Mahipal, will you stop using femto for routine cataract surgery? Yes,
No, I will not, because of the simple fact that that study is again flawed. And the flaw is that he says that the time taken for the procedure goes up. I personally feel that if you have somebody who's helping you outside, which we have in large institutions, you can actually have two different people doing the two sets of things, and the amount of time that you're taking for doing a femto procedure actually goes down. The Phaco after a femto procedure, that is going down. So I think from economies of scale, it has made me much faster than what I was before. The throughput has increased significantly, and the outcomes have gone up very significantly as regards the 6/6 patients getting on to 6/6 vision. There can always be hidden reasons for individuals going to say that femto is because if he's a single practitioner and he has to do both the things and the patient has to move from one to the other, maybe the time taken obviously would be more because it's a switchover. But if you have two different people working, the time taken is much less. And I have always felt that technology which gives you repeatability, which gives you safety cushion, which gives you precision, which gives you accuracy. I agree that in a trained phaco surgeon's hand, the outcome may be the same at 3 months down the line. You can't do an LRI with a phaco. That is another additional advantage that you have. And there are several people who know that if the incisions that you are making, they are more watertight than in a phaco. So I would not go back from phaco. I am pretty sure about it. There is a significant growth of about 30 to 40% year on year. After the COVID, more people are going in for premium procedures. The same thing we heard when I started phacoemulsification. There was so much of bashing of phacoemulsification that it said, why does a patient need early visual rehabilitation? There were even articles in newspapers which said that phaco is bullshit. Okay, so I personally, we stood our ground and we said that yes, phaco, and today phaco, again, you can have the same conversation about SICS versus phaco, that at the end of 6 months or at the end of 1 year, SICS could give you as good results as phaco. But if I have yet to see any ophthalmologist getting an SICS done on his eye when he has the availability of a phaco surgeon, and I've yet to see ever since I started femto an ophthalmologist coming to me and saying that, sir, do a phaco and not a femto. So that is where the proof of the pudding lies, that ophthalmologists, when they have to trust their eyes for surgery, they are preferring to go in for a femto even today, despite these one-off articles that keep coming, because cost at the end of the day.
Mahipal, I think I will thank you for being with us, even though I may not totally agree with you on all these points.
Sure.
But one last question and I will let you go. 10 years down the line, what do you foresee in cataract surgery? 10 years down the line?
Maybe some eye drops.
Thank you, sir. Thanks a lot.
Thank you.
I know that
Thank you.
Thank you so much, Dr. Mahipal.
Thank you.
Khokhar, sir, he had... Khokhar, sir, is still there?
I don't. Okay, thank you very much.
Okay, thank you.
Great. Bye. Thanks.
Thank you so much.
Thank you.
We had a lot of questions for Dr. Khokhar, but he also was busy there. Is he still there? It's okay.
Marshall has to finish his talk, Srini.
Yeah. No. I mean, we should have had more discussions on iris flow. Anyway, Harshal.
Yeah. Thank you so much, Srini, for giving me this wonderful opportunity. So I'll be talking on the toric IOLs. Can you see my presentation here?
Yeah.
Okay, just a minute. Okay. So we all know that based on the current literature, approximately 50% of cataract patients have one diopter or more of pre-existing corneal astigmatism. And so they can benefit from a toric IOL implantation because astigmatism in post-cataract surgery patients, it leads to poor vision. So we need to correct this along with the cataract surgery. So, and now we all know that the acrylic hydrophobic IOL material is the best platform for toric IOLs because of its addition to the capsule and the profound shrink wrap effect which these hydrophobic IOLs give. And nowadays we not only have a monofocal toric IOL, but we also have multifocal and trifocal and EDOF toric IOLs, which can give presbyopia correction along with the correction of the astigmatism. So in today's era, whenever we have a cornea which is regular, so in patients of glaucoma, epiretinal membrane, macular degeneration, and other pathologies also, they can also benefit from use of toric IOLs, but they are contraindicated in irregular corneas and patients who are wearing rigid gas permeable lenses or sclered contact lenses. So if you look at the toric IOL models which are routinely available, so these are the different models which are available from different manufacturers. So the power which is given at the IOL plane, so and this is the power on the right side at the corneal plane. So these are the various models, and till T9 or the 4.1 diopter of correction at the corneal plane is routinely available, then we can of course get the customized toric lenses. And the axis notation which is used is from the left eye 0 to 180 degree, and right eye from nasal side to temporal 0 to 180 degree. That's how we use this notation. So the success for toric IOL implantation, it depends on to measure the astigmatism correctly, its magnitude as well as its axis, and to place the toric IOL on the intended axis, and the IOL has to stay on axis. So success of toric IOLs, it begins from surface. First thing is we need to assess and manage and stabilize ocular surface before surgery. So we need to treat any mild dry eye which is there, manage pterygium which is there, because these conditions, they give inaccurate and unreliable readings. So coming to the keratometry measurement, which is the main important thing in toric IOL calculation, remember that we are dealing with the corneal astigmatism. We don't have to look into refractive astigmatism. Patient may have using 3 diopter of the cylinder on the glasses, but if he has 2 diopter of corneal astigmatism, we just need to take care of that. So different keratometry measurements instruments are there. We can use automated keratometry, topography, sham flux system, or OCT based systems like IOL Master, which gives us the total keratometry. So we need to increase the accuracy, we need to use the two instruments which use different principle, like auto-K along with topography, or auto-K with sham flux system, or like this. And we also need to know the effect of posterior corneal astigmatism, which Dr. Douglas Koch has shown that if we only use anterior corneal astigmatism by these instruments, by auto-K or topographer, or the biometers which use only anterior cornea, in the patients who have with the rule astigmatism, it will cause mean overcorrection of 0.5 diopter, and in the against the rule, it will cause undercorrection of 0.3 diopter. So I'll explain this the role of the posterior corneal astigmatism in the next slide. And coming to IOL power calculation, we all know that we have to use optical biometry, which is best. And if you don't have, then immersion biometry. So coming to posterior corneal astigmatism, we know that posterior steepest meridian of the cornea is almost always vertically aligned. And what it does, it creates against the rule astigmatism, which compensate with the rule. So if the patient has 1.5 diopter of with the rule astigmatism, so basically it is only 1 diopter. And it increases against the rule. The patient has 0.75 of against the rule, it's actually a 1 diopter. So if we only rely on anticorneal astigmatism, we cause overcorrection. And if we use, if it's against the rule, it causes undercorrection. So let's see, then after this, we need to determine our surgical induced astigmatism. So from drhill.com website, we can feed in data from 30 to 40 patients, and then we come to know what is our SIA, keeping our incision location same in the right and left eye, so that we can feed this SIA, this mean and median values here in the toric calculators. And now we have come to the centroid value of SIA, in which essentially the single angle plot, which was previously used, it has been extended to the double angle plot. So what happens is in this is like a phoropter. Against the rule is here on both the sides and with the rule here. So in actuality, the centroid value is basically the magnitude as well as axis. So it has been extended so that now it gets double, and on the left side we have all the with the rule astigmatism patients here, and against the rule on the right side. So this is the plot which shows the centroid value of preoperative corneal astigmatism, which was 1.63, and this is the post-operative refractive astigmatism 0.09. So now coming to the toric IOL calculation. So this is the Hoya toric calculator, which I have shown here. So you need to turn on this Abulafia-Koch regression, which uses posterior corneal astigmatism. And in Barrett toric calculator also, it uses the take cares of the posterior corneal astigmatism. So you need to feed in the flat K, the steep K, its axis, and your surgically induced astigmatism. So this is the left eye is a 0.3, your incision location. And once you feed this data, the toric calculator gives you the option, 3 options. So we need to choose the option which gives us the least residual astigmatism. In this case here, it shows 0.03 residual astigmatism. We need to use the IOL plane 3 diopter toric IOL, which gives correction of 2.08. So this was the 1.81 pre-op corneal astigmatism, and taking into account the surgical induced astigmatism, the cross-cylinder result is 2.1. So this is the cross-cylinder result which we have to look into, that we want to correct 2.1 diopter at the corneal plane. So we need to use 3 diopter of the toric IOL at the IOL plane. And this is another, different companies have their own calculators. Now, most of the calculators, they take into account the posterior corneal astigmatism. This was the paper by Dr. Savini, which said about the influence of axil length and corneal power on astigmatism power of the toric IOLs. So assume that we need to correct 4.2 diopter astigmatism at corneal plane of the patient, and this patient has axil length of 30 millimeter and keratometry reading of 48. So assuming that there is a all the companies, they assume a fixed ratio of 1.46. So we'll using a 6 diopter at IOL plane, assuming that it will give a correction of 4.11. But have a look at this table here, the 30 axial length and 48, the ratio is 1.86. It's not 1.46. So if the ratio is 1.86, it means it gives the real correction of 3.2 only. So we don't get a 4.2 diopter of the correction at the corneal plane. So the calculator which I showed here, Hoya calculator, it gives an option here to adjust cylinder power on corneal plane depending on axial length. So you can use this option here. This is a new calculator which is being given. This is only for the higher axial length and higher keratometry reading. So if you look at the methods, there is a manual marking methods, a conventional 3-step marking, image guided marking method like from Callisto and Varion, or intraoperative aberrometry like ORA and HOLOS can be used. So studies have proved that in a surgeon who is skilled, both the conventional 3-step method and the image guided, both our results are same. So if you need to mark the reference axis 0, 180 degree, or the 6 o'clock also, you can either use ASICO bubble marker, electronic marker, or smartphone apps are also there. But what I love to use is the slit lamp marking. So essentially the patient is sitting straight on the slit lamp looking straight ahead, and you narrow down the slit beam and use a 26 gauge needle to put a scratch on the epithelium. And once you put the scratch marks on the epithelium, these scratch marks don't go away. Even if the ink marks, they fade. So after that, you put the ink mark there, and you have, using this 26 gauge needle, you have thin marks rather than the thick marks. So then coming to the toric IOL implantation. So you go ahead and use the meridian degree gauge here to mark the steep axis where you need to put the orient your IOL. So this is the hydroimplantation technique, which I described in 2010 in JCRS. So you essentially put a irrigation cannula through side port, which maintains the anterior chamber and capsular bag. And the IOL, it goes in the capsular bag, leading haptic and optic it goes. So the advantage is that there's almost no OVD, which has been shown that if you have residual OVD behind optic, it causes post-operative rotation of the IOL. And rexis size is most important and crucial. So here I find that the overlapping is a little more in this case. So before aligning the IOL to the intended axis, I go ahead, give a snip here, and use a micro forceps to enlarge the rexis to the proper size, because you want that IOL to stay in place. And using the bimanual method, using Kuglens hook and irrigation cannula, I rotate the lens to the desired axis here. And Then hydrostitch all the wounds. And see the IOL, it stays in the place. And be careful that just keep on looking at the toric IOL while you're taking off the speculum, and this finishes the case. This is another case which had small pupil. So here you can use Mulligan ring and to so that you get good access to the toric IOL marks here. And after that, you can take off the Mulligan, and you can also check with the equivalence hook, retracting the iris margin. This video which shows the implantation of the Hoya VVNex toric IOL. Again, the IOL goes in the capsular bag. I enlarge the rhexis. So don't leave the rhexis margin overlapping too much. So we may have a refractive surprise after, just I'll take 1 minute more, Shini. We may have a refractive surprise after toric IOL implantation. So I'll just show you quickly one case. This case was referred on 12th post-operative day by one of the colleagues. Had uncorrected visual acuity of 6/36 and best corrected visual acuity of 6/9 with -1 sphere and +2 diopter cylinder at 140 degree. So when I checked the on slit lamp, I found that the lens was sitting at the 10 degree where it was intended. So there was mistake in the calculation. So you can go ahead and do calculation, these back calculation on astigmatismfix.com. So what all you need is to put the current refraction, which is there, manifest refraction. You put in this calculator here, and then this calculator can show you whether rotating this particular IOL will fix this problem or not. So here, as you can see, it showed that rotating the IOL 15 degree clockwise should minimize astigmatism to almost 0.24. So again, you don't need to put OVD. Now here, we need to rotate it 15 degrees. So these marks now act as 0. So I just align 0 here and mark 15 degree clockwise direction here, and go ahead and put just irrigation cannula and go beneath the anterior capsular rhexis margin and just see, try to just rotate the IOL. So this is 12 weeks post-operative, and once you have rotated the IOL to the desired axis, it finishes the case. And next, see the axis, it came down from 10 to the intended axis now, and the patient improved to 6/9 vision. So on slit lamp, you can check the orientation of the IOL, and I think I'll skip all these slides. So success of the toric IOL, it depends on accurately measuring the astigmatism axis and power to accurately locate the axis in the eye, placing the toric IOL correctly, and preventing or correcting any post-operative misalignment. Thank you very much for giving this wonderful opportunity.
Thank you, Harshul. Khokhar, sir. Sir.
Yes, Srini.
Sir, yesterday I had a presentation at TNOA. It's basically on nucleus management. But from the crowd, a young surgeon came up and asked, if I have a problem with clear corneal phacoemulsification, no capsular support, and I want to put an iris claw lens then and there itself, because
yes,
there are practical problems. You might say, oh, it would be better to postpone until everything settles down and do a secondary IOL. But these kids who are just in practice, it's very difficult for them to convince the patients. So would you still?
Yeah, I understand.
So would you still say wait and do it as a secondary procedure or as a primary procedure? Because this is a question which is in the mind of a lot of people.
Okay, no, Shri, the simple answer is if you have the IOL power for that eye with the iris claw, please go ahead and do it. But do you people call a backup iris claw lens when you're doing a phaco? Nobody is calling it because we are so confident that nothing gonna go wrong. But if you have a power of the lens available, you can do it as a primary procedure without any problems.
Okay. Now comes the second question. It's a clear cornel. It's a clear cornel section. You have to extend it at least to 5.25.
Yeah.
Okay. Would you give backcuts and
right.
do it, or close it and go for a squirrel section?
No, I think I'll put the lens from the same one and put sutures, and we can always modify sutures later on. It's always better to, for a 5.2, rather than putting 2 sutures, put 3 sutures, and then we can remove them one by one, depending on the strength and the keratometry. But most of the patient, most of the patient, when you do it on the table, patient will not realize that they put an iris claw lens in the back, and if the things are all good, your vision going to be the same. Good, the next day. Sorry, the third question you can ask now.
Yeah. See, do you do a peripheral iridectomy for all your iris claw lenses?
Only for the anterior iris claw lenses, you need to do a PI. For the retro, as I explained in my talk also, because the lens has 10-degree angulation and you put the lens upside down, right? So the concavity is towards up and convexity is towards backward, towards the vitreous. Then you don't need a PI in these patients, not at all.
But I do PA because I've got a significant number of posterior iris claw lenses. See, I was taught by Dr. J.K. Reddy, and when I said, sir, because I had pupillary block for 1 or 2 cases, and when I told it to J.K., so he said, "Yes, really, what are you telling? That's not needed." But one day he had a pupillary block, and he said, "Okay, so sometimes you learn from your students." So that's
I'll come to that. Srini, it depends on which model lens you're picking up. When I started doing flat, which patient, if your lens degrees, then you don't need to do it. But if you have a flat, there are a certain set of patients in which I'm getting lenses which are flat, which doesn't have an angulation, which doesn't have a vault. If your lens is flat, without a difference in the curvature, then please do a PI. And for the beginners, I think in the first, you just do a PI for the sake of your safety. But eventually, we did it about 6 months. That's about 3 years back. And now we stopped doing PI for all the problems. But your lens has to have a vault. That's what was the model which was.
Yeah. The Appasamy lens has a vault. XL lens doesn't have a vault.
Okay, I haven't used that.
Yeah, and Dr. Ambika had a question for you. Dr. Ambika?
Yeah, sure, please go ahead.
Yes, good evening, sir. So I just wanted to ask. Yes, sir. So if the pupil is very small, in a myosed pupil, is there a risk of sphincter trauma? Would you still do a retrofixated lens for the patient?
Okay. So the dictum used to be, when you're doing the anterior iris claw, always constrict the pupil to as much as you can. Right? That you can actually fix. Please avoid constrict too much. Yeah, if you have too smaller pupil, that very taut pupil for having a tear. Which we have supported the back is open. There's no posterior capsule. So the lenses, actually the iris diaphragm falls back and it opens up a bit. So you can actually manage yourself without much problem. Yes, but there's always a risk if you're not very careful with that. You can have a sphincter tear in these ones. But if the pupil is really, really, really small and very rigid, otherwise it gives in. And you put helons on the top of the iris, with the weight itself, it opens up to a large extent. Okay.
Okay.
You see, sir, the problem with very small pupil with you put a pilocarpine and make it really myos. It's the difficulty in enclavating getting the second haptic behind the iris.
I got it. I know that's what she was mentioning. If once one goes, the other can also go. But the problem here is that don't worry, you're not going to have any pilocarpine available to anybody. In my OT, the pilocarpine finished last week. And
It's come back. I got a new stock.
You're lucky because last week I was having problems. So what I'm saying, now my technique is I don't constrict the pupil till my lens is in front of the iris. So I put the lens in and rotate it. By doing the rotation itself, some pupil goes little to some smaller to some extent. Then only if I see if I need to put pylo, I put. Otherwise, I'm avoiding pylo in all my retrofixated lenses. Okay.
Sir, actually, most of us have a stock of all powers of iris claw lenses. So we have an option of using iris claw lenses as a
I think it's a good option on the table, especially if you're not a retinal surgeon and you're not very comfortable with the scleral SFIOs. And that is, I'm talking about the adult patient in which the sclera is still properly thick. But if you have a Marfan's or a Beal syndrome or a homocystinuria, so we did a study from 5 to 15 years of age. This kids, I was talking to the kids group. Adults, it's a cakewalk. You can do even the iris fixation, and also in adults, it's not going to cause as much problem as the children. Because the sclera is thin in those conditions. If it's a normal sclera, normal structure of the iris, even if you do iris claw anterior with a PI and get away and your patient is happy, I think you've done a good job.
Thanks a lot, sir. I mean, anyone has any more questions? Because sir is
there was one question from Vijay Lakshmi. I think she was asking about, does it ever bleed when you're doing an enclavation? The answer is no, it never bleeds during the enclavation. But yes, if you're a little rigid during enclavation, sometimes your one arm of the claw can come in front of the iris. So 2 patients out of 50 had their trouble, but it was holding, the iris was holding well, the other side was good, so we left it alone. And there's no loss of any damage to the endothelium. Bleeding can happen only if you're removing the claw and you pull at the tuck at the iris root. So the bleeding is always at the iris root, never at the iris. So Shini is smiling away now. He must have done it something like that before. Yes, all yours.
Yeah. See, anyone has any more questions? Otherwise, we should thank Khokhar sir, because he has been very kind enough to stay back and take our questions. And once again, your videos were absolutely superb, and I have assisted you, and I know I have seen other people. You are the best, sir. Thanks a lot, sir.
Hey, come on. But you had a guy who, you can buy a FLACS. If you can't owe me, if you can't afford me, you can buy a FLACS.
Okay.
But FLACS is not going to do the surgery for you. All you guys understand. Technique and technology both go hand in hand. Technology, you need to up your technology. You need to have a good suctions, good cutting, and good all. I agree what Mahipal was saying, that like smile also for the refractive also. But at the end of the day, it's a surgeon who decides. It's his gut feeling. Okay, and that's what is more important. And the more technique you improve on, you become a better surgeon. And anybody has any question, they have my email ID. They can always ask me for the videos, or they can come to RP Center anytime. I can show them the live surgeries whenever they are willing. Okay, Srini?
Thanks a lot, sir. Thanks a lot.
Thank you.
Okay.
Most welcome.
Thanks.
And where's Gopal? He's missing throughout the entire show.
Yeah, he's a retinal surgeon, sir. What business does he have with the
but we are going to their territory. We're going retro iris, so he should be getting bugged about it.
Sir, thanks a lot.
All right. Thanks.
Bye,
Bye-bye. Bye.
Bye. Srini. Yeah. Yeah, we'll move on to the next session.
Srini, Dr. Umesh.
Yeah, Umesh.
Yeah, just a couple of points on your question on iris claw.
Yeah.
So there are few classical indications for not putting on the same day.
Okay.
One is when you are not able to do a complete vitrectomy or you don't have facility, the iris has been manipulated severely. And of late, I am seeing a few of the beginners, they're not able to distinguish whether it is a ICCE or a PC rent. When you have a rhexis margin and you're not able to identify, good that you wait for 2 weeks. After 2 weeks, you can actually make out the rhexis margin. You can as well go and put a photo. So these are a few indications where you can wait for a. Yes, go ahead.
Thank
Just
you,
wanted to add this.
Yeah, Jayaprasad.
Yeah, good evening. Where is Dr. Divya?
Divya?
Sir, Rakhi will be coming.
Okay.
Okay, so that was an enlightening session. So we'll move on to the next session, which is on managing difficult situation phacoemulsification. This session will be moderated by Dr. Divya. So let me just give a quick introduction about her. So Dr. Divya has done her MS from MBBS from Government Medical College Trivandrum and MS also from the same college. She is trained in pediatric ophthalmology and strabismus from Aravind Eye Hospital, Tirunelveli, and currently working as an assistant professor in Government Medical College, Kollam. Over to you, Dr. Divya.
Thank you, Dr. Raki, for the kind introduction. Now, let us move on to the third session of today's CME. Now, it's for my proud privilege today to introduce the eminent speakers and panelists of this session. Due to want of time, I would be introducing them back to back. The chairperson of today's session is Dr. Jayaprasad. Sir is the founder, chairman of Avardeep Eye Care Centers, Trivandrum and Kollam. He is a visiting faculty at Kochi Eye Care Center, Aluva. He is a pioneer of Phaco surgery in Kerala and the first keyhole cataract surgeon in Trivandrum. His areas of interest are cataract, glaucoma, and oculoplasty. He did his MBBS from Government Medical College, Trivandrum, and MS from Regional Institute of Ophthalmology, Trivandrum. He has his fellowship in anterior segment from Shankara Eye Care, and he has worked as a senior resident in Jipmer, Pondicherry. He has numerous presentations and live phaco surgery workshops, and today he will be talking to us on the topic tackling small pupil. Next, we have Dr. Sonu Goyal, who is a medical director and senior phaco refractive surgeon at Anand Hospital and Postgraduate Eye Institute, Jaipur. He has special interest in complicated cataract surgeries, refractive, glaucoma, and femto-assisted surgeries. He is a pioneer in LASIK and femto-enabled cornea and cataract surgery, and he has numerous publications, presentations, and live surgery workshops in Phaco, LASIK, ICL, FLACS, SMILE to his credit. He is a recipient of many prestigious awards and has worked as executive of the Jaipur Ophthalmological Society, the Rajasthan Ophthalmological Society, and chairman Scientific Committee, Rajasthan Ophthalmological Society. He is presently the member Scientific Committee of the AIOS. This topic today is managing subluxated cataracts. Now, we also have with us Dr. Umesh. He is the Chief Medical Officer at Shankara Eye Institute, Bangalore since 2008. He has an experience of over 50,000 vision restoring surgeries. He did his diploma in ophthalmology from Regional Institute of Ophthalmology, Bangalore, and underwent specialized training in cataract and refractive surgery from Shankara Eye Care Center, Coimbatore. He also underwent training in refractive surgery from Germany. He is regularly conducting Phaco training programs at Shankara Eye Hospital and has trained over 100 surgeons. So he will be talking to us today on Phaco in long and short eyes. Now, Dr. Harshal Talk was the chairperson of the previous session and very familiar to us now. So a warm welcome to you, sir. Now, we also have a panel of eminent panelists. Dr. Jagadish Rana, who is a proprietor and consultant eye surgeon at two Park Eye Hospitals in Ahmedabad, Isanpur and Maninagar area, is a director and refractive surgeon at Freeman Laser Center and Neutralia Super Speciality Eye Hospital, Ahmedabad. He is Executive Secretary of Ahmedabad Ophthalmological Society, Executive Secretary of All Gujarat Ophthalmological Society, Gujarat State Representative of FBS AIOS. He has numerous international presentations to his credit. He has innovated and patented the double-tooth Phaco chopper and the Rana Orta nucleus dividing hook and multi-purpose chopper. Dr. Sathya, she is a senior consultant at Giridhar Eye Institute. She did her MBBS from Mysore Medical College and MS from Calicut Medical College, anterior segment fellowship from Giridhar Eye Institute, and has won many prizes in Kerala State Annual Conferences, including the Best Video Award and Shivareddy Award. Dr. Vanasri Nair is a consultant cataract and anterior segment surgeon at Giridhar Eye Institute, Cochin. She has done her MS in ophthalmology from Government Grand Medical College, Mumbai, and long-term fellowship in Phaco refractive surgeries from Mumbai. A special interest in complicated cataract surgeries, topical Phaco, and refractive surgeries. A warm welcome to each and every one of you. First of all, let me invite our chairperson, Dr. Jayaprasad sir, for the talk. Over to you, sir.
Yeah, let me share the screen. Good evening. Before I go into the discussion, let me thank Dr. Srini, Dr. Thomas George, Dr. Gopal and Arup, and all members of the KSOS executive for this wonderful program. My sincere gratitude to the office bearers of Kollam Ophthalmic Club, Dr. Mini, Dr. Shaini, and Dr. Vishnu, and all other Kollam Ophthalmic Association members. Let me thank all the speakers as well as the panelists who have come here joining this session. Dr. Divya, convener of this meeting, needs a special thank you. Let us go on with the presentation. So 27 years back when I started Phaco, there was only ECC as the standby. And at that time, if you have a small pupil which was not dilating, then it was always stretching the pupil or making small sphincterotomies. And when that is not possible, and when the pupil comes in, these days, if the challenges include a higher chance of trauma to the anterior capsule or the posterior capsule, the iris can get traumatized. As you go forward in your surgery, the intraoperative meiosis worsens, and the retained cortical matter and the iris trauma increases postoperative inflammation. Apart from the regular other causes of small pupil, IFIS has been described by Chang and Campbell in 2005, where you have a floppy and flaccid iris that billows, chance of iris prolapse out of the main and side portones with progressive intraoperative meiosis. And please remember that it is not tamsulosin alone, but other alpha blockers as well as antipsychotic medications and numerous other medications, and even without medications, if it has been described. And the various strategies include ensuring maximum pharmacological pupillary dilatation by drops, pre-op drops, preoperative NSAID for preventing intraoperative meiosis, a bolus intracameral mydriatic and local anesthetic, which is available now in India, as well as adding a mydriatic with or without an NSAID, ketorolac, into the irrigating fluid. Apart from mechanical stretching and sphincterotomy, I will share with you my experience of viscodilatation or viscomydriasis of the pupil, as well as the pupil expanding devices. Viscomydriasis is nothing but you inject a dispersive OVD on the surface of the iris as well as to the pupillary margin. I have here used Orocort, no financial interest. Then you inject a cohesive OVD or a viscoadaptive OVD at the center, filling up and creating that space. And then I usually inject some small amount of BSS on the surface of the lens, that is for ease of doing a rhexis. Now, if you see during rhexis, of course, there is no fluid flowing, so the pupil will not move. But once you come to hydrodissection or phacoemulsification, you will see that that pupil continues to stay there. You have to replenish both the OVDs repeatedly, at least 2 or 3 times, so that you will end up at the end with a nice posterior capsule, a non-traumatized iris, and a lens which is very well secured in the back. And whenever you take out an instant, always inject OVD into the eye and do not allow the AC to collapse. So you end up with a round, nice pupil. Iris hooks, you are familiar with iris hooks, an intumescent cataract, posterior synechiae, we are trying to put iris hooks. The synechiae are released and then stained, multiple punctures on the anterior capsule, aspirate out the cortex with the same needle, and then I use a cannula to aspirate out, make a small rhexis. The idea is to create good space between the anterior capsule and the undersurface of the iris, so that when you put in your iris hooks, it doesn't go and damage the anterior capsule. Take out all the cortex on the anterior surface as much as possible. Now there's a big gap. Inject OVD under the iris, and then the iris hooks inserted through the parasymphysis. Remember, these should be horizontal, parallel to the iris. Go in and hook the iris and don't pull it to the limbus. Most important is do not pull it to the limbus. Only dilate to what you, the surgeon, really wants. So each time you inject OVD and then go in and hook the iris only and ensure that the capsule is not there, and get the stopper in. It prevents leak as well as keep the iris hooks in position. Now, please remember here, the subincisional one is very crucial because that will keep the iris away from the phaco handpiece. I cauterize one side because that side it will be going and hitting the lid and damaging the inner iris. So here I have cut the capsule. I'm going a second round, got a reasonable 5 mm rexis opening, and then finish my emulsification, take off the cortex, implant the lens. And at this point, I remove the iris hooks. Regular iris hooks, you can push it in, holding onto the stopper, and then you can turn it up and take it out. But I also use a V hook for taking out the iris hooks which have been cauterized. Because it was available, I used it, that's all. But generally, if you have a cauterized one like this, you cannot push the entire one in. So use a V-shaped hook, push the iris back and take it out and rotate it out from the paracentesis, leaving behind a beautiful round rexis. A similar pseudo-exfoliation patient, small pupil, sonular weakness. I have hooked not only the iris, but also the capsule. Ensure that it doesn't, you don't rob the eye. It should be stable in the center. And once you have finished emulsification and cleaning of the cortex, you take out the iris hook and hook now only the iris, not the capsule, so that the sulcus is now available for fixing. I prefer a three-piece IOL into the sulcus. That is my take for sulcus fixation, for pseudo-exfoliation. Why? Implant into the sulcus and get an optic capture. Once an optic capture is attained, then I go to the periphery, make a small nick in the anterior capsule, which will act as a peripheral anterior capsulotomy, so that you don't get a capsular distension syndrome in these cases where you are blocking the anterior capsular opening. You leave behind a nice round pupil. Now, there are certain situations where the pupil is dilated, but it is asymmetric. One side is okay, it's very well dilated, but the other side is in. In such situations, you can go in and put only 2 hooks. You needn't put 4 paracentesis, only 2 hooks, and then you can proceed with your surgery without any issues. So use minimal what is essential. And when you have, this is from a trainee's video, repeated iris prolapse through the main node. So what we did was we put a side paracentesis just beneath that, hook the iris back, and with that single one, we were able to maintain the anterior chamber, we were able to maintain the pupil. So these situations where there is an iris prolapse, you can definitely, this will be helpful, keeping a sub-incisional iris hook. Once again, another training here, video, catching the iris repeatedly. And you can see that in such situations, you can prevent further iris damage by hooking it across and then proceeding with your surgery. And you will end up with a round reacting pupil, but maybe with some amount of iris shaping. Dr. Dolakia has come out with iris hooks. This is with Madhu Instruments. I have no financial interest, but I have used a few cases, but I see that the tips are pretty long. It is like your capsule hook, but the tips are pretty long and the tip can go and damage and induce more of uveitis. I think the tip should be shortened. BX pupil expander is something that which needs a learning. There is a definite learning curve. It of course belongs to Suvan, Dr. Suvan from Calcutta. It's a flexible hexagonal nylon. Nylon means it's very light and it is only 0.07. That means less than 1 millimeter in thickness, and it is in a single plane. It has no up and down, and it expands the pupil to 5.5 mm. And the notches at the corners, here the notches at the corners and flanges on the sides are the ones that makes up this ring. And the flanges will go under the iris and the notches will engage the pupillary margin. This happens alternatively so that the ring stays in place, keeping the pupil dilated. The biggest advantage is that this ring can be inserted and removed through a 1 mm incision. Here we go, a post-vitrectomy eye, silicone oil still there, intumescent cataract with posterior synechiae, stained and through a small gap here under the iris also. 25 gauge forceps, I lift up the iris from the anterior surface of the lens. There's fibrous tissue here at the pupillary margin. I tried to peel, but then it is very tough. I would have torn the iris at its root. So I went in and used a Vanna scissors and cut that fibrous tissue, introduced this BX ring onto the anterior surface, then catching with a 25 gauge forceps, I push one flange under the iris. You will see immediately that the other 2 are above. Then go from the opposite side and catch the same one with the hole, push it down under the iris. Remember that you have the capsule opened here to reduce the, to take out the cortex. And then I go to the third one, and here I'm struggling. For me, it is a little difficult to take it out with the forceps. By the time the first and the second flanges try to come out, so I held it once again with the forceps and pushing it back under the iris. There is some amount of fibrosis. Then I went back to the third one, caught it and tried to put it under the iris. It did not work. Then I went to the time-tested device, that is the dialer, the Sinski's hook, held it gently and just pushed it underneath. So now you can see that the three ones without the hole, the three flanges without the holes are on the top, the others are below. Finish emulsification, enlarge the rexis and put in a 3-piece IOL into the bag. You can still see the silicone oil back there, and the lens is implanted into the bag. Once it is implanted into the bag, the company says you should use only for explantation only OVD. Under OVD only you should explain, not under fluid. So it is taken out from the pupillary margin, unlocked, and then it is brought onto the surface of the iris and pulled it out from the main wound because it is already there. Keep this dialer across so that it doesn't come and hit the endothelium. There it ends, and you get a reasonably nice pupil with maybe some amount of iridocyclitis post-op. This is another patient, if this patient with the hook or the pupil dilator already in. This is CT Lucia implanted under fluid, continuous irrigation. 25 years I've been doing this procedure, continuous irrigation, and the company says you should not take it out under fluid, but remember that if you can keep your left hand irrigating handpiece right across the anterior chamber over this and then pull it out, nothing happens. It will not come and hit the endothelium. So there, once again, you see that you are leaving behind a nice round reacting pupil. Finally, let me tell you that whatever device you use, whether it's a Maligan ring, BX ring, or the iris hooks, try to minimize trauma and post-operatively use frequent topical steroids and closely follow up the patient, because many of them will have severe iridocyclitis like this. And at times, if necessary, you can add on oral or intravenous steroids. Thank you very much for your patient listening.
Thanks a lot, sir.
Before I stop, 1 minute. I wanted to show this because if you are working in a scenario where you cannot afford to have even an iris hook, then you can always make one iris hook using a 30 proline regular suture as well as a scalp vein set. The technique, if somebody is interested, you can ask them to email me. I will let them know. Thank you so much. Thank you.
Thanks a lot, sir. Like we are running by late by more than half an hour, so we might not have much time for discussion. So next,
let us go to the next talk.
Yeah,
Divya.
Yes, sir. Thank you, sir. Wonderful talk and wonderful videos. Now, may I request Dr. Sonu Goyal to talk to us on management of subluxated cataracts, rings, hooks, and more. Over to you, sir.
Hi. Am I audible and visible?
Yes, sir.
Okay, wonderful. So at the outset, I'd like to thank the the Colum and the Kerala Ophthalmic Society for giving me this opportunity. I am really indebted to all the organizers. And as I was traveling from the flooded area of Madikeri, traveling down to Bangalore, I'm in the midway, and let me quickly go through managing subluxation lenses. So we all know that basically the subluxation, the choice of capsular supports depends upon a lot of factors. And for me, a dilated slit lamp examination, the moment I see a patient on a slit lamp dilated, and I always analyze the zonular lysis. I always work out for the extent of zonular lysis, and the clock hours, I would take a paper, mark the extent, and then decide the protocol. Now, the zonular lysis could be progressive, as in Marfan's or these developmental anomalies, and static wherever you have traumatic subluxation of the lenses. And you need to assess the strength of the zonules, because the whole game plan then depends upon all these three factors. So you have in your armamentarium the combination of capsular tension rings, the CTRs, the Sioni CTRs, the Emmett segments, the newer, the ASI anchor device, the Yagachaki hook, and the capsular hooks. So for me, wherever I have a patient who has a 3 to 4 clock hours of zonular lysis, I would always go in for a capsular tension ring. But if the zonal lysis basically, extends between 4 to 8 clock hours, I would, go in for 1 point fixation with a CTR. So either a CONE 1L or a CONE CTR or a CTS, a capsular tension segment, along with a CTR is the apt choice. So if the zonal lysis goes beyond 8 clock hours, you basically need to have a 2 point fixation for the lens. So here is where the combination of either 2 CTS along with 1 CTR comes in play, or you could have a CONE CTR 2L or a CONE CTR with CTS. A lot has been talked about the suture material. We have all these years using the nino and the tenopropylene, but the biggest disadvantage with these polypropylene sutures has been, as we have seen, that this hydrolyzes over a period of years. So over a period of 5 to 10 years, we again see these lenses dangling. So what we need to shift is to the polytetrafluoroethylene, or what we call it as the Gore-Tex suture or the CV8. And I'm a great fan of this suture, and I've been using the lasso technique, what Chi Soon Fik has taught us. So taking you through these 3 cases, because I have a long video library, can go of 2 hours. So if you see, there is this subluxation. Always triamcinolone is the first to go in, a limited anterior vitrectomy. If there is no glow, you need to stain. And believe me, the biggest success story is having a round regular capsular access. So capsular hook comes into the play, supporting one side, the viscoelastic goes in, and here I thread the capsular tension ring. So I make 2 side ports, shift my capsular hook, make them 90 degrees apart. A quick Phaco aspiration is what is required here. Always keep the bag distended. The bag should never shallow up here. So I do a Hoffman pocket, and this is the capsular tension segment. And this is the lasso technique that I'm using, the 8 of Gore-Tex, and it is reverse threaded inside a 26 gauge needle, and one loop is created within this capsular tension segment. So the basic aim here is to externalize the 2 sutures. So here the 26, the lasso loop goes in, and this is the loop which I've created to externalize the 2 ends of the capsular tension segments. So I'm trying to pull one suture out. Here, if you mark closely, the one end comes out to the Hoffman pocket. And now I again pass in the 26, create a second loop and externalize this. So the capsular tension segment is being used as the anchoring device using this Gore-Tex suture. And once I've externalized, I would withdraw this suture from the Hoffman pocket. Now the biggest advantage of this Hoffman pocket is that it doesn't allow this suture to be exposed and remains buried. So they are finely trimmed, and the choice of lens here, I am preferring a 3-piece lens, just in case if my bag gives way, I can easily convert to a Yamane technique or a glued IOL. So all the choices must be kept in the mind. And here the lens goes inside the bag very safely. And looking into the 3 Purkinje images of my Lumera microscope, I'm able to centralize the lens back complex. So I'm trying to suture the Gore-Tex here, now trimming, and just mark carefully, I've buried the Gore-Tex within the Hoffman pocket underneath the scleroconjunctival complex. So the viscoelastic is yet next to be washed thoroughly, and you have what is this picture of a very well centralized lens back complex. And believe me, with the Gore-Tex in, this is going to stay there for years. So you can expect a good stable lens back complex using the 8 of Gore-Tex in this patient. So next I would take you to a newer anchoring device. So this is the pre-op slit lamp picture, the lens dangling, and watch carefully, it's this picture. So again, the triamcinolone, a good anterior vitrectomy, and what is important here is to make a round regular capsular access. So I make an initial nick here, try to thread the two capsular hooks. You have to be very, very gentle. Put in a good viscoelastic, deepen the anterior chamber, and complete the capsular axis. It's a soft lens. You can easily aspirate. The bag, as I told, should always be distended. A CTR goes in to prevent the bag from collapsing. And now I'm planning a single point fixation using this anchor device. And this is a wonderful paperclip kind of a design. And again, the suturing material I'm using is the Gore-Tex using the Hoffman pocket, the same concept. Just watch carefully this anchor device. So the lens goes in and this clip is trying to hold the margins of the capsule. Just watch carefully how the lens back complex gets centralized. And this is very easy to manipulate within the bag. The viscoelastic can then be washed and you have a very stable lens back complex. At times I hydro stitch, keeping the bag distended. And this is the post-op day one picture achieved in these lenses. And with the Gore-Tex, you don't have any risk of the lens and the suture material getting hydrolyzed. A newer technique that we recently thought of using, these are the Sony 3-piece lenses that we have been using for long. And this is my own patient, operated 20 years back, came to us a few months back with the lens back complex getting subluxated. Now watch carefully. What I'm trying to do is I'm trying to prolapse the haptic of this lens in the anterior chamber, and I have threaded the Gore-Tex within the haptic of this lens. So I'm trying to do this within the 1.1 millimeter incision on either side. So I've not extended, I'm not trying to expand, neither I am trying to increase the incision size beyond 1.1. So again, two Hoffman pockets is what come to the rescue. And my simple aim is to transfix this lens within the eye without opening using the lasso technique with the 8O Gore-Tex. And I'm trying to thread the two loops which I've created tied to the two haptics of this 3-piece Sony lens. So this is the first part. And the second you see there's a little hyphema. So the suture, I trim, bury, and just watch carefully. Last, you need to just check whether there is any vitreous, and you have a good lens back complex sitting there. And this is what can be achieved using the various techniques. So thank you so very much for making me a part of this. And I think a combination of all these anchor devices, the rings, the sutures can all help in success stories for these subluxury lenses. Thank you so much.
Thank you, sir. That was an excellent talk on management of subluxated lenses. And let us move on to the next talk. May I request Dr.
Umesh
White to discuss the topic Phacoemulsification in long and short eyes.
Can you hear me?
Yeah.
Yes.
Umesh.
Yeah, at the outset, thank you, Dr. Srini, Kollam Ophthalmic Association and Kerala for giving me this opportunity. Since there is lack of time, we'll just dive deep into this phacoemulsification in long and short eyes. When you talk about phaco in long and short eyes, the first thing that came to my mind was just understanding the fluidics, the basic fluidics, and making sure how that is being implemented here. So what I want to emphasize is that any complicated case, first thing that we need to do is understand the fluidics, a fine balance between the fluidics and dynamics, especially important in high myopes and hyperopes, and 90% of the work is actually taken care there. So what is fluidics? Balance of fluid inflow and outflow to ensure that maintain a stable anterior chamber. And when you read the first book of fluidics, there will be indications for increasing the bottle height and decreasing. We see that you decrease the bottle height in myopes, in post-vitrectomy eyes, and increase in shallow ACR, high hyperopes. So first thing that you want to understand what is a short eye or how a short eye behaves. See, first thing that we must all learn to differentiate is how normal is it, whether it is axial hyperopia or relative anterior microphthalmos or an anophthalmos. So this is a normal eye. And if you see this, this is relative anterior microphthalmos. What is relative anterior microphthalmos? The axial length is normal, but the anterior chamber is crowded. That is very important here. That is called relative anterior microphthalmos. Nanophthalmos, everything is small, the axial length and the anterior chamber except for the lens. And the most important thing is the white to white, it is less than 9.5 or so. So, and again in nanophthalmos, you have simple nanophthalmos and complex nanophthalmos. Complex nanophthalmos is associated with other iris colobomas and all those things. The most important common thing that we see is the axial hyperopia. Axial hyperopia is essentially short axial length, normal anterior chamber. So if you understand these things, I think doing Phaco or doing maintaining your fluidics in these Phaco is going to be far easier. So what I want you to see is it's very simple in diagnosing these cases. There's no need of any high funda items. Just your normal biometry is going to help you. All you have to do is just look at the axial length, the anterior chamber depth, and the white to white. If you see here, this is a simple case of axial hyperopia, wherein the anterior chamber depth is very small, is normal. The white to white is narrow, and you see the power 38.5. That means it's just that the axial length is short. Similarly, you see this is a case just 20, and you see 32, and that's because of the shallow, the flat case here. To some extent, here the K is 50, 51. That means the compensation has taken place. So most of the time you understand by looking at the biometry. There's one case here wherein the power was 48, 50. If you see here again, the lens thickness is normal, the AC depth is 2.3, and the axial length is 15.10. Again, this again a case of axial hyperopia. So I was just going through the cases that we did in the last 3-4 years, which are more than 40, 30, 38, and 40. Most of them were axial hyperopias. But obviously, we look at as an anophthalmos and try to make sure. But real anophthalmos is wherein you see the white to white being less. This should be the white to white should be less than 9. The AC depth should be less than 1.8, and the axial length should be less than 15. So once you know this, I think your understanding how to go about the cases will be much easier for you. Obviously, the preoperative evaluation, all these things you need to do. Prophylactic ACPI only if it is crowded. Most of the cases which I have done, I have shown you previously, we have not done anything. We just did a complete glaucoma and fundal evaluation, and the glaucoma clearly showed that they are open angles. And obviously, just to tell the patients about the risk of surgery. One thing that is very important in these cases is these refractive surprises, that is biometry. In our experience, Barrett's Universal 2 and Kane formula is giving very good results, especially when the axial length, the white to white, the AC depth and white to white and the lens thickness is normal. When the anterior chamber is crowded, that is when the AC depth is very shallow, the white to white is very less, and the lens thickness is very thick, that is classical nanophthalmos. There you expect the ELP to be pushed forward, thereby giving you a high minus. So there you have to be careful. Probably look at 2 or 3 formulae, that is the Barrett's Universal 2 Kane or Hofer Q, and try to get a average this one and try to be on the myopic side. The patients will really benefit. I have, as long as the AC depth is more than 2.3, 2.4, usually it goes off as a regular normal case, and you can go ahead. There won't be much of an issues, but these are the things that you have to be, especially when the AC depth is small, shallow, and the white to white is less. Again, these are for the classical nanophthalmic class where you give mannitol and do under as much as possible, do under topical, increasing the bottle height, and use the cohesive to just maintain the space. And one important technique which I'm going to show is bulk of the nucleus may be decreased by shaving away the epinucleus within the bag and creating some space. That is one thing that is very important. And once you do that, more or less, you are creating much space for yourself, and it will go on as a, even for shallow chambers. For example, you're dealing with 1.8, 1.9, 2 millimeter AC depths. See, all these things, you don't need any high funda equipment. You just need your normal biometer, look into your biometer, and then you know how to go about this. So this is where the simple shaving, I think this AC depth was around 2 millimeters. This is quite adequate, but you just go there and shave the central portion, create up to 1 millimeter. You shave the central portion before you either do a chop or you do your simple divide and conquer or stop and chop, whatever it is. I do a direct chop. So as you do that, you create some space and you have enough space to go about and do that. This is called the surface debulking. Complications is very rare. I've had very less cases, but in the most of the studies that have been reported, especially sclerotomies versus non-sclerotomies, where I think during the ECC or in the classical nanophthalmos cases, where you have a very shallow white to white and a shallow anterior chamber, big lens, and a small axial length. There, sclerotomies versus no sclerotomies, there is a thing, but what normally we do is we do a UBM and also the B scan and look at the thickness, and based on our retinal surgeon's opinion, we can or have them as a standby to see if everything goes well, okay, or aren't able to do a sclerotomy. These are very rare cases, and these can be determined as and when you go about your cases in the classical nanophthalmos cases. Coming to the Phaco in high myopes, again the same thing. It is just the opposite of hyperopia. But one thing off late you have to be very careful is history of previous refractive surgery. Just last week I had one patient who never informed me. Luckily, the K was around 38. That gave rise to some suspicion. And when we did topo, we knew that. And after inquiring, she said that she underwent the LASIK procedure in one eye. So be careful in high myopes. This because you are entering the third decade of refractive surgeries, you will be ending. You will be seeing some cases, and a must is the peripheral retinal evaluation. Of the Barrett's Universal 2 is giving us very good results, almost spot on. I think most of us are happy with that, and we are doing that. And topical is good. Those who are not happy doing topical, we prefer the subtenance block. I think it's a very simple procedure. Most of you should go back to subtenance, should or learn subtenance, because that's becoming much easier and safer. And those who are doing perivolar should shift to subtenance. And again, the same thing. And one thing that we must remember in myopes is the LIDRS, that is the lens iris diaphragm retropulsion syndrome. And off late, as we see, the first thing that we do here is in the myopes is reduce the bottle height. Once you do the reduce the bottle height and ensure that there is no pushing of the anterior chamber behind, most of the lens iris diaphragm retropulsion syndrome is taken care. But in case that happens, a simple thing is just lifting the iris edge by using the Sinski or any other simple instrument. The reverse pupillary block will be released. That's very important to keep in mind whenever you're doing a high myope. Now, this is, I just took this case. I wanted to show this case typically because this was a very complicated case, a post-RK with 16 cuts, very minimal space between, and high myope and post-vitrectomy. See, one thing that all of us must remember is, I don't have the parameters to show, but the bottle height, normally in my settings, I use a bottle height of 90 to 100. I brought it down to 45. Now, irrespective of your settings, the first thing that you must observe is as you enter with the probe, don't enter with the irrigation on. That is very important. Or once the irrigation is on, observe for the sudden deepening. The best should be that the AC is as it is or slightly depressed, but not very deep. Now that simple thing that that thing is very important. And once that is through, and all the steps wherever you're going with the irrigation on, you be careful, and that will take care of most of the problem. That will ensure that your bottle height is adequate or not. And if it is deepening for any reason, you can ensure you can go back and always reduce the bottle height. Or if the bottle height is very low, you can always reduce the flow rate. To me, I just use the reduce the bottle height. I don't do anything. My all other settings are the same. Again, I'm showing you the same thing. This is very critical here because apart from the deepening of AC, it is also the cornea which is weak because of the multiple cuts. So if you see here, the AC is just as normal. There is no iris flutter, anything whatsoever. And I'm using high fluidics. Everything is high fluidics except the lens has been imported. And you can see once it goes in, and then you switch on. And when I switch on the irrigation, the AC doesn't deepen. That is very important. And as long as you are maintaining and observing of that, I think you're doing a good job. And in this case, even without a suture, the surgery went off well. And this is what is very important consideration. Post-op, obviously, refractive surfaces, the Barrett's Universal 2 is available. And with this, we don't see anything. And in case there is an anisometropy in the other eye, please think of an early surgery. And these are the things that probably make sense. And I felt that these are very important. Thank you once again, Kollam and Kerala Ophthalmic Society. Any questions, I'll be glad to take.
Yeah, thank you, Dr. Umesh. That is a wonderful talk, and we'll have discussions at the end of this session. We have one more speaker coming up, but before that, one quick question out from this same, something different. Let me ask Dr. Vanisri, the panelist. Vanisri Nair is here?
Yes, sir, I'm here. Yeah.
Yeah. What is your take on prophylactic intracameral moxifloxacin? Make it 30-second answer.
Yes, I would definitely recommend that we use prophylactic intracameral moxifloxacin. As we all know that a very large study from Arvind has also proved that it has brought down the rates of endophthalmitis significantly. In my practice, I do use that. So, and especially in complicated cases where we know that vitreous loss can be there or there can be a vitreous disturbance, there is a higher chance of endophthalmitis in these cases. So definitely, yes.
Do you use it directly 0.1 ml into the bag, or do you dilute and replace the fluid in the anterior chamber?
It is in the anterior chamber, 0.1 cc.
You inject directly, or you take it in a syringe, add 0.3 ml, dilute it, and replace the entire fluid in the anterior chamber.
No, I do not dilute and replace the entire.
Dr. Sandhya is here.
Yes, sir. I'm here.
Sandhya, good evening. What is your surgical choice in pseudo exfoliation with mild to moderate sonular weakness? Give me 1 minute for you.
Yes, in the pseudo exfoliation, two main concerns. One is small pupil and sonual weakness. So preoperatively, it will be very difficult to assess unless there's a gross sonual weakness. So most of the time we come to know when intraoperatively. There is few signs of this sonual weakness are during rhexis. When you puncture the rhexis, if there is a dimple, that is folding of the wrinkling appears on the anterior capsule, then there is definitely sonual weakness. And if you see there is fold just in the advancing border of the flap, then again it suggests that there is a sonual weakness. In such cases, what I do is, if this is mild to moderate, I usually see if the lens is stable, the bag is stable, then I go ahead with the phacoemulsification without putting CTR initially. And then in such cases, I use low phaco parameters. And then I use, the most important thing is you should have a good cortical cleavage hydrodissection so that the nuclear manipulation becomes easy and the cortex aspiration also becomes easy. And another important point is you should use adequate power, because if the power is less, then you keep on pushing the nucleus, so that will cause more and more damage to the sonules.
Thank you so much, Dr. Sandhya. The time doesn't allow for further discussions on that. And Divya, please continue. Please call the next speaker.
Yes, sir.
Yeah.
Now may I request Dr. Sachdeva to share his experiences with black and white cataract phacoemulsifications. Over to you, sir.
Thank you very much, Dr. Divya and Dr. Jayaprasad. So I'll be quickly showing you some videos of black and white cataracts. We all know that doing phaco in these kind of cataract poses a lot of challenges. So what I'm going to discuss you, the technique is what I call drill and chop technique, which I presented way back in 2010 in Paris and ESCRS 2011 in Vienna. So this technique is very effective. I've been using for years and teaching at different forums. So in these kind of brown and black cataract, we all know that the central endonuclear core is the hardest part to crack. So of course we need to go and stain the anterior capsule with trypan blue, and after staining we need to make an incision. We need to be careful that incision is not tight, because a tight incision can restrict the fluid movements around the phaco needle, and it can cause a wound burn if the incision is too tight. Coming to the rhexis sizing, I always make an adequate size rhexis of 5.25, 5.5, but not larger, because making a larger rhexis takes off all the advantages of the premium lenses which we are going to implant in today's time, the multifocal or trifocal or whatever lenses we use. So I make a rhexis which is of perfect size, and always we do specular count in all our routine these cases, especially in black and brown cataracts, so that we know the endothelial cell counts of the patient. We can explain them beforehand. And we use a chondroitin sulfate based OVD to protect the corneal endothelium. And this is under topical anesthesia, but for the beginner surgeon, I recommend to use a peribulbar block. And once they get skillful in dealing with these harder cataracts, they can switch over to the topical anesthesia also. This is a routine 1.8 millimeter co-MICS tip which I use. So essentially, I go ahead and I try to drill a hole in the center, and I'm remaining in the center here, very much away from the capsulorhexis margin. So drilling in the center, essentially what you're doing is you're weakening the central endonuclear core, which is the toughest and hardest part of the nucleus here. I keep on rotating with the chopper and drill in the center. And once I drill deep enough and below the surface, you see, I get a good margin from the anterior capsulorhexis. So it's very, once you put your phaco probe deep in this central core, and when you chop this from periphery, your chop becomes much more effective. As you'll see here, once I drilled in the center, I go ahead and hold the nucleus here and get my chopper, and you can see it's cracking the nucleus through and through anteroposteriorly. So once this crack reaches here, you rotate the nucleus 180 degree. So here at this stage, I'm always using the pulse mode. If you have a pulse mode and burst mode, you can use those power modulations to decrease the energy which is delivered in the eye. So I go ahead and rotate it 180 degree and divide the nucleus. You see this, the nucleus is completely divided in two halves. And again, you hold from one of the side, you drill here a little bit. So the advantage as compared to the crater and chop technique is that you don't have a big crater here, so that your holding of the nuclear pieces become much more difficult if you have a big crater. So divide the nucleus into smaller pieces and then take them off like a piece of cake. And so this is how the nucleus disassembly is done. And always try to do hydroimplantation, put the IOL in the capsular bag, and you can see the cornea is very clear, incision is very clean, and this is the hydro stitch cannula which I've designed. Another case, this is the case which had lens-induced glaucoma. So I always try to dilate them using Phenokin Plus on table, because many times you may get the lens-induced glaucoma attack if you dilate them 1.5 to 2 hours back. So again, so the problem in these kind of intumescent cataract is of capsulorhexis. There is a liquefied cortical matter. So I always try to make a small capsulorhexis of 1-2 millimeter, not more than that, using a micro capsulorhexis forceps. And once you have this small capsulorhexis in the center, you go ahead with 27 gauge cannula. You see, I'm just debulking the capsular bag, and this entire liquefied cortical matter comes out. And once you have debulked from, again, I go ahead and put some chondroitin sulfate based OVD like Viscoat, and go ahead from another side port and try to debulk this capsular bag from all the sides. Again, this case is under topical anesthesia. And after making a small capsulorhexis in the center and debulking, go ahead and give a tangential cut and use the micro forceps to make a capsulorhexis of desired size. So this is how you tackle these intumescent cataracts. And of course, again, put an IOL in the capsular bag, and that finishes the case. And this is another case of, again, lens-induced glaucoma. I'm just sharing these cases so that you can see how effective the sequential two-stage capsulorhexis is. Try to make very small rhexis in the center, the smallest possible, because this is the safest area. And see, the moment I debulk with this cannula, the entire capsular bag, it debulks and it becomes very easy to make capsulorhexis of desired size. And using the same technique, I go ahead and finishes the case. Just this last case I'll show. This is the Morgagnian cataract, hypermature cataract. The problem here is not of the increased intracapsular pressure, but because of the liquefied cortical matter, the capsules is thin, friable, and their zonules, they become weak in these cases. And because of the increased mobility of the nucleus, the chopping becomes difficult in these cases. As you can see here, the nucleus is very much mobile. Again, I go ahead and debulk, do some drilling in the center, and horizontal chopping works best in these kind of cases. So you go ahead and get your chopper from the equator. So nucleus disassembly, it depends on the technique which you use. So you don't need much of the Phaco power to disassemble these harder cataract. So here you need to protect endothelium with viscoat, and it finishes the case, as you can see here. And again, the IOL goes in the capsular bag. And always remember to enlarge, do the secondary enlargement of capsulorhexis using micro scissors, and try to use your left hand also, and so that you don't have a capsulophimosis later in the later period. So this finishes the case. So just last case again, we have a good capsulorhexis. Goes on. So I think with this, I'll finish my presentation here, as we are really running short of time. Thank you very much once again, Dr. Shini and entire Kerala Society of Ophthalmic Surgeons for giving me this wonderful opportunity.
Thank you, Dr. Harshal. It was an excellent presentation and good videos. Before we go into discussion, which I don't think Srini will allow now because we are already running late, but we'll give Dr. Rana, who is a panelist for this session, a chance to show his new chopper, Rana's chopper. Shall we allow him to show Dr. Srini?
Yes, sir. 2-3 minutes, sir.
Divya, shall we?
Yes, sir.
Dr.
I request
Jagdish
Dr.
Rana,
Jagdish
please.
Rana, our esteemed panelist, to enlighten
Sathya,
us
sir.
on Rana Chopper.
2 minutes from your session.
Yeah, okay. Thank you, sir. Yeah. So this is my double tooth Phaco chopper. So I will fast forward it. Here is the salient feature. It is having two blunt tooth at the tip. And this is how it is done. This is in a brown leathery cataract. It acts as a chopper also, rotator also. It helps in a chopping, rechopping also. In a soft cataract also, where with a single tooth chopper, there are chances of cut through to the lens matter because of a broader area of a contact with the lens matter. We are able to do the chopping in soft cataract also. This is in semi-dilated pupil. In pseudo-exposition cataract, where there are chances of zonular weakness are there because of a less trace over the zonule with double tooth Phaco chopper and broader area of contact, we are able to do the chopping easily. This is in the post-haste synechia also, after dilating pupil with a iris hook. So the main advantage is less trace over the zonules. The trace is more distributed over the more zonules rather than a axial trace over the zonules. This is how picture it mimics trace over the zonules. Chopping is done very easily. Safe, easy, and fast surgery. And the main important thing is there is no learning curve. These are the few pictures. This is the main thing what our expert says from our the Ronaldo. What he says is it is very easy to chop when the two chopping tooth are in line with a primary groove or in a Phaco tip. So that is in a line with a cortical fiber. So Dr. Suhas Haldiputkar is also a regular user of this chopper. And main important thing is this Dr. Toshika from OTA. He has modified this chopper slightly at the base, and it is named as a Rana water chopper, and it's available out of India. Also, it is manufactured in London also. Thank you. Thank you so much.
Wonderful innovation, Dr. Jagdish Rana. I'm looking forward to using your chopper. I'm sure that it will be very useful in soft cataracts where you can actually put it and drag across to get a division. Anyhow, thank you so much. And are we
one point to say
for the next session or anything else?
Yeah, one point to say that it's available with Appasamy and Epsilon with no financial interest.
Yeah.
Yeah. Okay.
Right. Thank you, Dr. Rana. And Srini, are we having a discussion or are we going to the next session?
Sir. We'll move on to the next session.
Thank
you
you
a lot, sir.
so
Wonderful
much,
session,
everyone. Sir. Dr. Divya, Sathya, Banasri, everyone. Thank you so much. And for all
Dr.
all
Sonu,
the speakers, Harshal, the musical man. Thank you so much, Harshal.
My pleasure.
Yeah.
Thank you, everyone. This was a really amazing session with a lot of surgical pearls for each and every surgeon over here. So our next session is on managing Phaco complications. And is someone already sharing the screen? Okay.
I think the previous speaker has to close down. You are being Vishnu Mohan screen actually. Vishnu Mohan screen.
Vishnu. Okay.
Dr. Vishnu will be the moderator for the next session. He has done his MBBS from Pariyara Medical College, Kannur.
Yes, ma'am.
And it's MS Opthal from the India's Navy prestigious Command Hospital, Mumbai. He's currently working as a consultant ophthalmologist as a Precise Eye Care, Karnataka. Over to you, Dr. Vishnu. Dr. Vishnu?
Yes.
Yeah, you can start your screen sharing.
Vishnu, no issues, Vishnu. You can just read out the CVs of the presenters.
Coming, sir.
No issues. No, if it's there on a laptop, just read it out.
Ready, we can just go ahead.
Yep.
Thank you, Dr. Divya, for the kind introduction. Welcome all to the fourth and the final session of today's CME, that is the management of Phaco complications. I welcome the chairperson for this session, Dr. Satyajit Sinha, who is the chairman and senior anterior segment surgeon at the AB Eye Institute, Patna. He did his fellowship from Shankar Nethralaya, Chennai, his basic science course from Stanford University, USA, and MS Opthal from JJMMC, Davangere. He has won the Dr. K. Bose Gold Medal for Best Scientific Paper at Bihar Ophthalmological Society Conference. He is the recipient of Best Paper and the Best Poster Award at Karnataka State Ophthalmological Conference. He received Educational Fund Award by Asia Pacific Association of Ophthalmologists. He has received International Award for Medical Excellence in New Delhi. He is also a recipient of IIRSI Gold Medal. He is presently the CSE of Bihar Ophthalmic Society and is the KOS ARC member for the second term. And he presented several papers and conducted numerous ICs nationally and internationally over the past 2 decades. Sir, welcome you to the session as chairperson. Now let me introduce the speaker for the sessions. The first speaker is Dr. Lav Sachdeva, who will be presenting about wound burn during Nethralaya and BB Eye Foundation, BAP Kolkata. Formerly, he was the Assistant Medical Director at Shankar Nethralaya, Kolkata. He did his MBBS from Bangalore Medical College, MS Opthal from Patna Medical College, and Pediatric Ophthalmology Fellowship from Shankar Nethralaya, Chennai. He won the Grand Prize Award in AP ACRS and Best Video Award in OSWB KAO. He has 15 publications in peer-reviewed national and international journals. His area of interest are pediatric ophthalmology, spin, cataract, refractive surgery, and ocular trauma. Sir, welcome you to this session.
Thank you.
Next topic is intraoperative sonula dialysis, and it will be delivered by Dr. Arup Bhaumik. Dr. Arup Bhaumik is the senior consultant at Disha Hospital, West Bengal. He won the KP Roy Award for Best Free Paper in 2000. So, Shovarani Hasa Award for Best Video in 2011 from OSWB. He is the first Indian to achieve the grand prize in ACRS 2010. Also the Best Video in Innovative category in ESCRS 2010. He also won the Runner-Up Award in Innovative category ASCRS in 2013 at San Francisco. Sir, welcome you to this session. And the next topic is the descemet membrane detachment and will be delivered by Dr. Anurag Mishra. He is the director of Radharaman Hospital, Cuttack, and partner of Carvision Eye Hospital, BBSR. He did his MS Opthal in 2003, 2 long-term fellowships in IOL and anti-segment and pediatric opthal and strabismus from Aravind Eye Hospital, Madurai. He has 30 live surgery invitations and many publications in peer-reviewed journals. He has got 13 years of experience and faculty invitation in various society meetings. Welcome you, sir, for this session. And the next topic is IOL damage during implantation and will be delivered by the chairperson, Dr. Satyajit Sinha. Final topic is the PC rent and the premium IOL implantation, which will be delivered by Dr. Shail Vasavade. He is working as a cataract and refractive consultant in Rakudeep Eye Hospital, Ahmedabad. He did his post-graduation in Ahmedabad. After that, fellowship in cataract surgery and Phacoemulsification in Rakudeep Eye Hospital. He is trained in general ophthalmology from LVP Hyderabad, then fellowship in cataract and refractive surgery at prestigious Moran Eye Center in Salt Lake City, USA. He has his degree of DO, DNB, FRCS, and FICO. He has more than 10 peer-reviewed publications. He has been awarded Best Paper in ASCRS 2015. He has received Grand Prize for the Best Video Film in ESCRS 2019. Now, let me introduce today's panelist, Dr. K.S. Chandrakant, who is the Chairman, Managing Director, and Chief Consultant of Dr. Chandrakant Malabar Nethralaya, Calicut. He was formerly the Senior Consultant at Aravind Eye Hospital, Madurai. He has presented numerous scientific papers and has been a faculty of various state, national, and international conferences. Welcome you, sir. And Dr. T.P. Sunil Kumar, he is a fellow of Royal College of Physicians and Surgeons of Glasgow, member of American Society of Cataract and Refractive Surgery. He is a winner of gold medal from Mumbai University and pioneer in Phacoemulsification and leading refractive surgery in the state. Welcome you, sir. And I welcome Dr. Srini Edaklon, Chairman, Scientific Committee Chair, for us panelists in this session. And Dr. Matthew Kurian might be joining us panelist for this session. Requesting the chairperson to take over the session. Thank you.
You unshare your screen, Vishnu.
Thank you, Dr. Vishnu. What a wonderful webinar this has been thus far. Kudos to Dr. Srini for organizing this entire show. Before I even begin, I would like to thank thousands of viewers who are seeing on YouTube and Facebook for being all through this program right from 4 o'clock. And I would like to thank Kollam Ophthalmic Society, Dr. Mini, President, Dr. Shini, Secretary, and Dr. Vishnu, Treasurer, who is with us. I'd like to thank Dr. Arup Chakravarti, Dr. Gopal Pillai, Dr. Biju John, and Dr. Srini, who is here with us. I'd also like to thank all the speakers who have joined, Dr. Love Kochkave, Dr. Arup, Dr. Anurag, and Dr. Shell. And I would like to thank Dr. Matthew, Dr. Chandrakant, and Dr. Sunil. Without wasting time, we would like to go away to the first topic of Dr. Love Kochkave, who is at Netralayam in Kolkata, and he will be speaking on wound burn. Dr. Love Kochkave, please.
Is my screen visible?
Yes.
Okay, thank you so much for giving me the opportunity to speak on this topic. And I would be speaking on corneal wound burn, which is also called corneal wound contracture. And to understand how it happens, we have to understand how heat is generated in our phacosurgery, which is two ways. One is by conversion of the electrical energy to mechanical energy, which is ultrasound. And second is the friction heat between when the probe rubs against the sleeves during phaco. So plus the cooling mechanism also, because which is mainly the fluid in the phaco sleeves. And if the fluid is first infused and then aspirated through the phaco tip, that is the cooling mechanism. But if the temperature reaches around 60 degrees, then that may lead to wound burn, which is also called wound contracture. If you see at the incidence, there are a few publications which with the sample size in US and Canada it was done, and a sample size of 9.2 lakh cataract surgeries, in which they found that the incidence ranges between 0.037 to 0.098%, but also with the observation that it may be artificially low due to underreporting, which we all see in our practice. And sorry for the little poor quality photo, but what you can see here is the wound burn. Now, risk factors, let the video keep playing and then I'll go to that when the initial steps are running. It is the level of the ultrasound energy that is used. And when you see a decreased irrigation around the phaco tip, then a milky fluid generates, which you will see in this video. In this video, that is very classically depicted. Flow of and why it happens? Because of the flow of obstruction by the viscoelastic devices used in the eye, mainly sodium hyaluronate or chondroitin sulfate, if we are using that. Exothermic nature of the OVD also contributes to wound burn. These viscoelastics are generally transmitters of heat, and then now you see when the phaco has started, you see the milky white fluid at the tip because the aspiration is not working due to viscoelastic material. And that once that happens, the heat is generated and it is transmitted to the wound, which leads to a wound burn. So now it has started progressing, but during the initial step itself, you see here the wound, there has been a wound burn. So this case was after this completed in a routine way. And since the irrigation and aspiration was working fine after the initial step, the wound burns stopped there itself and didn't extend. Many times when it is very bad, you will have to switch to another site, another wound, another incision site. And this you see at the end of the Phacoemulsification. So now we know this luckily didn't need any suture, and with hydration itself, the wound got sealed. So this is one of the scenarios in which wound burn occurs. How do we prevent it? First is to ensure that irrigation of the sleeve around the tip and aspiration from the central canal is going on. And as you see in the earlier part of this video, just keep a watch on the vacuum values and the torsional energy values. Avoid manipulation and tension in the wound area, and this is what I'm telling, avoid going to the foot pedal position 3. And here you see the vacuum is full, torsion is 0, and vacuum full with occlusion. So occlusion is with the viscoelastic devices, viscoelastic. And once the vacuum comes down, that means that the occlusion is broken, and then we can start with the phacoemulsification. So now you see there is an ingress of fluid and the vacuum has gone. Then that is the point in which you start using torsional energy. But unfortunately, again, this was a very hard cataract. More of phaco energy is used. And also another important point is that studies have shown that OSIL compared to normal phacoemulsification, the ultrasound one, vertical ultrasound, it doesn't reduce the incidence of wound burn. So the energy generated in nozzle is almost similar to other phaco probes. Now, just keep looking at this point because this is a balanced tape, and the bevel I have kept horizontal. This part of the tape, the left side part of the phaco tape is touching the sleeve, and that is generating heat and getting transmitted to the main wound. So this is second reason. First was the occlusion through viscoelastic device. Second reason is direct touch of the phaco tip and sleeve to the main wound, that also may cause wound burn. And here the CD value, if you see, we have reached around 27, 28 at the end of the surgery in a hard cataract. And once the phaco tip is out, what you notice is a small wound burn here. And that is on the left side itself, where the tip and the gap between tip and the sleeve was not there. So this is another thing. And how to counter it? Probably we will have to keep it beveled down so that the distance between the phaco tip and sleeve is equal on both sides. Complications again is a high astigmatism, wound leak, which may have to be sutured, and multiple horizontal and vertical sutures both have to be given. Fistula may form and may also cause endothelial damage. Now, the third case, what I'm showing is a routine cataract surgery, and there was no initial occlusion with viscoelastic devices, and normal phaco is going on, but again the same problem. Since the bevel is horizontal, the gap between the tip and the sleeve here at the main wound is not there. And again on the left side, because I'm a left-handed surgeon, it is on the left side. And going on well, the CD value is also not very high in this case. We'll move forward. So last piece is being taken out now. And more or less unedited video with in a high speed, what you are seeing. So another important thing is that visco has not been pushed again in between while chopping is going on. And the end of it, what you see here is a very small wound burn again on the left side of the wound. So this gives a good insight on what happens and how it happens. And detection is by the warning sign, which is the milky fluid at the phaco tip. And generally wound burn is more severe in those cases. And second is the whitening of the main cornea at the main incision. Management, again, if it is still leaking with the hydration of the wound, then we have to give multiple sutures, and these pictures have been borrowed by video of Dr. Uday Devgan. And what you see is multiple oblique and radial sutures have been applied and leading to closure of the wound. Sometimes bandage contact lens may be needed, and severe cases, probably none of what would have gone through this is you have to give amniotic membrane graft or scleral patch graft. Thank you so much.
Thank you so much, Dr. Love, for that wonderful presentation. How do you differentiate between a simple hydration of the stroma at the point of entry and between a wound burn for the benefit of all the...
It will be a very localized whitening, localized round whitening on the edge of the wound, and hydration is generally diffuse. And this is a typical small round whitening on the main wound.
Is there some correlation between lower endothelial cell count and a higher incidence of wound burn?
No.
Have you ever...
While preparing this, I had gone through a lot of literatures. I didn't see that anywhere.
Low endothelial cell count and higher
incidence. Wound burn is mainly due to more energy being used. So when wound burn happens, then expect more of corneal edema, more of striate keratitis in those patients because of the energy transmission that has occurred from the Phaco tip.
Dr. Matthew, you are there? Dr. Matthew Kurian?
Yeah, I'm here. Hi, Sachdeva.
Hi, hello, sir. Just needed your views on this wound burn of your comments you would like to share with the audience.
See, typically when we do most of our cases, we are using HPMC as our viscoelastic device. So you put your Phaco tip in, go into position 3 directly, there is not enough resistance, fluid flow is there. In your special case, you're putting viscoat. Okay, that is where you feel that there is a wrong association with lower endothelial counts. In your special case, lower endothelial count, you put viscoat and you go into the same habit of introduce a Phaco tip and go directly into position 3. In viscoat or similar chondroitin sulfate combinations, you need to wait for 5, 10, 15 seconds to ensure that fluid flow is there, because that material is so thick, aspiration flow rate has not introduced, and so tip cooling is not happening. At that point, if Phaco power is on, you will instantly get a wound. It is the culprit is the better quality viscoelastic. It is not the endothelium.
Thank you so much. Thank you, Dr. Love, for that wonderful presentation. We'll go on to the next presentation by Dr. Arup Bhaumik, who will be speaking on intraoperative zonular dialysis. And Dr. Arup is from Disha Eye Hospital from Kolkata, West Bengal. Dr. Arup Bhaumik, please.
Good evening. I thanks KSOS for a wonderful opportunity. It's a lovely webinar. I've been watching this last 2 hours almost. So my topic is intraoperative jonular dialysis. So I try to make it short because we are running late. I have no financial interest to disclose. So jonular dialysis can happen any stage from rhexis to IOL implantation. So the most important thing is how it is happen. It is maybe the direct trauma, that is a catch of the rhexis margin or rhexis margin, either Phaco probe or aspiration port of a bimanual or coaxial, as I shown in the previous video, or maybe this is due to the indirect forces during that surgical maneuver, the forceful nucleus rotation, excessive force by the Phaco probe during the trenching, the excessive force or asymmetrical force during the nucleus division, and sometimes in the very hard cataract, when you put an excessive force by the chopper to get a good crack, you can end up to capsular jonular problem. So, and the most of important thing, if any maneuver where the anterior chamber is shallow, you can end up into the capsular jonular problem and jonular dialysis. So strategies of management is the immediate management. Why immediate management? It is a old proverb, is a stitch in time saves 9. If you try to manipulate with the compromised jonular situation, it actually creates more jonular problem. So it is the strategy should be the immediate management, either implanting CTR. This is a treatment of the jonular dialysis. I'll come to the later. And either CTR or capsular hook. And now, where you capsular bag stabilize? You know, CTR is basically treatment of the jonular dialysis because it gives the support of the horizontal stabilization of the capsular bag. But during the maneuver, when you are early stage of the Phacoemulsification, you need to stabilize the capsular bag anteroposteriorly also. So it is better to stabilize bag with the capsular hook. In my strategy, I am always try to put, nowadays I did a lot of mistakes. So I nowadays, whatever the jonular problem, either small or any amount, I try to put at least one capsular hook. This is create my life easy. So, and definitely this extensive capsular bag damage, jonular damage, you may fix the bag. That's first video I have shown. There is almost 180-degree damage of the capsular jonule. So you have to fix the bag with the CME ring or CTR segment. This I just highlights the two video of my video. So the importance of early diagnosis and early management. So this is a long day. I'm starting my surgery and I try to finish my surgery very fast. And there's a long list. I am going to chop, and during chop, you can I putting some, and there is a signal. You can there is a signal that the rhexis margin is slightly coming from this side, but I just ignore. I just try to continue my surgery because I just want to finish it early, and I think I can finish it very early, without putting anything. So I just try to this, and I didn't even remove my any parameters. So ultimately, there is a catch of the capsular rhexis margin with the Phaco probe. So this is happened. And now what I am doing, I am implanting CTR. I am implanting CTR. I thought this is a treatment of the jonular problem. So I can do the surgery with it. Now, at this stage, when you are implanting CTR, you can end up trapping the epinucleus bulk within the bag with a compromised jonule. So it is a very difficult situation to remove the epinucleus bulk. Somehow I manage. This is my viscoelastic device. This is a visco pump. I somehow manage with the visco dissection with the either side where there is no jonular vessel. Luckily, I can able to manage this case and remove the bed. But it would be better if you put some capsular hook there, as there is a large amount of jonular dialysis, and I can wait for the CTR in the later stage. It will be the much better option for me. So so that, and I just showing this is the ideal management. This is a hard cataract, rock hard cataract in the grade 6. You can understand this is a hardness, and I am going to do the chopping, and whenever I try to do the chopping, I just increasing my as getting the crack, I'm increasing my force in the left hand, and it is create some kind of jonular problem. And I just this, you can see that the nucleus is you can see the margin is coming from this side, but I didn't notice that. I just continue my Phaco with the normal parameter, and it is a hard cataract, and at the second I just try to remove the fragment from the bag. There is a jonular dialysis, so I leave it there. And what is this? This is the ideal treatment. I put a 2 capsular hook there to support horizontally, and you can, if you in this situation, in the either way, if you implant the CTR and without stabilizing the capsular bag without hook, and if this is a very hard cataract, you may end up on the much bigger jonular dialysis. So it is always better if you in the early stage of the phacoemulsification, like you are managing nucleus in the bag, it is always better to implant use capsular hook to stabilize the capsular bag, and the dictum of the CTR as late as possible, as soon you must. So it is important to implant CTR. This is the timing of the CTR. This is a famous dictum: as soon as you possible, but at late as possible. So, and in this case, you can able to implant CTR in the late stage of the surgery. And with this, I just at the pulse is address jonular problem immediately when you noticed. Don't neglect this, and because stitch in time saves 9, and always treatment is always implant CTR. Even the smallest capsular jonular problem, you may end up in the late capsular fibrosis, slight decentration. So even in the small jonular problem or jonular laxity, it's better to implant CTR, and capsular bag in the large jonular laxity is a savior. Thank you so much. Thank you so much for your kind hearing. Listen.
Thank you so much for that wonderful presentation. You have shown everything so nicely that there's little left to discuss. However, I'd like to ask Dr. Chandrakant, sir. Dr. Chandrakant, you're there? Dr. Chandrakant?
I'm there. I'm there. Yes, yes.
Sir, you would like to share your tips and pearls about using these ropes in intraoperative glomerular dialysis?
No, as I said, as already said, if it's a smaller segment, let's suppose less than 1/3, I think while doing a phacoemulsification, you can use the capsular hook and then manage. And if it's not increased, if only 1/3 of the glomerular dialysis is there, you can manage with the capsule hook and without even using the CTR. Thus, in due course, if the glomerular dialysis increases, then maybe in the midway, you have removed a part of the cataract by phacoemulsification. Then midway, if you want, you can go for a CTR and then proceed. If it's more than half the circumference of the glomerular dialysis there, and then definitely you need, along with the capsular hooks, you need CTR rings, definitely. Then as Dr. Arpa showed, the same procedure what we usually follow.
Thank you so much. We'll move on to the next presentation by Dr. Anurag Mishra, who is from Cuttack, who will be speaking on Descemet membranes detachment. Dr. Anurag is a very, very prolific surgeon, and he, as you will see in this slide itself, he has a passion for instruments and everything good in life. Dr. Anurag Mishra, please.
Thank you so much, Satyajit and Dr. Srini, KSOS. Gratitude to all of you for the podium. Good evening, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. It will be a short presentation as the previous two speakers have followed suit, and it would just be highlighting on certain points, certain pearls to manage an intraoperative Descemet membrane detachment. The incidence of DMD is up to 43%. Of course, it depends on the surgeon's skill level and a host of other factors. But the occurrence has been reported in various literatures to be up to 43%. However, a small percentage out of this, which amounts to around 0.5%, is large, and it involves central cornea, where essentially it needs a medical or even more importantly, a surgical management. The various risk factors for DMD, it has been postulated that there is a mutation occurring in the TGF-alpha gene, which actually loosens out the anchorage of the Descemet membrane to the stroma. That can be a contributing factor. However, the more common and clinically important contributing factors are these: the advanced age, where essentially the patient presents to us with a harder cataract, pre-existing endothelial dysfunction might play a role, use of blunt instruments after a series of cases for that particular day, inappropriate plane of the incision, which actually facilitates an inadvertent injection of either BSS or viscoelastic, particularly when we are injecting it, not taking the cannula fully inside. So it has wrong plane of getting entry and then causes a detachment of the Descemets. Instruments or IOL entry in shallow AC. So wherever the AC is shallow, the direction of entry of the instruments on, and even the IOL is more horizontal than is oblique, and it doesn't shoot towards the bag or the mid plane of the anterior chamber cavity, might lead to Descemet membrane detachment with direct trauma. How do we recognize its presence? One, we might just be aware of it's happening on the table and see a membrane hanging from the corneal stroma, the deep side of the corneal stroma. The other thing is when we notice that there is a non-resolving post-operative corneal edema, which is just not resolving with routine or enhanced medications. However, it has been postulated that this non-resolving post-operative corneal edema, more often than not, is due to the direct endothelial damage by the procedure and not the DMD itself. So when the cushion from the endothelium is taken off and it gets exposed to the trauma of the procedure, it leads to more persistent corneal edema, and so DMD directly is not responsible for that. Invaluable instrument in diagnosing DMDs in these cases of non-resolving edema is, of course, the anterior segment OCT. Wherever you have access, use it. If you don't have access, you can take the help of a place where it is available. There are various ways to classify that has been suggested. One classification system divides it into a planar, where the Descemet membrane and stromal separation is less than 1 mm, and non-planar, where it is more than 1 mm. Obviously, the non-planar attachments are less likely to resolve spontaneously, and the planar ones are more likely to resolve spontaneously without any treatment. Scrolled and non-scrolled, depending on the morphology of the edge of the DMD, where the scrolled membranes appear after a long time and the non-scrolled are the fresh ones. Central and peripheral, depending on their locations, obviously they would signify whether treatment is required or not. More important, more clinically acceptable and theoretically acceptable classification has come up from Jacob et al., who divide it into a rhegmatogenous DMD, where there's a hole, tear, or dialysis at the Schwalbe's line. It could be tractional because of inflammation and fibrosis, and then on a pull downwards of the DM. Bullous, where there is a smooth bulge without an overt injury, and complex, which depicts that the edges are rolled or scrolled out. But these are all theoretical discussions. This is just one of those examples of a scrolled DMD. As you can see, there's not much of persistent corneal edema though, but it does affect the visual acuity. It did affect the visual acuity of this particular patient because the DMD occupies right at the center of the visual axis of the pupil. This is an example of non-planar detachment on ASOCT. You can notice the corneal edema at the stromal plane, and the distance between the detached membrane and the rest of the stroma is more than 1 millimeter. This is a live OCT or live real-time video of the anterior segment OCT. As you can see, the DMD is moving on the undersurface of the cornea as the cursor is moving on different axes of the eye when the ASOCT was taken. So it undulates, and there is a significant amount of corneal edema out here, as you can notice. Somehow, some patients will present to you like this. There is a membrane out here when this patient presented to us, but the catch here was the pupil was also peaked. So though there is a membrane on the undersurface of the cornea, this might not be the Deschment membrane. We did an anterior segment OCT again, which showed that this was actually an anterior capsular flap, which was running from the anterior surface of the lens onto the endothelium. So it just might create a confusion. Coming to the more clinical side of it, this was a wonderful algorithm which was described by Kumar et al., the HELP algorithm, which dictates the treatment protocol for DMDs. It depends on four letters. H stands for height. The distance between the detached DM and the stroma depicts the height. Extend the region of the DMD in relation to the zones of cornea. Cornea is divided into 3 zones. Zone 1 is central 5, zone 2 is 5 to 8, and zone 3 is then on from 8 to the peripheral part. The length, chord length of the detachment stands for L, and whether or not the center of the pupil, center of the anatomical pupil is involved. As you can see, this is a peripheral detachment, so the pupil has not been involved in this case, but the height is quite significant, and so is the chord length in this particular picture. So the algorithm says that if the height is less than 100 microns, the length is less than 1, and the zone, wherever it is located, 1, 2, or 3, medical management should be taken up first. If the height falls between 100 and 300, and the length is 1 to 2 millimeters, depending on the zone, if it's on zone 1, you have to have a surgical intervention plan early because this will affect the visual acuity of the patient. However, if the zone 2 and zone 3 are involved, you can take up medical management. If it does not resolve within the first 4 weeks, then obviously you have to take up surgical management. But in the third situation where the height is more than 300, the length is more than 2, wherever it is located, zone 1 and 2, you have to plan a surgical intervention early. In zone 3, which is very peripheral near the wound, maybe you can try out the medical management for a few days. So our treatment options in the medical side is topical prednisolone. There are a lot of authorities who speak that the hyperosmolar agents like 5% sodium chloride does not work for resolution of corneal edema, but it does. In our clinical experience, we see that it does work to affect an early resolution. However, in some patients where there is particularly a preoperative subclinical dry eye, this might just lead to the salt deposition on the subepithelial plane of the cornea if it's used for too long a period. So it has to be counterbalanced with a good quality lubricant to be used along with it. And you might just wish to stop it the moment you see that the visual axis has been clear. The rest of it might just clear with time. Topical hypotensives can be added on if there's a microcystic epithelial edema, which overlies the whole lesion. So just to reduce the IOP a bit and help its resolution. Surgical management, you might create a fluid current, particularly if the DMD is small and it's close to the wound. You might create a fluid current, which is intracameral, which brings the fluid back to the main wound and thereby opposes the DMD. In these cases, I would strongly recommend to only hydrate the side ports and not the main port where the DMD is located. Or if the DMD is located in one of the side ports, then you hydrate the cornea, and form the anterior chamber through the other side port is what I would recommend. A 14 to 16% C3F8 or a 20% SF6 0.2 ml can be used to create a tamponade, and these are expansile gases and which stay in the anterior chamber for a long time. C3F8 even longer than SF6. However, they do have a risk of pupillary block and consequent IOP rise. So we have to have methods to tackle them. A sterile air which is drawn from the OT environment can also be used. And of course, you can always go ahead and suture the cornea if the DMD is very large. So coming to air, you have to have 100% air fill, and which should stay for 10 minutes. And this 10 minutes, you can go ahead and operate another patient in the other table, but just leave that patient in supine position for 10 minutes. And then you can follow it up with a fluid air exchange, leaving 80% air in the anterior chamber, and the patient has to be supine for 2 hours at least for the proper affection of DMD. However, for topical anesthesia patients, actually the air actually escapes a lot quicker than these expansile gases because the eye tends to move and it pushes the air out and it just bubbles out, burps out. So you're not left with much of air, even if you see the patient after 4 to 6 hours. C3F8 has slower absorption and it has a greater effect on IOP. So this is one of the patients wherein there was a gross stromal, deep stromal edema. And I did this. I actually do this for majority of my C3F8 patients. I do a peripheral iridectomy. You cannot do a laser PI in this particular case because the cornea is just too heavy for that. When you attempt to inject C3F8, you find the air leaking, so it has to be sutured first. So that's what I did and buried the knot there, and then leave the patient with a full air bubble inside the AC. Basically, what we do is we take 2 milliliters of C3F8 in a 50 ml syringe and then dilute it up to 50, which gives us roughly a 14 to 16% dilution. So this patient showed the progressive resolution, as you can see, over a period of time. The edema resolved, and the endothelial surface is still not very smooth even after complete adhesion of DM, but it just gets smoother with the passage of time as we progress. So if you do a corneal suture, it should be done after air desmetopexy, and there should be a full thickness bite, and the knot should be shallow. I follow a protocol of 2-1-1 or 3-1, so that the knot is not very bulky. It's easier to bury the knots, and they should be removed after 3 to 4 days. If the Descemet membrane involves a large area, and this is the base and this is the apex, then base is where it should be sutured. And I always take a bite parallel to the wound, because if you take longitudinal bites, then you might have to use more than one bites here. So the bite has to be full thickness. That should be kept in mind. And then it should come out on the other side just gently. And then the knot should be tied 3-1-1 or 2-1-1. As I said, the both ends of the suture should be cut or trimmed flush with the suture, and then they should be buried. And then it should be removed quickly as early as you see. Call the patient back for frequent follow-ups. And the moment you see that the edema is resolving, you should take them out, because otherwise it just might leave behind a suture track, which might just come in the way and cause irregular light scattering. So that will be all from the vault in this edition, ladies and gentlemen. Thank you so much for the opportunity again.
Thank you for the wonderful presentation, Anurag. My question to you was, is there any particular correlation you have ever noticed that a particular segment of patients were more prone to endothelial detachment or anything like that?
Yeah, I mean, if you have a shallow AC to start with, and coupled with that, if you have... Sorry?
Or was it always iatrogenic?
It has to be iatrogenic. It has to be a trauma that causes it. But however, there has been a postulation they just found in literature, which is interesting to read, that they say that there is an anchorage problem, and in these patients, you just have to be careful. However, there has to be a trauma for the DM to just sag below down. And if you have a shallow AC to start with, and coupled with that, you have an advancing age and a hard cataract, then these patients are more prone to have it. Luckily, we have enough instrumentation and enough support from the technology front to give us comfort and comfort cushion even in these complicated cases. However, we just might remember to cushion the endothelium all the time, cushion the important delicate layers of the cornea all the time, and stay away from them as we stay away from the posterior capsule all the time. So it should be identified clearly that the business area lies somewhere between the two delicate membranes, and we have to operate in that zone itself. And blunt instruments are a strict no-no. It's better to use as disposable instruments as possible, particularly when you're making your incisions. And the moment you find them blunt, just go ahead and change them. If you're not cutting that butter, then just go ahead and change them. And be absolutely sure that your plane of entry is well below and you are entering beveled and creating a beveled incision, so that your track itself is ergonomically designed to take the instruments down than horizontal. So these are the things that you have to keep in mind.
Dr. Sachdeva, if I may, like, Dr.
Posterior polymorphous dystrophy. This is a PPMD or PPD. We call it.
Arup, we can't hear you.
Very prone to develop total desmet detachment.
Arup, louder.
Louder. Can you repeat? You're not loud enough.
Yes, PPMD, posterior polymorphous dystrophy. Am I audible?
Yeah.
Posterior polymorphous dystrophy. If you identify the preoperatively, you will be very careful, because even in the slightest trauma, the whole detachment can happen. I have seen the cases of I have seen the PPMD cases. The first 2 days, it is absolutely clear cornea, and the third day is a total desmet detachment. So, so very careful if you identify PPMD.
Yeah, PPMD cases also have intraoperatively, even if they're not detaching Arubda, you can also find them undulating. You can see that there is the endothelium is actually appearing loose to you, just like see the posterior capsule.
There are the postulations. There is the addition of the congenitally. There is a weakness of the addition of the.
There's a weakness in there.
Yes,
the anchorage is weak.
Dr. Sunil, you would like to share your thoughts on this?
Yeah.
Thank you, sir. It's a wonderful presentation, and I think it's not somehow luckily it's not happening. Maybe because of the experience. I think the wrong entry, the wrong boot size, and poor bad quality instruments all are making desments detachment. I think maybe because of the experience, we are not having that bad ankle. That actually happened. I had this detachments happening in my initial cases, but now not getting it for years. So I think the angle is very important. You use good viscoelastics when you entry, so that you will have good cushion, and especially anticipate in a very old patients, hard cataracts, you can anticipate that, and shallow AC, as Sir has rightly said. So if you can anticipate, I think you can prevent it.
It could be more common with SICS than Phaco, because you have a hard-drawn cataract getting caught in the wound and you push it back. The chances of descent detachment is much more with SICS.
Maybe true, because Phaco is much better refined technique than SICS. So it has less chances of DM detachment.
Yeah, Dr. Sathya.
Thank you. I'd like to go on to the next talk, which is an IOL damage during implantation. And this will be a short video for all the attendees who are listening to this talk. So once you have started your cataract surgery and you have finished phacoemulsification, you are all ready to just implant the IOL and go on to the next case. It is very important that you load this IOL also very properly. The haptics and the optics should be in alignment when you are putting the IOL. If you are not very careful, this is what happens. The haptic may break when you are injecting the IOL, and you will get a broken IOL in the AC. Now, once this happens, there is no need to worry and panic. It's important at this point of time that we should safeguard the endothelium, the posterior capsule, and all the vitals. So we have to park this IOL properly in the anterior chamber. And then before doing any other maneuver, we go ahead and properly load a second IOL. And this time you want to be more careful while loading the IOL and putting the haptics and optics together. And then you go ahead and put the second lens right into the bag, just below the broken IOL. You carefully put it in the bag. You put all the optics and the haptics in place. And now your posterior capsule is safe. Now you have to make sure that you have to remove this broken IOL without enlarging the incision that you have made for the phacoemulsification, so that you give as less astigmatism as possible. So you go in with this IOL cutter and go up right till the center, and you will see my left hand, it is on the IOL, because sometimes when you are trying to cut it, it may flip and hurt the endothelium. So if you have the spatula on the left hand side, then you can keep the IOL safe. Now you turn it around 90 degree, and then once again, and all these while when you are making all the maneuvers, you have to use a lot of viscoelastic so that your endothelium is safe. Now you cut out a quarter of the lens that is there, and the small piece that is quadrant that is there of the IOL, you take that out. Once you are doing so many maneuvers, the IOL also, the iris also starts to prolapse. So you have to keep using a lot of viscoelastic. You remove that quadrant, and you will notice that while you are making all these maneuvers in the anterior chamber, the pupil is going on becoming smaller and smaller. If you had not put the IOL earlier in place, it could have become difficult for you to put in the second IOL or even to wash at a later stage. Now, once that quadrant has been removed, now you go in and position the remaining IOL which is there, because you will appreciate that from the center to the periphery, now this will come out easily. You have to just rotate it and bring it out without extending the wound, and then your case is over. You can wash out the viscoelastic which is there, and your the broken IOL has been brought out safely. Thank you so much for your patient hearing. And so for paucity of time, now we'll go on to the next presentation by Dr. Shail Vaswada, who is from Raghudip Eye Hospital from Ahmedabad, and he will be speaking on PC rent and premium IOL implantation.
Thank you very much, Sinha sir, and thank you very much, Dr. Srini, for this kind invitation. I'll be sharing some of the disasters that we have faced over the years. This was a patient of a relatively dense cataract, planned for a toric IOL, and since the pupil, this was the maximum pupil dilatation, I decided I didn't want to take any chance. So we went ahead with iris retractors. That is my favorite method of pupil dilatation. And the pupil dilated sufficiently, and I could make a large enough rhexis. And the rest of the case ideally goes off quite smoothly. The only thing that occurs quite often with iris retractors is that due to these iris retractors and some tenting of the iris, some of the fragments tend to get hidden somewhere behind the iris, between the zonules, the capsular bag, and the iris. They are not in the bag. So during phacoemulsification and while removal of the cataract, you feel almost everything has been removed. But while during IA, sometimes they pop out from somewhere, and that's exactly what happened in this case. So after the cortex removal was almost completed, this relatively large fragment popped out from somewhere between the iris and the capsule. Now, ideally, since this is a fragment, I should have gone ahead with the phaco probe. But sometimes you feel that this is just one last fragment, and I don't want to get out my probe again. So I went ahead and I thought I can crush this fragment now easily with the bimanual irrigation aspiration. I increased the vacuum and appropriately bottle height, and keep noticing here, because this was very dense, you could notice those folds on the capsules that came up. That surge that occurred because of this extremely dense cataract being sucked out, these folds, that was actually when the actual posterior capsule came and caught out. So fortunately, I noticed it at that point of time, and a better sense prevailed that now this is the time when I need to stop being over aggressive. At this point of time, the best thing is not to panic. And here, even if you have not used a dispersive viscoelastic until so far, you must use it now so that the tear doesn't enlarge and vitreous doesn't prolapse. So far, I feel the vitreous hasn't prolapsed, so I still have a chance of salvaging this posterior capsule tear, which is still very small. The best way to salvage a posterior capsule tear is to convert it into a posterior capsulorhexis. And here the use of microincision capsulorhexis forceps is very important. And converting this ragged margin of the posterior capsular tear into a strong circular PCCC. And why is that important? Because even though it may have been a very small tear, when you implant the IOL, that tear can extend if you have not converted into a posterior capsulorhexis. But while pulling out this flap, notice it's not coming out, which means there is a tug of vitreous that has been attached to this PCCC. So I don't want to pull this flap now. I've left that flap right there. And now I need to address the vitreous that is present in this zone of the posterior capsulorhexis. Our preference is for the pars plana approach with the irrigation through the side port with your same aspiration. And then after removing the vitreous from the posterior capsular tear, we went ahead with in the back toric IOL implantation, because now we have a strong anterior capsulorhexis as well as a strong posterior capsulorhexis. And therefore, I'm not worried about the stability of the IOL changing over a period of time. And I'm making sure that the IOL is aligned appropriately. Always make sure, even in the end, before you close the case, that there is no presence of any vitreous in the chamber. And fortunately, there wasn't. And hydrate all your wounds before making the chamber shallow. And the pars plana trocar, of course, will be removed at the very end and just giving a counter pressure. And this is the patient doing very well post-operatively now, more than 2 years. And you can see this posterior capsulorhexis and the IOL position has not changed over these 2 years. Which form of vitrectomy, pars plana or limbal? I think any form is good, but make sure that you do adequate vitrectomy around the posterior capsular tear. The most important step is to stain them with triamcinolone, because very often you feel there is no vitreous, but when you put triamcinolone, you find that there is some strand hanging somewhere. With limbal vitrectomy, the only disadvantage is that you're constantly dragging on a larger and larger bulk of vitreous. So you're likely to keep bringing out more vitreous and enlarge the small posterior capsular tear into a larger posterior capsular tear. Compare that to the pars plana, where you are actually draining it from where the vitreous is coming. So you are attacking less amount of vitreous, and you also make sure that the tear doesn't enlarge. The other advantage is that with limbal vitrectomy, the ergonomics are sometimes quite skewed. So although you are able to do vitrectomy in the area of the tear, you are unable to remove it adequately from all around the tear. And therefore, you leave behind inadequate or incomplete pockets of vitreous, which can, cause some tilt, even though the IOL may be inside the bag. Compare that to the pars plana, where you have a lot of scope, because the ergonomics are so easy that you can move all around the posterior capsular tear equally, so that a relatively equal amount of vitreous is removed from all around. So our approach is the pars plana. This is a second case of a posterior polar in a young girl with high astigmatism and already a pre-existing posterior capsular defect. So you'll notice here that there is already a pre-existing defect with some material already in the anterior vitreous. Our preference is to do the cylindrical pattern with FLACS, because that allows each epinuclear shell to be removed from the support of the other. So eventually, until the last epinucleus is removed, the polar part is still protected, and you can scoop them out, because these are vertical walls that are created. You can scoop them out like an ice cream from a cup. And make sure that the epinucleus is attached. Now here what we are doing is just creating a communication between the anterior and the posterior compartment. Therefore, small amounts of fluid will start trickling. So now at this point, even if you have to do hydrodissection, it is unlikely to cause a further split in the pre-existing posterior capsule dehiscence. But we wanted to make sure that if we can avoid doing any form of hydro procedure, we would be happy to do that. So making sure that we follow the principles, relatively low bottle height, low flow rate, And before bringing out any instrument, make sure that the chamber is formed. And you can see this large defect that is pre-existing. Bimanual irrigation aspiration has a distinct advantage in such situations because the valve of the main incision is not disturbed. And you get ergonomic access all around the chamber. And fortunately, until the end, we have been able to preserve this posterior capsule dehiscence to its original size without enlarging it, and avoid any form of drop nucleus that is occurring. Now, so here we have this situation, the plaque with the pre-existing posterior capsule dehiscence. Once again, the best way is to convert this existing dehiscence into a posterior capsular rhexis, because our original plan is still to go ahead with a toric IOL if we are able to. Keep changing your hands and your ergonomics. So I started from one incision, went to the other. I may end up going from the third incision as well, to make sure that your ergonomics of pull are always in the correct direction, so that you not only cause less stress to the capsular bag, but also less stress or less chances of shallowing the chamber and causing vitreous to prolapse. So I've been able to convert this into a PCCC as well as circumvent the plaque area, so that the visual axis also remains clear. As you can notice, there are already some lens particles here. On injection of triamcinolone, there was no vitreous prolapse into the anterior chamber, but in the area of the tear, since there were some pre-existing lens particles already there, we decided to go ahead with limbal vitrectomy. And you can see the anterior and posterior capsular rhexis, and this patient required a T7 IOL, high astigmatism correction IOL. And because now we have strong anterior and posterior capsular rhexis margin, we are able to go ahead and place the toric IOL in the bag and complete the case as we would normally. And in the end, of course, again inject viscoelastic to make sure that the chamber doesn't shallow. And this is the anterior capsular rhexis and the posterior capsular rhexis, and this is the patient doing very well now, long-term follow-up. Another case of a bilateral polar cataract, once again with FLACS, we were able to, we have been able to reduce our posterior capsule rupture rate. Like in the previous case, there was a pre-existing defect. Here, there wasn't any pre-existing defect, and we hoped that we would be able to preserve the posterior capsule nicely, which fortunately we were able to. So until now, there is no capsular dehiscence that has occurred. Bimanual irrigation aspiration on both sides to remove the cortex, and the posterior capsule is very, very. So the posterior capsule is well intact, and at this point of time, things should have been very easy. But sometimes you tend to get overconfident, and the dictum is never touch the posterior polar plaque of a posterior polar cataract. I went overboard, and I thought, let me just pull out the fibers from the periphery of the plaque. And inadvertently, as it would always happen, you end up catching the capsule. And if you can notice, this typical vertical split has occurred in this patient, where we were able to prevent a PCR with our surgical technique. This patient was planned for a multifocal toric IOL, a young patient, a non-presbyopic, and something which I would have ended up doing straight away has now ended up in a complicated situation. So first thing again is to make sure that you don't allow this to enlarge further. So once again, don't withdraw your instruments, inject dispersive viscoelastic. And now, since this was just a catch of the capsule which led to a split, there is still no vitreous prolapse that has occurred. So still I have a chance of trying to salvage, if possible, this posterior capsular tear and convert it on both sides into a strong margin. Because until you have a strong margin, even though this tear may not be extending up to the equator, while IOL insertion and IOL manipulation, it can split and can lead to a disaster. So it's always very important to convert a posterior capsular tear into a posterior capsular rhexis, and appropriate use of viscoelastics, dispersive first, and then a good cohesive viscoelastic of sodium hyaluronate to make sure that it doesn't enlarge further. And we need to convert it from both sides, not just from one side. So I could manage to do it from one side, and then from the other side port, I was able to convert it from the other side as well. And since now, once again, I have a good anterior and posterior capsular rhexis, I decided we can still go ahead with in the bag IOL implantation of this multifocal toric IOL. I was less concerned about this tear now giving way, since I'd given strong margins to this tear. And having placed the IOL at the appropriate axis, of course, you won't be stupid enough to go behind the IOL to remove viscoelastic. Give mannitol post-operatively to these patients. And this is how the patient did 1 year follow-up, now 2 years follow-up with this strong posterior capsular axis margin and no movement in the multifocal toric IOL. And this is the last case where sometimes you may need nothing to be done. And this was a case, second eye planned for femtosecond cataract with toric, absolutely normal case, nothing, no polar, nothing, grade 2 cataract, everything going on perfectly, IA done and toric IOL to be done. And sometimes what happens is just like Dr. Sinha showed, be careful about how you're injecting the IOL. And here what was not noticed is that the loading was inappropriate. So if you notice here, the plunger is actually overriding the optic, which it should not. It should be at the optic haptic junction here. So the IOL is likely to get stuck here. This was not noticed, of course, at that point. This is all retrospective. And I felt there is significant resistance, but that sometimes I thought maybe the IOL is cold and, sometimes you'll get away. I was being very slow, very cautious, but still I had that jerk. So my heart came in my mouth, but still you do get some of these jerks. And I thought I had a good cohesive viscoelastic in the bag, so nothing would have happened. This was toric IOL to be placed in the bag. But unfortunately, this jerk has led to this large posterior capsule dehiscence, which is extending from here almost up to the equator. Now, this is a very awkward situation where I have a single piece toric in the bag. So if I have to do something for it, I have to, either explant it by bringing it out of the capsular bag. Now this tear is extending up to the equator, so there is no option of converting it and then going ahead with in the bag IOL implantation. The only advantage here was that all of the rest of the procedure is done. So now I don't have to do any other manipulations in the capsular bag. So the thought that came to our mind was, having done 2-3 of such cases for other reasons, is to reverse capture this IOL. Which means normally the conventional optic capture is you keep your haptics in the sulcus and optic in the bag. Here we are doing the exact opposite. The haptics will remain in the bag, but we are prolapsing the optic out of the bag. And it is very, very tricky, particularly with the single piece design. 3-piece is the ideal for capturing, but this was a unique situation. So I'm struggling. I could manage one side, the other side came off, so on and so forth. Fortunately, the rexis was of an adequate size. And finally, I could achieve this. If you see this dumbbell sign, so the haptics are now in the bag and the optic is prolapsed into the anterior chamber and placed, the toric IOLs are placed as per the axis placement of the IOL, making sure that while this reverse capture maneuver was done, any, vitreous if it has prolapsed, but fortunately there was no vitreous prolapse. Fortunately, I could save the day. And if you can notice here, this tear right from here up to the equator is existing with the IOL well aligned, the optic above the anterior capsular axis. So this patient is naturally likely to have little more inflammation. So you may want to start him straight away on NSAIDs and give topical steroids for a longer time. But eventually this patient did quite well post-operatively. So I think I'll end at that. There are another couple of cases, but I think time is an issue. Thank you so much for the presentation. Sir, you're on mute.
You're muted. You're muted. Thank you so much, Dr. Shell. What wonderful videos you showed. Well, beautiful learning experience. Paucity of time, I would like to once again thank Dr. Love, Dr. Arup Bhaumik, Dr. Anurag Mishra, and Dr. Shell for the wonderful presentation. And I would like to thank Dr. Vishnu, Dr. Matthew, Dr. Chandrakant, and Dr. Sunil for their role as panelists. And big thanks to Dr. Srini, who is by now, after 5 hours, he must have become the master of Phaco. He's sitting till from 4 o'clock. And I think Rakhi had a coffee in between because she was feeling sleepy. But big thanks to everybody who has been there throughout the day. and to all the viewers who were there to listen to our last session, complications in Phaco. All yours, Srini. Thank you so much.
Thank you, Dr. Sajid. Wonderful session. Great speakers. Your selection. I selected Shail. Rest of the people you selected, and all were top class. Thank you. I'll hand out to Raki for the vote of thanks and ending.
So thank you, everyone. So it was indeed a very fruitful as well as interesting session. By this, we have come to the end of this session. On behalf of KSOS and KOS, we would like to, KOA, we would like to thank all the chairpersons, speakers, and delegates who have spent their precious time, effort, and dedication for this session. And also, I'll especially mention our thanks from part of Kollam Ophthalmic Association to Dr. Srini, to Dr. Gopal, and to Dr. Arup for giving us this opportunity to conduct this webinar, as well as for guiding us through each and every step and backing us up. So, and lastly, I would like to thank the viewers, because you have spent your precious time out of a fruitful Sunday for this session, and I hope this session will be very fruitful for each one of you there. And keep watching us. We have a power-packed sessions going on in the KSOS YouTube channel. Keep watching us. Thank you.
Thank you to you also, Dr. Raki.
Thank you, sir.
Thank you. Ankit.